Yeah, check. Check. Hello? Hello? Hello?
Association and SARC Urology Association for this kind invitation. Friends, PCNL is one of the commonest endourological procedure that we do. Most often, it's a very, very friendly procedure for the patient and for the surgeons. But sometimes we land into situation which makes us miss few heartbeats. This was one such situation. This was a patient with a very large stone completely filling the upper calyx. In view of the large size and large was the only option to do. Seeing the CT urography and the RGP picture, it was clear outside the PCS and there should be no leakage of fluid during the procedure. When I did nephroscopy, I found a glistening white structure which did not look like normal kidney. On exploration, I realized that definitely I was not in the right place. I explored this further, went laterally to realize that there was a crevice-like space there with some flimsy clots, and suddenly I saw lung in the view. So I was doing fluoroscopy instead of doing a nephroscopy. Immediately, I withdrew my nephroscope and went in with a guide rod, again dilated the tract with impulse dilators and tried to look at inside once more. Despite an attempt at redilatation, the diaphragm refused to budge in and I was at the same place where I had begun with. In desperation, I tried to do something which I would normally not do, as try to dilate the diaphragm with the forceps. Though this is something to be dissuaded, I found at that time there was hardly any option. The only precaution I did was that I did the dilatation very gradually. I was able to follow the wire and follow was fragmented with lithoblast and complete stone clearance was achieved. Antegrade stent was placed. At the end of procedure, CP angle was checked. Obviously, as expected, the lung was collapsed and the chest was filled with fluid. Our initial puncture nerve was on day one, nephrostomy tube was removed. After that, Foley and last chest tube. At the time of chest tube removal, there was no fluid coming out. There was no harm in proceeding with the procedure. Pleural injuries are known in upper pole access, but if you take precautions, the magnitude of injury is usually not very severe. We know that the pleural space moves upwards during expiration. So if you make a puncture lateral to the mid-scapular line, between below the tendon, the possibility of hitting the pleural space is very low. So when you are doing upper colic access, dilate in expiration
Hello, hello. Off करा, stop करा. Hello, hello, hello. भाइ आएको छैन के साउन्ड बाहिरको जुमको आएको छैन के भएको त्यो हेलो हेलो अपले अफ गर
Good morning, friends. I thank Nepal Urology Association and SARC Urology Association for this kind. Friendly procedure for the patient and for the surgeons, but sometimes we land into situation to follow the wire and follow the track. Very soon I could see identify
Good morning, Madhu sir. Good morning, Malikarjun sir. We'll be starting in a few minutes. Let us be getting up ready.
Good morning, Madhu sir. Good morning, Malikarjun sir. We'll be starting in a few minutes. Just be with us, sir.
Yeah, good morning. Good morning. Morning, Malik.
Good morning, sir.
A very good morning and my best wishes for the success of the UROCON.
उहाँले कुन भ्यू देखाउनु छ होला हलको भ्यू देखाइदिनु न
Good morning, friends. I thank Nepal Urology Association and SARC Urology Association for this kind. Most often it's a very friendly procedure for the patient and for the surgeons, but sometimes we land into situation which makes us
पहिला यहाँबाट प्ले
this would need a good morning, friends. I thank Nepal Urology Association and SARC Urology Association for this kind invitation.
हामीले के पनि गर्नु पर्दैन पक्का भयो भने त्यहाँ रेकर्डेड प्ले हुन्छ उनीहरूले नै गर्छ हामीले केही पनि गर्नु पर्दैन
SARC Urology
रेकर्ड गरिसकेपछि अनि घुम्ने हो कि
Association. Seeing the city
यहाँ मात्र हुन्छ त्यहाँ हलको भिडियो देखिरहेको छ ओके
वेलकम बोला राखौँ जुमको स्क्रिनलाई एक ठाउँमा राख्न सकिन्छ भइसक्यो डाउनलोड भइसक्यो यसको डाउनलोडमा आइसक्यो
डाउनलोडमा आइसक्यो म पेनमा हालेको छु
पेनड्राइभमा हालेर त्यहाँदेखि अनि टङ्ग्रेकर सरको दिइसकेँ मैले पिडिएफ हल्बीमा कन्भिनर तिमी एकचोटि हेर्नु होइन Good morning, ladies and gentlemen. May I have your attention, please? We have our guest of honor, Mr. Isala Rawan Marikun with us, sir. Please be seated. I'd like to begin the ceremony now. Good morning, ladies and gentlemen. It gives me great pleasure to welcome you all here on behalf of the organizing committee to the inauguration of the second South Asian Association of Urological Surgeons, in short, SAUS Congress. Thank you all for accepting our invitation, especially in this difficult time of COVID-19 pandemic. I wish you all a good health and would like to take this opportunity to humbly request you all to kindly follow the health safety guidelines all the time. To begin the proceeding, I would like to welcome our dignitaries on the dais. First, let me begin by welcoming our very dynamic urologist, our beloved guru of us all, the president of NAUS, Professor Dr. Chandrasekhar Agarwal, sir, please. Now allow me to welcome our guest of honor, whose presence here today has taken this Congress to whole new heights. His Excellency Secretary General of SAARC, Mr. Isala UROCON, sir, please. Moving on, let me call upon our dear Guru, my mentor, aspiration of many new urologists, who has taken NOWS to the International Committee and made significant contribution to the start of this house. The General Secretary of NOWS as well as SOUS, Dr. Pawanraj Salise, sir, please. Now I'd like to welcome our very dynamic and renowned urologist, who has had a great contribution to this NOWS from its inception. The chairman of our scientific committee, Dr. Mahesh Adhikari, sir, please. And at last, but certainly not the least, I would like to welcome the scientific coordinator of the South Congress, Dr. Rajiv TP, sir, who has joined us in virtual platform. As well as I would like to welcome the president of this house, Dr. Madhu, sir, who has joined us from the virtual platform. Now I would like to request C.S. Agrawal, sir, to present the bouquet to our chief guest, His Excellency Secretary General of SARC, Mr. Isala Ruan Wirakun. We'd also like to welcome Director of Human Resource Development and Tourism Division of SARC Secretariat, Mr. Fazul Rahman Rahmani. Is he here? He'll be here shortly. And may I request our organizing secretary, Pawanraj Salise, sir, to distribute badge and scientific agenda to the guest of honor on dais. Now, I would like to request our President of NOWS, Professor C.S. Agrawal, to come on podium to deliver his speech.
Good morning to all of you. Today's guest of honor, His Excellency Secretary General of SARC, Mr. Isala Ruan Wirakun, President of SARC Association of Urological Surgeons, Dr. Madhusudan Agrawal, Organizing Secretary and Secretary General of SOUS, Dr. Pawanraj Salise, Chairman Scientific Committee, Dr. Mahesh Adhikari, Scientific Committee Coordinator, SOUS, Dr. Rajiv TP, President and Secretaries of Association of Member Countries of the SARC, past President of NOWS, invited national and international guests, faculties, delegates, media personnel, ladies and gentlemen. I feel honored to welcome His Excellency Secretary General of SARC, Mr. Isala Ruan Wirakun. Thank you, sir, for gracing this occasion. Despite your other important commitments and busy schedule, we are overwhelmed by your presence, sir. Your presence has motivated all of us. Thank you once again, sir. I also extend my warm welcome to the SOUS President, Dr. Madhusudan Agrawal. Your virtual presence has encouraged all of us. Thank you, sir, for giving us the opportunity to host the second SOUS Congress. We have tried our best to make this session a memorable meeting. I would also like to welcome the Secretary General of SOUS, Dr. Pawanraj Salise, Chairman Scientific Committee, Dr. Mahesh Adhikari, Scientific Committee Coordinator of the SOUS, Dr. Rajiv TP. The Secretary General and Chairman of the Coordinator of the Scientific Committee have worked day and night to make this Congress a grand success. The Congress Scientific Committee has planned a half-day scientific program of high educational standard with remarkable presentation by distinguished and renowned speakers. The program focuses on the current and controversial issues of urology, aiming to provide reliable information to our young members to prepare them to meet the challenges and opportunities that constantly arise in day-to-day practice. We are missing the physical presence of our friends and well-wishers from the SAARC countries due to the COVID pandemic. But on the other hand, we are happy that they are still contributing by their virtual participation and presentation. The meeting is a great opportunity to renew our old friendship and create new ones. I look forward for active participation of all of the delegates to make the Congress a grand success. Once again, I welcome you all to the South session and wish you a stay and comfortable stay in Kathmandu. Jai Naos, Jai South, Jai Nepal. Thank you.
Thank you, sir. Now, I'd like to request Dr. Pawan Salese to the podium to deliver a speech.
Respected President of NOWS, Dr. C.S. Agrawal, our guest of honor of today's South Congress inaugural ceremony, His Excellency Secretary General of SAARC, Mr. Isala Ruan UROCON, President of South Asian Association of Urological Surgeons, Dr. Madhu S. Agrawal, President of South Asian Urological Association and executive members who have joined in virtual platform, all senior NOWS members, my friends, eminent dignitaries, ladies and gentlemen. It gives me immense pleasure to welcome you all here at the second South Congress in association with 6th Annual Hybrid Conference of Nepal Association of Urological Surgeons, UROCON 2021. As you all know, the Urological Association of South Asian region have come together to form a common platform to take our friendship in an organized fashion for the mutual development of urological field in this region. Countries in this region share a similar socioeconomic background, and with mutual cooperation, we can take this urology to a whole new level to come in par with the rest of the developed world. The organization which we proposed as SOUS is very new. All this started during the leadership meeting during 13th BAUSCON on February 10, 2019 at Sri Mongol, Bangladesh, where we felt a need of our mutual cooperation in this region. We called this as Sri Mongol Declaration 2019. Ad hoc committee was formed and started, and formalization of our association is done. Further, South Asian Urological Association and Society's executive meeting was held during UAA Congress at Kuala Lumpur, Malaysia, and executive committee for 2019 to 2021 was unanimously elected. The team is putting all its effort to find the strong route for their organization. I am very thankful to our President, South, Dr. Madhu Agrawal, and the treasurer and also the scientific coordinator of SOUS, Dr. Rajiv TP. As a part of its activities, the very first SOUS Congress was held in Kochi, India last year, and I'm very thankful to the team of USI for organizing this inaugural Congress. It would have not been possible without the constant help and encouragement from all the stakeholders of this region. So I take this opportunity to thank them all once again for this platform. I think SAARC is maybe going to play a great role in our organization and to planning our our legal status as a recognized body by the SAARC. And I'm sure the good words and the words that we have been given today in our breakfast meeting by His Excellency is very encouraging for all of us. Thank you, sir. Yes, we have a long way to go and lots to achieve. But I'm confident that with this kind of love and support from all of you, We have better days to see in the future. May this organization grow a great deal. Long live South, long live NAUS. Jai Nepal. Thank you.
Thank you, sir. Now, may I call upon the President of SAUS, Professor Dr. Madhusudan Agrawal, who has joined us on virtual platform to deliver his thank you speech. Sir.
Friends, thank you very much for this invitation and giving me this opportunity to be with you on this virtual platform. Of course, it would have been a greater pleasure to be there in person and meet all of you. But I must again thank Dr. Chandrasekhar Agarwal, Dr. Pawan, and Dr. Mahesh for taking this responsibility of organizing the second SARC, the South meeting. The first meeting, of course, we held in Kochi last year, and I see a great future for the South Asian cooperative venture, which we started about 2 years ago. And with the blessings of the Secretary General of SARC, and I extend my thanks once again to Mr. UROCON for his blessings to this nascent organization. And with his support and with his help, we should be able to achieve what we have been looking forward to, legal status as an affiliate body to SARC, so that these countries of South Asia, which have a common heritage, which have grown together, which have common problems, and we have to strive together to find a common solution to these problems. We have worked very hard and very effectively in these last 2 years to come together on a common platform, and we have done some very useful and effective scientific activities in these last 2 years, and we look forward to a great future for the coming times. I'm thankful to the NAUS and to all the executive members, the presidents and secretaries of the member organizations, including Dr. Mallikarjun, Dr. Keshav, and Dr. Sabnis from India, Dr. Mumtaz from Pakistan, Dr. Suren from Sri Lanka, and Dr. Deepu from Bangladesh, all the member countries who have participated wholeheartedly in the South Asian South programs until now, and we'll all continue to work together in future. So thank you very much for being with us, all of you today. And I thank Dr. Mr. UROCON once again for sparing his time and being with us. Thank you very much. I look forward to a great future for this South organization. Thank you.
Thank you, sir. Now, I would like to request our guest of honor to inaugurate the scientific session of South Congress by lighting up hands. Thank you, sir. Moving on. Now I'd like to welcome and request a short inaugural speech from the President of the representative of South Asian Neurological Associations. First of all, do we have Dr. Jamari Noori from Afghanistan, Habibur Rahman, So, Tohin sir, can we have him on screen, please? Dr. Tohi, General Secretary from Bangladesh Association of Urological Surgeons. Sorry for the technical difficulties. Moving on. We have President of USI, Mallikarjun sir. Can we have him on screen, please?
Thank you very much. Thank you. His Excellency Mr. UROCON and President's House, Professor Madhusudan Agarwal and Chandrasekhar Agarwal, my friend, President's House, and all the office bearers of the Nepal Urological Association of Surgeons. Thank you for this opportunity. And as Dr. Madhu was talking about, we all share a common heritage and a common methodologies and common problems in our day-to-day practice. I think we having a meeting for ourselves, discussing our own ways of managing the patients, what we have in these days is going to be of utmost importance in the near future. I think a bright future for this association, and we going on discussing about the problems of our countries and our patients in our countries will be go a long way in managing these patients. All the best to this association and all the best to our future and healthier future. Hopefully this pandemic will subside. Thank you very much for this opportunity and all the best to you all.
Thank you, sir. We have Dr. Tohin from Bangladesh Association of Urological Surgeons. Sir, if you, can we have him on screen, please?
Thank you very much. Honorable President of the SARC Association, Professor Madhu Agarwal, and Secretary General Dr. Pawan, our very dearest, and the President of India and all other countries. I welcome you all of today's SARC Congress, and I must give thanks to Dr. Pawan and our dynamic President of SARC, Professor Madhu, and Treasurer Professor Rajiv TP for organizing this virtual Congress in this unprecedented time. Actually, we all are now in a very crucial time passing due to this pandemic. You know, in our country, now again, the second wave is in very alarming situation. Every day, more than around 100 people are dying now, and almost 7,000 new cases are diagnosed due to COVID. We are in a strict lockdown in Dhaka. You know, this month we organized a hybrid conference. Due to this second wave, we postponed it. So, but in this crucial time, Dr. Pawan and his team and the Nepal Urology Association leadership organized hybrid conference, and I must congratulate them for organizing them in this difficult time. I wish is grand success, and really I see the very great hope of this SARC Association of Urological Surgeons with the help of all neighboring countries, as we have a common problem, common disease, common treatment plan. So we must continue, and we should continue the these activities of this society and of this organization. So it will further enhance our friendship, collaboration, and so many things. Thank you very much, and I wish the grand success of this hybrid conference. Thank you very much.
Thank you, sir. Now moving on, I would like to request President of Pakistan Association of Urological Surgeons, Dr. Mumtaz Ahmad, to deliver his short speech. Can we have him on screen, please?
Thank you very much. Honorable chairs, distinguished guests, friends, ladies and gentlemen, good morning and assalamu alaikum and greetings from Pakistan. It's a matter of great honor and privilege for me to be part of this very prestigious meeting of second SARC Association of Urological Surgeons, which is organized by SARC and NAS. Although the SAS is a young association, but as we all know that this represents about 25% of the world population. And I'm sure that this will progress with time, and Pakistan Association of Urological Surgeons definitely will make every effort to promote SARS in terms of education, training, research, and patient care. Thank you very much.
Thank you, sir. I'd like to call upon once again the President of Afghanistan Association of Urological Surgeons, Dr. Jamari Nuri. Do we have him here? Okay, moving on to Bhutan, Dr. Sonam Darge. From Maldives, Dr. Ahmad Ashraf Ali. And from Sri Lanka, Slaus Surendi Zilva. Can we have him on screen, please? So we are ready.
Good morning, dear colleagues. I bring warm greetings from Sri Lanka to the presidents and the members of both the Nepal Association of Urological Surgeons and the SAUS. The Sri Lanka Association of Urological Surgeons considers the South Asian Association of Urological Surgeons as a very important forum. We collectively care for a very large proportion of Asia's population. The disease patterns in our countries are very similar, and our working environments are also similar, with similar sociocultural and economic constraints. However, this is also our unity and strength. When we exchange ideas, we invariably come up with new and unique ideas which will benefit not only our South Asian people, but also the rest of the world. Let me end by wishing the second South Congress great success, and may the SARC Association of Urological Surgeons grow from strength to strength. Thank you.
Thank you all. Now, may I call upon our guest of honor, His Excellency Secretary General of SARC, Mr. Isala Ruan Wirakun, for his speech. Sir, please.
Professor C.S. Agrawal, President of the Nepal Association of Urological Surgeons, Dr. Madhu Agrawal, Dr. Pawan Raj Chalise, Dr. Mahesh Adhikari, members of the organizing committee, ladies and gentlemen, good morning. It is a great honor and a privilege for me to address the inaugural session of the hybrid conference of the Nepal Association of Urological Surgeons. I congratulate the Nepal Association of Urological Surgeons and the South Asian Association of Urological Surgeons for convening this Congress despite the challenges posed by the pandemic. Your resilience and determination are indeed praiseworthy. I extend warm greetings to all the delegates attending this Congress of Urological Surgeons. Your participation in this Congress bears testimony to your resolve to work together for promoting urological health services across the region. Distinguished delegates, as you are aware, the South Asian Association for Regional Cooperation was founded in December 1985 with the primary objective of promoting the welfare of the people of South Asia and improving their quality of life. The convening of this conference is a befitting initiative to add impetus to this charter objective of SARC. Moreover, since its inception, SARC has continued to attach priority to the promotion of people-to-people contacts in the region. In view of this, we welcome this initiative, which brings together medical professionals from the region for cross-fertilization of ideas, sharing of best practices, and knowledge and skills. Ladies and gentlemen, there have been remarkable developments in the field of urology, including uro-oncology in the SARC region in the last decade. However, there may have been no initiatives changes of best practices and evolving ones in the field. This is also an opportunity to foster new contacts and renew old ones, thereby promoting people-to-people contacts, which is one of the key priorities of SARC. Distinguished delegates, I understand that the Nepal Association of Urological Surgeons has played an important role towards improving quality and accessibility of urological health services in Nepal. With the eventual realization of the concept of forming the SARC Association of Urological Surgeons, I am confident that we will be able to make further advances in promoting urological health services across the region. I'm happy to learn from the Secretary General of the Nepal Association of Urological Surgeons, Dr. Pavan Raj Chalise, that the proposed SARC Association of Urological Surgeons is already working towards its legal registration. In this connection, I'm pleased to mention that as a regional organization, SARC welcomes the coming together of professionals such as urological surgeons to a common platform for facilitating contacts and exchanges for uplifting urological health services in the region. In conclusion, I thank the organizing committee for inviting me to address this important Congress and all the participants present here and the delegates participating in virtual mode for making this conference a reality. I wish the distinguished participants fruitful exchange of views during this Congress. I thank you.
Thank you, sir. Now, can we have a brief introduction of scientific session of South Congress by Rajiv TP, sir, scientific coordinator of South Congress. Do we have him with us? Okay, moving on. Finally, I would like to call the chairman of scientific committee, Dr. Moez Bahadur Adhikari, for his vote of thanks. Sir, please.
Good morning. His Excellency Sala UROCON, Secretary General of the SARC, President of Nepal Urology Society, Dr. C.S. Agrawal, President of the South, Dr. Madhu Agrawal, and the Scientific Coordinator of the South, Dr. Rajiv TP. all the members of the SARC Urology and all the office bearers of the SARC Urology. So we like to welcome you and thank you. We like to thank you for attending this coming scientific session of the SARC Urology Society. We like to thank all the international and national delegates. Mostly they are on the virtual, they are present virtually in the online media. And I like to also thank our national delegates, our seniors for taking part in this SARC Urology meeting. I would like to finally thank our now scientific committee members who have really put forward, they have done a very hard work to put forward this scientific content of the meeting. So I'd like to thank everyone for, being physically present in this session, and also all the members of the SARC Urology who are on the virtual media. Thank you very much. Jai Naus, Jai South, and Jai Nepal. Thank you very much.
Thank you very much, sir. I'd just like to announce that we'll have the start of South session at 9 o'clock in this hall itself. Before that, I'd like to call upon the executive members of DIAS for a quick photo session with our guest of honor, please. Can I also call upon past presidents and past executive members of SAUS on the dais for the photo session, please? I call upon Professor Dr. Bolaraj Joshi, sir, to please come on dais for the quick photo session. And now, may I call upon organizing committee members on the dais, please? With that, I would like to thank everyone, especially our guest of honor, His Excellency, Mr. Isala Ruan Wirakun, for taking this trouble and attending this inauguration of this Congress. Thank you, everyone. Now I'd like to hand over this mic for the start of our South session from 9 a.m. Thank you.
Madhu sir.
No position.
Good morning to all of you. Now we are going to start the SARC session. The first session is on endourology. And along with me, Dr. Madhu is also a convener. He is the president of the SARC Association of Urological Surgeons. And once again, I welcome you all, those who are physically and virtually present to attend this session. I invite Dr. Keshava Murthy. He's the General Secretary of the USI, and Dr. Tohid MS Hussain. He is the General Secretary of the Bangladesh Urological Association to chair this SARC Session 1 on endourology. Dr. Keshav Murthy, I request you to lead the session. Thank you.
Good morning, everybody. Thank you, And thanks on behalf of my co-chair, Dr. Tawhid Hussain. We start this session on endourology, the PCNL. The first talk would be by Dr. Pankaj Maheshwari about dreadful complications. Pankaj Maheshwari is actually presenting an unusual case of an intraoperative problem during PCNL and how we came out of it. And he would also give you tips of how to prevent these complications. First talk would be Dr. Pankaj Maheshwari. Hello, I think it's a recorded video.
Good morning, friends. I thank Nepal Urology Association and SARC Urology Association for this kind invitation. Friends, PCNL is one of the commonest endourological procedures that we do. Most often, it's a very, very friendly procedure for the patient and for the surgeons. But sometimes we land into a situation which makes us miss few heartbeats. This was one such situation. This was a patient with a very large stone completely filling the upper calyx. In view of the large size and large high Mansfield unit, both ESW and RIRS were not the options for treatment, and PCNL was the only option to do. Seeing the CT urography and the RGP picture, it was clear that this would need a supracostal access. A supra 11 puncture was done. In contrast to what I had expected, the guide wire went down very, very easily, and the dilatation went very smooth and as per plan. The only thing different I did was I made a 24 French tract and kept the implant sheath reverse. The aim of putting the implant sheath reverse was so that the bevel should not remain outside the PCS and there should be no leakage of fluid during the procedure. When I did nephroscopy, I found a glistening white structure which did not look like normal kidney. On exploration, I realized that definitely I was not in the right place. I explored this further, went laterally to realize that there was a crevice-like space there with some flimsy clots, and suddenly I saw lung in the view. So I was doing pleuroscopy instead of doing a nephroscopy. Immediately, I withdrew my nephroscope and went in with a guide rod, again dilated the tract with impulse dilators and tried to look at inside once more. Despite an attempt at redilatation, the diaphragm refused to budge in and I was at the same place where I had begun with. In desperation, I tried to do something which I would normally not do, as try to dilate the diaphragm with the forceps. Though this is something to be dissuaded, I found at that time there was hardly any option. The only precaution I did was that I did the dilatation under fluoroscopy control. Even this did not work. And as a very gradually, I was able to follow the wire and follow the tract. Very soon, I could see identifiable structures, and finally, I saw the stone. Placement of ureteroscope helped in a way that I knew the direction of the tract. And once this was done, holding the guide rod in that direction and dilatation again saved the day for me. Now the diaphragm burst and I could enter the pelvic license system. Once I was there, the procedure beyond that was very smooth. The stone was fragmented with lithoblast and complete stone clearance was achieved. Antegrade stent was placed. At the end of procedure, CP angle was checked. Obviously, as expected, the lung was collapsed and the chest was filled with fluid. Our initial puncture needle was placed in the pleural space. It drained clear fluid, and hence a decision of placing a pigtail catheter in the pleural space was taken. This puncture was made in the fourth intercostal space. Over the guide wire, tract was dilated with 10 French routine PCNL dilators, and a 10 French pigtail catheter was placed in the pleural space. This pigtail catheter was later attached to underwater seal. Immediately, around 400 ml fluid drained, and after that, patient had a smooth postoperative course. The lung expanded on table. On day 1, nephrostomy tube was removed. After that, Foley and last chest tube. At the time of chest tube removal, there was no fluid coming out through the chest tube, which showed that there was no reflux through the stent. It was definitely a difficult case as there was no space in the upper calyx. One error probably I did was that I used the reverse end of the implant sheath. We note that the bevel end is more sharper and the reverse end is more blunt, and sometimes reverse end may not move as smoothly as beveled end would. Should I have staged the procedure? Definitely no, because there was no bleeding, there was no infection. And this is which had to be done. So it was no harm in proceeding with the procedure. Pleural injuries are known in upper pole axis, but if you take precautions, the magnitude of injury is usually not very severe. We know that the pleural space moves upwards during expiration. So if you make a puncture lateral to the mid-scapular line, below the 10th rib, the possibility of hitting the pleural space is very low. So when you are doing upper colic access, dilate in expiration lateral to the mid-scapular line, make a minimum necessary tract, always use a plus sheet so that the low pressures are maintained. An experienced anesthesiologist would help. And at the end of the procedure, look at the CP angle carefully and confirm that the CP angle is absolutely normal. Once you see this, you are sure that you have caused no harm. At the end of procedure, if there is reduced air entry or if the CP angle is obscured, evaluate this patient further. You could do a pleural tap. If there is a large amount of clear fluid or blood in the pleural space, then a tube drainage is done. If late presentation happens, though this is very, very unusual, this would mean that there is some form of obstruction to the pelvic collection system. If the stent is there, this could be related to reflux and hence anticholinergics could be added. If the stent is not there, then the stent could be placed. There are luckily no long-term implications or lung injuries after supracostal access. So though we landed into problem, we could save this patient and have a smooth post-op course. Thanks for patient. Good morning, friends. I thank Nepal Urology Association and SARC Urology Association for this kind invitation. Friends, PCNL is one of the commonest endourological procedures that we do. Most often, it's a very, very friendly procedure for the patient and for the surgeons. But sometimes we land into situations that makes us miss.
Yeah, thank you, Dr. Pankaj Maheshwari. Can I ask Tauhid to call the next speaker?
Thank you, Professor Keshav Murthy. Very good morning from Dhaka. Dear Keshav,
yeah.
How are you?
I'm fine, sir.
Oh, thank you, sir. Thank you. So, as you know, the PCNL from is starting his journey. The PCNL is very much popular procedure in these SAARC countries, India, Bangladesh, Nepal, in every country, Sri Lanka, Pakistan, everywhere. But this procedure is evolving day by day. Now it is in supine PCNL. Sometimes it is both supine and prone combination. And there is so many newer technologies to reduce his morbidity. That is mini PCNL, ultra mini PCNL, super mini PCNL, and micropulse, so many things. So now I call upon Dr. Jamai Nori. He will talk on newer technologies for PCNL. So let's see from the Jamai Nori presentation, the newer technologies for PCNL. Dr. Jamai Nori, please.
Sir, sorry for the interruption. We don't have Jamai Nori sir with us. We'll move on to next presentation.
So now I call upon the Dr.
Do we have Mumtaz Ahmed, sir, please?
Dr. Mumtaz Ahmed, he was here, I think.
Yes, please.
Hello, sir. Assalamu alaikum.
Wa alaikum salam. How are you?
Yeah. Ramadan Mubarak, sir. Ramadan
Thank
Mubarak.
you.
So again, the things is, you know, the evolving procedure of stone surgery, the RIRS. But Professor Mumtaz Ahmed is confused, or I think he's confident. Is the modern armamentarium in RIRS is a threat to mini PCNL? Sir, please, can I hear from you?
Thank you very much. Thank you very much. First of all, I would like to extend greetings from Islamabad. Now we are talking about the urolithiasis, and because it has got a very high prevalence, up to 15 to 20% in our region, and this constitutes about 60% of the urology in our region, and the third most common cause of chronic renal failure. As we all know that the ideal treatment modality for any disease should be effective, non-invasive, cost-effective, it should be acceptable to the patients, and it should be feasible to the patients, and it also depends upon the surgeon preference and experience of the surgeon, and finally on the facilities which are available. According to the EAU and the AUA guidelines, we all know that the treatment of urinary chassis more than 2 centimeters in size is the standard PCNL. Because the standard PCNL mean a tract size of 24 to 30. This has got the highest stone-free rate and the most effective and minimally invasive treatment method for stone. It has comparable stone-free rate to open surgery, and it is, of course, less invasive. Now, recently, 2 above techniques, that is mini PCNL and the RIRS, emerged as an alternative to the standard PCNL, particularly for stone less than 2 centimeters in size. But these techniques are stretching their indications. Mini PCNL with a track of less than 22 FR, and so the idea behind this is that this has got less complication as compared to the standard PCNL, particularly the blood loss. And similarly, the RIRS with the plea that it is a totally non-invasive procedure. In a recent large meta-analysis comparing RIRS and the mini PCNL, what has been shown that higher stone-free rate in mini PCNL as compared to the RIRS. Definitely in RIRS, short hospital stay as compared to the mini PCNL, but the operative time and the complication rate was same in both the procedure. So mini PCNL mean that it has got all the the benefits of the standard PCNL, but only the difference is that it has got short tract size. So the beauty of this mini PCNL is that it is not affecting the effectiveness of the procedure with the increase in the size of the stone. So the effectiveness remains the same. Similarly, the non-invasiveness is the same with the increase in the size of the stone. But of course, the field of the vein will be smaller as compared to the standard PCNL. In contrast to the mini PCNL, in RIRS, if the size of the stone will increase, the effectiveness of the procedure will decrease. And similarly, this non-invasiveness with the increase in the size of the stone will be decreased. And there is a particular problem in lower pole stone, because the access and the breaking of stone in the lower pole in RIS can be a real challenge, because there are more chances of the breakage of the scopes, and the fragments often remains in the calyx and not pass spontaneously like what happens in ESWL. And these are the different factors: lower calyx length, width, height, and the angle of the pelvic cleal angle. And this is the impact of anatomy on the flexible URS or the RIRS. So the larger stone burden and the lower calyceal stone locations are important factors in deciding, and it is the cause of low stone free rate in RIRS. So another thing about the RIRS, it is a stage procedure, because as we all know, in 70 to 80%, we have 2 procedures. One, first RIRS, and then the removal of the stone, stent. But in 20 to 30% of the cases, we have 3 procedures. That means one is the pre-stenting, then the procedure, and then the stent removal. So the feasibility for the patients in our region, and then the follow-up and the compliance is, a big problem for the patients in our region, because they come from far-flung areas to the big cities and to the big centers. And we all know there are complications related to the RIRS, like urethral trauma caused by urethral excess sheath, which is there in 46.5% of the cases. And there is also avulsion and the stricture formation in 1 to 2% of the cases. And still long-term results are, we don't know the long-term results of this URSN and by the urethral excess sheath. And the finally very important issue is the cost in our region. And the cost is related to the scope, whether it's optical, digital, or reusable, the cost of laser, urethral excess sheath, and of course the nitinol baskets. So in summary, if we see, so these are the differences between the RIRS and the mini PCNL. The efficacy of the stone-free rate is definitely higher in mini PCNL. Of course, it is a little bit more invasive, but it is more acceptable to the patients, and repeat procedures is not there in mini PCNL, and similarly auxiliary procedures are not there. The complications, of course, a little bit higher in mini PCNL, and similarly the morbidity. But the feasibility, if you see the feasibility, it is more feasible for patients because the stone clearance is on first post-operative days, in contrast to the stone clearance in RIRS from 1 month to 3 months. And there is a hospital stay in a little bit shorter in RIRS. But the major issue of cost, it is much, much higher in RIRS as compared to the mini PCNL. And in conclusion, because there is a very high cost of RIRS, so if we consider the economy of our patients, so similarly, this RIRS is a staged procedure in a substantial number of patients, presenting in more than 20% of the cases. So this comes, it is not a feasible procedure for our patients. So the stone clearance is not immediate. So the patient acceptance is not there as compared to the mini PCNL. And size being the limiting factors, because the majority of our stone in our region are larger than the 2 centimeter size. So, and similarly, the risk of ureteric injury, avulsion, and the stricture is there. So in my opinion, this RIRS is not a threat to mini PCNL. Thank you very much.
Thank you. Thank you, Professor Mumtaz sir, for your very nice presentation. And finally, we see you tell the RIRS is not the threat for the mini PCNL. So now over to Professor Keshav.
Yeah, we move on to the next paper by Dr. Anil Shrestha, who will be talking on techniques of stone disintegration in RIRS. Which one would you use? There are so many energy sources which are now used. So I think Anil Shrestha will give us an outlook of which are the best ones to use for stone disintegration in RIRS. Over to you on Dr. Anil Shrestha.
Thank you. Thank you, respected chairpersons and distinguished dignitaries.
Is transmission on or it is stopped? Audio, I can't hear anything.
Hello, somebody there? Can we know whether the transmission is on?
Yeah, I think we are stuck. There is no audio, there is no video.
Thank you, respected chairpersons and distinguished dignitaries of SARC session. So in this beautiful morning, I'll be speaking on techniques of laser lithotripsy in RIRS. Since laser has become very essential part of urology practice today, it is very important to know various laser lithotripsy techniques for endourologists. The unique feature of RIRS as surgery is that for better stone clearance, we need to either dust the stone into smaller particles which can be spontaneously passed in urine, or to break the stone, fragment the stone in smaller pieces which can be actively retrieved using baskets. Though in later period, some suction devices have been introduced and being used in some part of the world, but it needs clinical validation for better acceptance among endourologists. So what is good dusting? Traxler and group in early 2020 did an in vitro experiment and defined dust as particle of less than 250 micron size, which easily floats with the irrigation pressure of 40 centimeter of water, and which is feasible for aspiration through 3.6 French working channel of flexible scopes. So there are various laser lithotripsy modes, and today these modes are quite familiar to endourologists, and the settings used for these modes are quite well known. But what is important to understand is Holmium-Yaag laser physics. Holmium-Yaag laser pulses are highly absorbed in water. So if we keep the laser fiber too far from the stone, then the laser pulses are absorbed in the stone and the purpose is not solved. That means the lithotripsy doesn't occur. It doesn't happen. So what happens is we are heating up the water inside the kidney, and the temperature inside the kidney in such situations can rise tremendously. Whereas if we touch the stone with laser fiber, what happens is the fiber bond back becomes very high and the stone also gets fragmented instead of getting dusted. Check this video for a laser fiber distance. If we stay close and if we don't touch the stone, then we produce fine dust, which is easily passed in urine. But if we pull the laser fiber a little further, and if the distance is more, then the lithotripsy doesn't occur and the water is heated. So for beginners, it is very important to maintain that golden distance between stone and laser fiber to achieve efficient lithotripsy. So to do efficient dusting, maintain that golden distance of 1-2 millimeter from laser fiber to stone. Choosing appropriate dusting setting only may not be sufficient for doing good dusting. We also need to acquire good clinical skill, like moving constantly over the surface of the stone, not making holes, and not creating larger fragments at the beginning of the lithotripsy. We should also remember that with the same setting, laser setting, a good endourologist can dust the stone and fragment the stone with same setting. So having a good clinical skill is very important. So another lithotripsy technique is fragmentation, which means to break. To break the stone, we need high power, low frequency to have better control over fragmentation, and short pulse duration. So the combination of high power with low frequency and short pulse gives high peak pulse power, which is very good for fragmentation of the stone. So with high power and low frequency, we can precisely fragment the stone without producing much dust. And fragmentation is generally done with the intention of fragment retrieval with baskets for stone analysis or for better stone clearance, or to relocate the stone from lower pole to or calcial diverticulum to other favorable calyxes for further treatment. Popcorning or pop dusting is generally done when there are lots of fragments which are not appropriate for basket retrieval and which cannot be spontaneously passed. So with this setting, fragments are made smaller to microfragments or dust, and it was introduced by Chawla et al. In 2008, and they have found that with 2 minutes of popcorning of high power and high frequency setting, around 60% of the fragment size has been reduced. And now it is advised that at least 4 to 5 minutes of popcorning should be done depending upon the nadir fragment size. So to conclude, combination of various lithotripsy techniques gives highest stone-free rate. So one should learn different lithotripsy modes and techniques to do efficient laser lithotripsy and to get highest stone-free rate in RRS. Thank you.
Thank you,
Thank
Dr.
you.
Thank you, Dr. Anil, for a wonderful presentation on that laser lithotripsy. I would ask Tohid to invite the next debate. It's a debate on management of staghorn caliculi.
Is Dr. Nouri is not available here till?
No, I think he's not available.
Okay. So next there is a very interesting talk on debate on management of the staghorn calculi. Dr. Kalana will talk on standard PCNL, and Dr. Karthikeyan Nagayan will talk on the mini PCNL. And after their talk, there is a rebuttal for the 2 minutes each, and finally it will end. So now I call upon the Dr. Kalana. He will talk on standard PCNL, please. Dr. Kalana, are you here? Oh, thank you. Thank you very much.
Greetings
Please start talking.
Nepal Association of Urological Surgeons for organizing this fantastic event. Dr. Karthik and myself will be having a debate to decide what modality of treatment is better in treating staghorn caliculi, standard or mini PCNL. Staghorn caliculi are complex branching renal stones that occupy renal pelvis and at least 2 calyces. Complete staghorns occupy more than 80% of entire pelvic calyceal system. PCNL although recent refinements to the technique and advancements in instrumentation and equipment, PCNL for staghorn caliculi still is a challenge for urology. How do we get the best out of standard PCNL for staghorns? Preoperative planning is the key to success. Proper patient selection and optimization, and also assessing renal anatomy and stone characteristics with non-contrast CT-KUB is of paramount importance. Good pre-op planning leads to a good puncture. Good puncture means a good PCNL. Careful dilatation of the access tract minimize the intrarenal injury. Wider infundibular necks in stag-horn calculi easily allows standard PCNL access genes. Why complex stag-horns are best managed by standard PCNL. Standard PCNL utilizes larger tract sizes. Good vision and irrigation is the result. Larger instruments can move in and out. Larger stone fragments can be extracted. Hard to reach fragments can also be retrieved with special stone retrieving devices. Shorter operation time due to the above reasons does not compromise surgeon comfort. Any energy device can be utilized without compromisation. Multiple tracks does not always necessary with the use of flexible nephroscope and laser. When conducted properly, standard PCNL can be tubeless. What does the recent literature has to say with comparison of mini PCNL and standard PCNL in the management of stag-horn calculi? Have they really compared the stone burden and complexity? Do they compare the experience of the performing surgeon? So I would propose to keep those in mind when adopting the technique into your practice. Best for stag-horn management is standard PCNL with 24 French amplasty. When performed meticulously, standard PCNL provides efficient stone fragmentation and prompt clearance than mini PCNL. It also has minimal complications and maximum stone-free rates. Bigger is faster and better. Thank you. Rebuttals.
Okay. Thank you, Dr. Kalana. And then I will invite Dr. Karthike Royan to talk on mini PCNL. Dr. Karthik, please.
Greetings from India. I thank Nepal Association of Urological Surgeons for having me here. I am Dr. Karthikeyan Naganathan from Trichy, and I am going to talk for mini PCNL in the management of stag-horn calculus. Thanks, Dr. Karana, for making my job easier. PCNL is the primary modality in the management of stag-horn calculus, either alone or in combination with other modalities. The goals of treatment are to achieve complete stone clearance with less nephron damage and minimal complications. We all agree that standard PCNL can achieve a good stone-free rate in stag-horn calculus, but at the cost of more complications. When the track is dilated to 26 to 30 French, more artery and vein are damaged, leading to intraoperative and postoperative bleed, which may require angioembolization in some cases. Therefore, to reduce the complications of standard PCNL, mini PCNL has evolved. With the advent of miniaturization of scope, there is a big difference in the way endourology is being practiced in the current era. Though there are various terminologies in the classification of mini PCNL, any track less than 22 French is considered as mini PCNL. With miniaturization of scopes and better optics and the introduction of better lasers and with suction, nowadays there is no need for standard PCNL even for stag-horn stones. Small is big because of comparable stone-free rate and less invasive nature and less complication rate. Small is not only big but also better because of the vacuum cleaner effect in mini PUC the stone clearance rate is much faster, reducing the intraoperative time. This stone clearance occurs by means of simple passage of fluid back and forth by means of vacuum cleaner effect. The stone fragments can be passively cleared through the tract without the need for any graspers. This advantage is not there in standard PCNL. In the literature, there are a lot of studies which support mini PCNL. Dr. Chen has compared standard PCNL and mini PCNL and has concluded that both have comparable stone-free rate, whereas mini PCNL have shorter hospital stay and lesser complication rate. In the meta-analysis by Zhu, he also concluded that mini PCNL was a safe and effective procedure with comparable stone-free rate and with less chance of bleeding, fewer transfusion rate, and less pain and shorter hospitalization. Swan Lamy has even found that the mini PCNL carries nearly 1% risk of transfusion, whereas the standard PCNL carries nearly 10 to 15% of transfusion. In this study by Zhang et al., whereas multiple tracks PCNL was done by either mini PCNL or standard PCNL are compared, and they have found standard PCNL as a stone-free rate at the end of first session in only 60% of cases, whereas mini PCNL could achieve stone-free rate in nearly 80% of time. Biggest troublesome because of the tract size and the damage to the adjacent artery and vein to the infundibulum and the pelvic-axial system. It is very rare to see such a bloodless field in a standard PCNL, whereas in mini PCNL, it is almost always bloodless. To summarize, I conclude that mini PCNL has a comparable stone-free rate to standard PCNL with minimal risk of bleeding and less complication rate. I rest my talk here, and I strongly support standard small PCNL, mini PCNL for the management of staghorn calculus. Thank you.
Thank you, Dr. Karthyan. Now I call upon the Dr. Kalana for a rebuttal, please. Dr. Kalana, please unmute yourself. Please unmute.
Standard PCNL. If carried meticulously, applications less bleeding, rebel hospitals as lengthy operation times with lesser stone-free rate, and with long operation duration due to the surgeon fatigue, there's always risk for mishaps. Managing complex tagbones is an art. So, ladies and gentlemen, my take-home message will be success of PCNL for staghorn is directly proportional to the expertise of the team and the availability of the resources. Efficacy and success of PCNL for staghorn does not depend on tract size alone. So when you deal with your next complex staghorn, I think you will select standard PCNL. Thank you.
Thank you. Dr. Karthikeyan, please.
For having me here, but you need for such a nice effort. Well, I am back for the rebuttal. Thanks, Dr. Kalana, for such a nice effort. To make it big, you need to think small. Yes, small PCNL has the advantage of having a less complication rate, at the same time having a comparable stone-free rate. Not only the stone-free rate is better, even the requirement of tracks is less with mini PCNL. In this study, nearly 70% of patients who underwent standard PCNL required multiple tracks, whereas only 30% of patients required multiple tracks when done by mini PCNL. Nearly one-third of patients required more than one sessions who underwent standard PCNL, whereas it is nearly 10% when mini PCNL was done. Remember, this is a multicentric study and it is a recently published data which supports mini PCNL in the management of Stahan calculus. In the standard PCNL, one of the major reasons for postoperative pain and discomfort is having a nephrostomy tube. With the mini PCNL, nearly two-thirds of patients can be done tubeless, that is without any nephrostomy tube, because of the smaller size of tract. Not to mention about the less risk of bleeding with mini PCNL. So I now agree, even Dr. Kalana would have understood that size does matters even in PCNL, because the conventional PCNL carries a higher risk of bleeding because of the size, whereas mini PCNL carries the lesser risk of bleeding and comparable stone-free rate. So I conclude that mini PCNL should be the standard of care for Stagan calculus. Thank you one and all for your patient listening. Thank you now for the wonderful.
So thank you, both the speaker, Dr. Kalana and Kartigan, for your excellent talk. Now, a participant will decide what is the better, and the things is depend on the individual judgment, availability of your armamentarium. So thank you. Over to Professor Keshavmurthy.
Yeah, that was an interesting debate. Now we move on to the expert comments by Dr. Dilip Mishra, who is the convener of the youth organization of the USI. Dr. Dilip Mishra, over to you for your expert comments. Dr. Dilip, can you hear us?
Thank you, sir. Thank you, Keshavmurthy sir and Dr. Tohid sir, for inviting me for this. I think the video is already recorded. We can ask the team to play the video for the expert comments. Hello.
So we have a small technical glitch. We are transferring the file. Just bear us with 1 minute, sir.
Okay, if there is some issue, I can speak live, not a problem.
Okay, sir, can you do it live, sir? Then we can go live.
Not a problem. Okay, thank you, Keshav sir and Dr. Tohid sir for inviting me for this talk. I am Dr. Dilip Mishra from Agra, India, and I thank South Asian Association of Urological Surgeons, Nepal Association of Urological Surgeons, and UROCON 21 for inviting me for this debate on stagnant stones. Now, PCNL is one of my favorite topics, and I would congratulate both speakers, Dr. Kalana from Sri Lanka, Dr. Karthikeyan from India, for their point of views. Now, frankly speaking, there is no debate in this. Standard PCNL is standard protocol in these large volume complex stone cases. Now, mini PERC, which is less than 22 French size, contributes in many ways to help reduce the morbidity associated with PCNL for large staghorn stones. Now, staghorns have complex problems. They're not just simple stones, they are large volume stones. They may have superadded infection. There might be a component of renal failure involved in these cases. These patients are also more prone to bleeding during the procedure. So we need to address all these problems. It's not just about the size of the tract. It's about all these problems which need to be addressed for these staghorn cases. Now, patient needs to be optimized. We should have a sterile urine culture, and we should have optimized renal function before the surgery. Now, proper planning of punctures is very essential. We need to place all the punctures, like if there are is a big stone and where there are multiple branches, then we need to place all the guide wires beforehand and use the tracks as and when required for this surgery. First, we should dilate the tract, which allows the removal of most of the stone bulk. Then we can use the mini tracks initially for access. And once we have confirmed entry, then we can change the guide. And any residual stones which is lying in some parallel calyx can again be approached by mini PCL, which helps to reduce the damage to the parenchyma as well as reduces the size of the tract, secondary tracts. Now, we also have more technology coming in for these kind of stones. We have rheology and shock pulse, which are very useful. Yes, sir. Hello.
Continue, Dilip.
Should I continue, sir?
Yeah, continue, Dilip.
Yes. Okay, sir. Okay, I was talking about trilogy and shock pulse, which are very useful in these quick clearance of these stones. They utilize suction, ballistics, and ultrasound guided lithotripsy. All these three are combined, and this is very effective in stone clearance in such cases. And you don't have to bother much. All the stones which is crushed and fragmented, it can be sucked out with this trilogy and shock pulse. And suction is also coming up in a big way for better results in PCNL in these kind of cases. So to summarize, staghorn stones are complex cases and need all the armamentarium available for good results. And it includes both standard and mini PCNL. You cannot just do with one. Thanks a lot. That's why I conclude, sir. Thank you, sir.
Thank you, Dilip, for your expert comments on that. We agree with most of the points which you have raised. And it was a good debate by Kalana and Karthikeyan about management of complex renal staghorn stones. We have the question and answer session. I am not sure whether all the participants are there to take the questions. Is Dr. Mumtaz there? Dr. Anil Shrestha, Dr. Pankaj Maheshwari?
ফোন করো না 10 মিনিট পর এই সেশনটা শেষ হোক
Hello.
Thank you, Dr. Karthik Keshava Murthy and Dr. Tohit for your excellent chairing the session, and thank you all the participants. Now we will move on to the session 2, that is on uro-oncology, and I request Dr. Ravindra B. Samnis, he is chairman and head of the Department of Urology at Nadia, Ujibhai Patel Hospital, Nadia, and India, and Dr. Kalana, he is from Sri Lanka. So, Dr. Samnis, are you there?
Yes, thank you very much.
Thank you, sir.
Thank you, Dr. Pawan. And we carry forward from here the next session. And with my co-chairman, Dr. Kalana from Sri Lanka. The first, may I invite Dr. Irshad Khan for his talk on the extended lymph node dissection for carcinoma of bladder. Does it really change the outcome? As we know that the lymph node dissection is always a debated portion when it comes to radical cystectomy, whether it should be standard, whether it should be extended, whether it is going to affect the outcome. And he is going to give the overview as to what exactly is the realistic outcome of the lymph node dissection. So over to you, Dr. Irshad Khan.
Good morning. I'll be discussing about extended lymph node dissection for carcinoma of bladder. Does it really change the outcome? We all know that 90% of bladder cancers are urothelial carcinomas. Of these, 1/3 to 1/4 of patients will either present with or subsequently develop muscle-invasive disease requiring radical cystectomies. The rationale for an external lymph node dissection in high-grade invasive bladder cancer is based on natural history of the disease process, which is accomplished by a system of lymphatic channels and lymph nodes separated into 6 distinct groups. The lymphatic drainage starts from the distal lymphatic plexus within the bladder wall, goes to the intercalateral lymph nodes, pelvic collecting trunks, regional pelvic lymph nodes, that is obturator, internal iliac, external iliac, and then on to the common iliac lymph nodes and to the aortic cava lymph nodes and so on. The radical systemic series have confirmed that the two most common sites of lymph node involvement are the obturator and the external iliac lymph nodes. Smith and Whitmore in their study report that these sites of nodal metastasis were involved in 74 and 65% of cases respectively. This study also demonstrated lymph node metastasis in 19% of cases to the common iliac lymph node packet. In fact, this was one of the first anatomical lymph node mapping studies in patients undergoing radical cystectomy that suggested the importance of an extended lymph node dissection and remove all potential lymph node metastases, including those along the common vessels. The incidence of lymph node metastasis in patients undergoing radical cystectomy is approximately 26%. The pattern in the largest report systematic series of 1,054 patients from the University of Southern California, a total of 246, that is 24% of the patients were found to have lymph node metastasis, and the percentage of metastasis positive would depend on the primary stage of tumor, with maximum 45% with P4 primary tumors. Among patients with nodal metastasis located within the limits of a standard dissection, that is below the bifurcation of the common iliac, suppose they were positive, a significant proportion of patients also had nodal involvement at the level of common iliac vessels and above the aortic bifurcation, that is 57 and 31% respectively. The authors noted, had the dissection been limited to the obturator spaces, 74% of all positive lymph nodes would have been left behind, and nearly 7% of the patients in this cohort would have been misclassified as node negative patients. Before we go further, let's see the nomenclature of different lipid therapies. Standard, the boundaries are defined as medial to the genitofemoral nerve, posterior boundary defined as internal iliac artery, distal lymph node of Cloquet, medial obturator nerve, and the proximal extent of dissection is up to the bifurcation of the common iliac. Now, the extended lymph node dissection is described in two ways by the different authors. One is dissection up to the proximal extent of dissection up to the common iliac vessels where the ureter crosses the iliacs, or where the bifurcation of the aorta occurs. Super extended when the proximal extent of dissection goes up to the inferior mesenteric artery. Now, does it really change the outcome? Logically, it should, because lymph nodes are positive above the common iliacs in cases of higher primary stage tumors. It should increase. Does it really change the outcome? Paulson et al. Were the first to come out with a finding that external lymph node dissection was reported to improve survival by 21% compared to that obtained by standard lymph node dissection in their series of patients undergoing lymph node standard versus external lymph node dissection. In another series by Leishner et al., RC with external lymph node dissection with the removal of more than 16 lymph nodes resulted in a 22% 5-year survival advantage. They both found no increased morbidity or mortality in these studies in patients undergoing external lymph node dissection compared to a standard lymph node dissection. Wang et al. Recently performed a meta-analysis of all the studies done previously. He found that they found that external pelvic lymph node dissection template associated with a significantly better recurrence-free survival. Also, there was significant correlation between extended pelvic lymph node dissection and better disease-specific survival. The results showed no increase in morbidity or mortality in these patients. One of the most keenly awaited studies, the first prospective randomized study, was recently published. The results were recently published, LEA-EU in Germany. Around 401 participants were randomized to standard versus extended lymph node dissection. They, however, found that extended lymph node dissection failed to show superiority over standard lymph node dissection with regard to recurrence-free survival, cancer-specific survival, overall survival. In fact, they found that Calvin grade greater than equal to 3 lymphocytes were more frequently found reported in the external lymph node dissection group. However, if we go deeper into the study, I found that in these patients, the patients with neoadjuvant chemotherapy were excluded, which would have been more representative of populations which we treat. 2, 14% of patients with T1 high-grade tumors were included in this study. Also, 56%, total of 56% of the patients were T2 or lower than T2. I would say that more patients would have benefited if they were in T3 and T4 stage. They would have higher stages, higher rates of metastasis to the standard group of lymph nodes and higher group of lymph nodes. They would have benefited more as compared to the lower grade of tumors. Lastly, patients did not receive NAC, which would have been a more representative of population of patients which we treat. So I would say that we require more number of prospective randomized controlled trials before we can refute or can prove that external lymph node dissection really changes the outcome. Presently, one keenly awaited trial is still going on, SWAG 1011 trial, a prospective randomized controlled phase 3 trial comparing SLND with SELND. Around 620 patients have been randomized, and patients. One important point is that patients with PT1 had been excluded from this study, and NAC was allowed, and powered to detect differences of survival by 10%. So, what are the takeaway points? Rationale for performing a standard lymph node dissection is that the standard template can identify 93 to 95% of node positive patients. Justification for performing an external lymph node dissection is that 6 to 43% of all positive lymph nodes are found above the standard lymph node dissection field in node positive patients, while they are left in place when only a standard lymph node dissection is performed. As far as safety profile is considered, we have limited data which compare the extent of the lymph node dissection and evaluate the long-term functional outcomes and perioperative complications, but the result of a systematic review suggests that there are no differences between standard lymph node dissection and external lymph node dissection. So what should we practice? As of now, no level of evidence favors extended or super-extended lymph node dissection. Standard or extended, I would say whoever is performing what should continue till we have more prospective randomized study. Both are, I mean, if you go with the reasoning, both are justified. With no, as of now, no extra or increased morbidity or mortality in these patients. And patiently await the SWOG 1011 trial and until then adhere to the brand guidelines. Thank you.
Thank you. Thank you. Dr. Kalana, would you invite the next speaker?
Yeah. May I invite Dr. Umesh Nepal to discuss on lymph node dissection for renal cell carcinoma, dilemmas and controversies. Over to you, Dr. Nepal.
Good morning, everyone. The topic for my presentation is lymph node dissection in RCC, dilemmas and controversies. Before starting, I would like to thank NAUS and the scientific committee of this conference for giving me the opportunity. You may wonder why this topic was selected. We all know that RCC is quite common disease and accounts for significant number of cancer-related deaths worldwide in both men and women. Locally advanced RCCs are around 25% of all renal tumors. The main treatment for most of these is surgery, but the controversy has always been there regarding concomitant adrenalectomy and locoregional lymphadenectomy due to the lack of sufficient literature. Trying to search the literature regarding who will benefit from LND and its indications, we have to see this article by Umberto Capitano. He has done a lot of work in RCC. There are many series regarding LND and RCC, but the indications of LND and its extent are neither reported nor standardized in many. As per this article, large tumors, especially more than 10 centimeter ones, and those which are locally advanced or those which have unfavorable characteristics like higher Foreman grade, sarcomoidal features, and presence of tumor necrosis benefit from LND. Regarding identifying patients who will benefit most from LND, various methods have been studied like CT, MRI, and other imaging modalities. Various clinical nomograms have been suggested. Some have also suggested some biological markers, but none of them are flawless, and some even have doubtful use in day-to-day clinical practice. It becomes a sensible thing at times to remove or sample a clinically significant node during surgery, but the confusion always arises if the lymph nodes are clinically negative, and the role of LND in such a scenario is still controversial. Bekema et al. Tried to address this issue For clinical assessment of lymph node status, they use CT or MRI and intrapalpation. And it was found that the imaging modalities were unsuitable for detecting malignant disease in lymph nodes of normal shape and size. It was also found that only less than 20% of clinically positive nodes came out to be pathologically positive, suggesting that LND mostly will lead to overtreatment. The survival curve from the same study, where clinically T3 tumors were considered, the two curves are seen together and the p-value is not significant. Grisman et al. Did a large retrospective study and they found that the lymph node dissection was not significantly associated with a reduced risk of distant metastasis or cancer-specific or all-cause mortality. It was also seen that the extent of LND had no better oncological outcomes. This is a CT picture of one of my patients with a more than 10 centimeter left-sided RCC. The picture shows no significant locoregional adenopathy. But the same patient had multiple lung metastases, which may indicate that at times these tumors have predilection for early hematogenous spread even before lymph node metastases are seen. Capitano tried to evaluate if the number of positive nodes had any effect in the outcome, and it was found that the survival was definitely better in those patients who had fewer positive nodes and no extranodal extension. This highlights that LND does have a benefit for staging and prognosticating. The SEED database analysis of more than 9,000 patients showed that LND along with radical nephrectomy had no effect on disease-specific survival. What if the lymph node dissection is done in correct patients who have pathologically positive nodes on final histology? It was found that more than equal to 10 lymph nodes dissected resulted in 10% absolute increase in DSS. This study also showed that ELND results in significant prolongation of cancer-specific survival in patients with unfavorable prognostic features. Can LND along with radical nephrectomy be harmful is another frequently asked question. This retrospective analysis showed that in terms of morbidity or mortality of the surgery itself, the LND had minimal complications and were favorable. What is the incidence of pathologically positive nodes if LND was done in clinically negative nodes? This RCC tries to answer this query. It took T2, T3 tumors for study and they found that only 4% of nodes were positive. Also, the LND template was not clearly defined. So it was observed that LND had staging benefit only. This slide tries to depict the common templates for left and right tumors. We should also note that when nodes are removed from cross of diaphragm to aortic bifurcation, it is considered an extended lymphadenectomy. The optimal extent of lymphadenectomy to be it for staging or survival benefit is still controversial. The retroperitoneal lymph node drainage is highly variable, making it very difficult to define a fixed template. These are various studies which try to compare LND and LND along with radical nephrectomy and try to see any survival advantage. Most of them have taken larger tumors, but only one out of all shows a statistically significant p-value. It has been postulated that at least 15 lymph nodes should be removed for any definite survival advantage, but this requires further studies. Sentinel lymph node biopsy for RCC is still requires further studies, and the various mapping studies show that right-sided tumors predominantly drain into interaortic and retrocaval nodes, whereas left-sided tumors predominantly drain into para-aortic nodes. The retroperitoneal LN drainage is highly variable. Another question we shall try to answer is what to do when the nodes are clinically positive. As I said earlier, LND is always justified in these patients, at least for staging and prognostication, but the extent remains controversial. One of my patients had clinically suspicious paracaval nodes which were sampled, but the histopathology came out to be negative. Graceman et al. Did a systematic review and meta-analysis to see if LND was helpful in both non-metastatic and metastatic RCCs. They included patients at higher risk of lymph node mets, but found no significant survival benefit. EOR-TC 30881 is a landmark paper. It's a randomized phase 3 trial to see any benefit if lymphadenectomies were done together with radical nephrectomies, but they also found no significant difference. These are the survival curves from the EOR-TC trial showing non-significant p-values. Now coming to what the guidelines say, EAU 2020 recommends that in patients with clinically enlarged nodes, perform lymph node dissection for staging, prognosis, and follow-up implications. However, the strength rating is weak. AUA and NCCN also do not recommend routine lymph node dissection in clinically negative nodes. So the take-home message is that the existing literature does not support a therapeutic benefit in either non-metastatic or metastatic RCC. Thank you for your patience.
Thank you. Thank you, Dr. Umesh. I think that was an excellent overview as to what should be the current status of lymph node dissection in radical nephrectomy. Well, we move on next by a talk by Dr. Ganesh Bakshi, who is a renowned the oncosurgeon, onco-urologist in India. And he is going to tell us the approaching the surgery for metastatic renal cancer in an algorithmic way. You know that the metastatic renal cancer is always a dilemma, and there are many situations which produce the complexity to a given case. And Dr. Ganesh Bakshi is going to throw a light what should be the algorithmic way to overcome this dilemma over this controversy. Over to you, Dr. Ganesh Bakshi, please.
During the time of targeted therapy. Good morning. I thank the Nepal Association of Urological Surgeons for giving me this opportunity. My topic, approaching surgery for metastatic renal cancer in an algorithmic way. In 2004, this meta-analysis of 2 RCTs concluded that cytoreductive nephrectomy improved OS in metastatic RCC treated with interferon. And later in 2014, Daniel Heng published this article during the time of targeted therapy. If you see the curves, cytoreductive nephrectomy in MRCC fared better, but there was no benefit of CN if 4 or more IMDC risk factors were present. These are the 2 main risk models, MSKCC and IMDC, to risk prognosticate the patients into low, intermediate, and poor risk groups. So cytoreductive nephrectomy followed by sunitinib or TKI was almost the standard of care, but the data was retrospective. And in 2018, Carmina trial was published in NEGM, sunitinib alone or after nephrectomy in metastatic RCC. So this was a multi-center RCT with 450 patients randomized in 1:1 fashion, CN followed by sunitinib versus sunitinib alone, and stratified as per MSKCC criteria. So if you see the 2 arms with risk category and location of metastasis, it is well balanced. And if you see the OS and progression-free survival curves, they almost overlap each other. So at a median follow-up of 50.9 months, it concluded that sunitinib alone was non-inferior to CN followed by sunitinib. In 2019, the CERTIME trial was published in JAMA Oncology, and it compared immediate versus deferred cytoreductive nephrectomy in patients with synchronous MRCC. So a median OS of 32.4 months was seen in the deferred CN arm and 15 months in the immediate CN arm. In the deferred CN arm, 48 of 49 patients received sunitinib versus 40/50 in the immediate arm. And systemic progression before planned CN in the deferred arm resulted in a recommendation against
Are we stuck in the video or it is going on?
I think it is played for the recorded video.
Yeah, but, the organizers, please check.
Yeah. So we're rejoining, sir. Just a minute.
Okay. Organizers, are you able to retrieve the video recording?
Yes, sir, just a minute. We have the electricity cut down and we are just rejoining, sir.
Okay, no problem.
Good morning. I thank the Nepal Association of Urological Surgeons for giving me this opportunity. My topic, approaching surgery
To the
for
point.
metastatic renal cancer in an algorithmic way. In 2004, this meta-analysis, this groups, sunitinib alone as per MSKCC country and location of metastasis, it is well balanced. And if you see the OS and progression-free survival curves, they almost overlap each other. So at a median follow-up of 50.9 months, it concluded that sunitinib alone was non-inferior to CN followed.
Dr. Ganesh, do you have the presentation of a later part? You can do it if you have it.
Yes, sir. I am just actually putting the thing. I think we had a problem with the screen ratio. Let's come back. I think we should take it to the point where Dr. Kabnis this article during the time of targeted therapy. If you see the curves, cytoreductive nephrectomy in MRCC fared better, but there was no benefit of CN if 4 or more IMDC risk factors were present. These are the two main risk models, MSKCC and IMDC, to risk prognosticate the patients into low, intermediate, and poor risk groups. So cytoreductive nephrectomy followed by sunitinib or TKI was almost the standard of care, but the data was retrospective. And in 2018, Carmina trial was published in NEGM, sunitinib alone or after nephrectomy in metastatic RCC. So this was a multi-center RCT with 450 patients randomized in 1:1 fashion, CN followed by sunitinib versus sunitinib alone, and stratified as per MSKCC criteria. So if you see the two arms with risk category and location of metastasis, it is well balanced. And if you see the OS and progression-free survival curves, they almost overlap each other. So at a median follow-up of 50.9 months, it concluded that sunitinib alone was non-inferior to CN followed by sunitinib. In 2019, the CERTIME trial was published in JAMA Oncology, and it compared immediate versus deferred cytoreductive nephrectomy in patients with synchronous MRCC. So a median OS of 32.4 months was seen in the deferred CN arm and 15 months in the immediate CN arm. In the deferred CN arm, 48 of 49 patients received sunitinib versus 40/50 in the immediate arm. And systemic progression before planned CN in the deferred arm resulted in a recommendation against nephrectomy in 29%. This concluded, as with the deferred approach, more patients received sunitinib and OS results were higher. Pre-treatment with sunitinib by patients with inherent resistance to systemic therapy before planned cytoreductive nephrectomy. So over the years from sunitinib, today we have progressed and the drugs have been significantly improving the efficacy of systemic therapy in MRCC. So is there a role or no role for cytoreductive nephrectomy? There was a critical analysis of Carmina that it included only intermediate and poor risk patients. Accrual was slow and incomplete. This reflects difficulty in enrollment as well as selection bias. Previous retrospective studies had already indicated poor risk patients don't benefit from CN. Considerable shorter OS in both arms compared to previously reported similar cohorts. And median size of primary was 88 millimeters as well as median total tumor burden was 140 mm. So metastatic disease contributed 40% to total tumor burden. Thus, cytoreduction in the true sense was not possible for many patients. And critical analysis of CERTIME, poor accrual, only 99 patients, 19% patients did not receive the therapy that they were assigned. The solution lies then in individualizing patients with MRCC. Now, what happens in RCC with single metastasis? This is a paper published in 2005 with 43 patients of single metastasis at different sites, and all were treated with curative intent. For synchronous metastasis, median survival was 26 months. For metachronous metastasis, median survival was 45 months, with significantly greater survival if the interval to metastasis was more than 12 months. Does the site of metastasis matter? Patients with a single liver met or with 10 lung mets could fall in the same MSKCC IMDC risk category if they have similar lab values. But these patients are not the same. This study showed that the presence of more than 3 sites of metastasis and presence of liver mets were significantly associated with poor survival. If you see this algorithm, newly diagnosed metastatic renal cell carcinoma, if palliation is required, then consider cytoreductive nephrectomy. If there is a following criteria: good performance status, favorable risk, limited metastatic burden, then it favors a upfront cytoreductive nephrectomy. However, poor performance status, poor IMDC, MSKCC risk, initial systemic therapy is considered. And in intermediate risk, IMDC or MSKCC risk and good performance, there is a multidisciplinary discussion should be strongly considered, and an initial systemic therapy may be preferred, but there are data in which both can be selectively considered. When upfront systemic therapy is given, consider delayed cytoreductive nephrectomy in well-selected patients depending on the response to systemic therapy. So as per the algorithm, this is the management. A take-home message for this talk: individualized patient care. One size does not fit all. Upfront cytoreductive nephrectomy in selected patients after MDT. In intermediate risk patients, systemic therapy, delayed cytoreductive nephrectomy of good response. May consider upfront cytoreductive nephrectomy if only one risk factor and if all metastasis can also be resected. Poor risk or poor performance status, upfront systemic therapy. Metastasis, we should remember the site and the number of mets, they do indicate prognosis, and always a multidisciplinary decision and high volume center treatment benefits. Thank you so much.
Excellent, Dr. Ganesh. This was an excellent overview of a really complex problem. So many people still get confused, but I think you have thrown a nice light on the topic. May I request Dr. Kalana to invite the next speaker? Unmute yourself.
It's my pleasure inviting Dr. Balsingham Balagobi to enlighten us about what's new in medical management of metastatic renal cancer. Over to you, Gobi.
It's a pre-recorded video, I think. Someone had Welcome, everyone. I am going to talk on what's new in medical management of metastatic renal cancer. I'm Dr. Balagobi, a senior lecturer and consultant urological surgeon attached to the Department of Surgery, University of Jaffna, Sri Lanka. We all know that metastatic renal cancer is quite common, and 1/3 of patients primarily present with the metastasis, and another 10 to 20% develop metastasis after the initial treatment. So we are dealing with about 40% of renal cancer with metastasis. That's a big load. And we know that MRC, it's a lethal disease, but the invention of new immunotherapies and combination treatment, the survival is improving. So when a renal cancer is confined to the kidney, the surgery is only answer. When they have a wide metastasis, then the medical treatment is the only answer. In the middle, when the patient have oligometastasis, we combine the surgery and the medical management. So the immunotherapy made a big difference in the management of medical management of metastatic renal cancer. we know that checkpoints, by the checkpoints, tumor cells evade the immunity, immune cell destruction. So the drugs that act against the PD-1 receptors and PD-L1 ligands, they are involving in the medical management of metastatic RCC. So what are the drugs we use? Anti-PD-1 nivolumab, pembrolizumab, anti-PD-L1 avelumab, anti-CTLA-4 ipilimumab, and the well-known other drugs we know that tyrosine kinase inhibitors like sunitinib, cabozantinib, axitinib, pazopanib. So they act against the vascular endothelial growth factors. So if you see the evolution of medical management of renal metastatic renal cancer, started with the cytokines, then the targeted therapy era, sunitinib and mTOR inhibitors, then the discovery of immunotherapy era, nivolumab. So now we are in a combination therapy era. So started with cytokine era, targeted therapy era, immunotherapy era. Now we are in a combination therapy era. So in last year, there are a lot of studies in renal cancer, more studies about the organ confined renal cancer. About 20% of the papers came on medical management of metastatic RCC. So what is new? So in 2018, we already know that Checkmate 214 discovered and described about nivolumab ipilimumab combination. That's a combination of two immunotherapies. Then in 2019, Keynote 426 described about pembrolizumab axitinib study. That's a one checkpoint inhibitor and another vascular endothelial growth factor inhibitor. Then Javelin Renal 101 described about avelumab axitinib combination, again a checkpoint inhibitor and the tyrosine kinase inhibitor. The latest one in 2020, Checkmate 9ER, described about nivolumab cabozantinib combination. So we are quickly recap about these landmark trials. So Checkmate, it was a ipilimumab nivolumab combination against the sunitinib. There's an obvious advantage overall survival, but this is only described in intermediate and poor risk group, not in the patient with a good risk group. So that's a disadvantage about this combination. Then the Keynote 426 was pembrolizumab plus axitinib PA versus sunitinib against a very good overall survival and progression-free survival with immunotherapy plus vascular endothelial growth factor inhibitor combination. The important thing about this study is this advantage, the benefit observed in all IMDC risk group. That's the advantage about this combination. So obviously, the checkpoint inhibitors plus vascular endothelial growth factor inhibitors combination is better than combination of two checkpoint inhibitors. Then the next study was a Javelin study, that is AA, avelumab plus axitinib versus S, sunitinib. Again, the overall survival is observed in all risk group and is better than the tyrosine kinase inhibitors. So, and then the latest one, Checkmate 9ER study, nivolumab cabozantinib combination against sunitinib, better overall survival and better the complete response rate and better progression-free survival. So because of these factors, the EAU 2021 completely changed its recommendation. So standard of care now is combination of nivolumab cabozantinib, pembrolizumab axitinib, pembrolizumab lenvatinib. This is not only for a favorable risk group, even for any risk group like intermediate and poor risk group. So these three combination you can use in any risk group. Nivolumab ipilimumab combination is only for a IMDC intermediate or poor risk group. Then if the patient is not fit for these drugs, then we had to go for a sunitinib or pazopanib or cabozantinib groups. So if someone was treated with immunotherapy first, then second line treatment, vascular endothelial growth factor targeted therapy. If someone treated with the prior tyrosine kinase inhibitors, then we had to go for a nivolumab or cabozantinib. In conclusion, when compared to tyrosine kinase inhibitors, checkpoint inhibitors are better. But compared to checkpoint inhibitors, combination of 2 checkpoint inhibitors are better. But compared to that, combination of checkpoint inhibitor plus vascular endocrine growth factor inhibitors are better. But which combination is better out of this group is a burning question. The time will tell the answer. Thank you.
Well, thank you, Dr. Dr. Balagovi. Now we come to a very interesting debate, and there are two speakers who are very well known in their own subject. And the topic is lymph node dissection for CA prostate. Is it a surgical exercise or it is worthwhile? I think this is a very nice topic the organizers have selected. I must congratulate the scientific committee because this is the debate which is going on, and there are both sides to it. Whether some people recommend, some people don't recommend, and we are going to hear from the expert what exactly is their feeling. So first, I invite Dr. Abhishek Singh, who is going to tell us, or who thinks that the lymph node dissection CA prostate is just a surgical exercise and it is futile to do all this lymph node dissection. So let us see what he has to tell about it. Over to you, Dr. Abhishek.
Respected expert, my worthy opponent, and dear colleagues. I am Dr. Abhishek Singh from Mulji Patel Urological Hospital, Adyar, India. Without further ado, let us start this debate. This debate is about lymph node dissection for CA prostate. And the question is it a surgical exercise? I would say, yes, indeed it is. I have nothing to disclose. So if you look at the NCCN guidelines, they clearly tell you that PLND should be done for intermediate, high, and very high risk groups whenever you are doing a radical prostatectomy. But just look at this dichotomy. Whenever you diagnose a N+ disease on radiological imaging, no surgery, no PLND. And if you read through the description of PLND, then it reads that extended PLND is merely diagnostic. So why do a PLND? The imaging has changed. Earlier, we used to do exploratory laparotomy to come to a diagnosis. Then we did diagnostic laparoscopy. And today we have modern PET scans. I would say modern imaging is like a Mars rover and PLND like a dinosaur today. Why did this change? This changed with the PRO-PSMA study, where PSMA PET scan was found superior to the conventional imaging by 27%. As far as the lymph node diagnosis was concerned, it was superior by 32%. Therefore, more of imaging and less of PLND. What is the genesis, I would say? We did radical prostatectomy. Patients started having BCR. We started imaging them. We came to an imaging which could identify nodes in the pelvis without any disease outside. We started to do salvage PLNDs. We thought we were improving the results. But when we did multicentric analysis, we found that a third of these patients died due to CA prostate. BCR was high and ADT-free survival was less. This proved worthlessness of PLND in CA prostate. What about the diagnostic accuracy of CT and MRI? It is very poor. About 40% sensitivity and 80% specificity. Therefore, my friend decided that let us use PLND as a better staging tool. But if there is indeed an advantage of using PLND, then all the nodes that are to be removed should be within the template described for PLND, which is not the case. In about 25 to 40%, para-aortic, presacral, pararectal, and common iliac areas are the primary landing sites. So if you do a standard PLND or you do an extended PLND, you will miss a significant of these lymph nodes. Therefore, no PLND. Just think about the complications. This can happen to your patient. An arterial injury, a venous injury, an obturator nerve injury, or a ureteric injury. The incidence can be as high as 19%, and there can be a statistically significant longer operative time, longer hospital stay, and bleeding. Persistent drain at 3 weeks. You don't want this to happen to your patient, do you? Therefore, no PLND. Cost is prohibitive, about $900 to $3,000 extra to a radical prostatectomy. The premise of doing a lymph node dissection is based on nomograms, whether it be Barton's table, Briganti nomogram, Roche formula, or MSKCC nomogram. But all these belong to an era prior to MPMRI-based biopsy, therefore not very reliable in today's context. And what happens when you compare limited pelvic lymph node dissection to no dissection in terms of outcomes across the groups? The 5-year survival shows no statistical difference. Look at the situations like perineal prostatectomies, EBRTs, or brachytherapy. Result is always comparable in terms of PCR and cancer-specific survival. Therefore, what about the large number needed to treat? So assuming that 100% of the lymph nodes are removed, causing a 15% decrease in the rate of clinical events. For a 1% positivity, you have to treat 667 patients. And for a 10% positivity, you need to treat 67 patients. So I would say there are plenty of problems with PLND. It is only diagnostic, has high complication rates. Number needed to treat is very high. Nomograms are not very reliable. Cost is prohibitive, and it is not supported as a therapeutic modality by the guidelines. So see you at the rebuttal, my friend. Respected chairperson, respected.
The next, you can start the next. Dr. Kalana, can you invite the next person? Will we invite the next? Please unmute yourself. Unmute.
Good morning, everyone. At the outset, I would like to thank SOS for this opportunity. So today I will be speaking on lymph node dissection in carcinoma prostate. It is not a surgical exercise. So what is the current trend? It is evidence-based approach based on experience and guidelines, and not experience-based approach which some surgeons follow based on clinical judgment. And this is due to lack of clarity regarding oncological benefit and variation of lymph node dissection outcomes with patient risk group. So let us reinforce the fact why lymph node dissection during RP and its role in staging, oncological outcome, decision on adjuvant therapy and survival benefit. Undoubtedly, the most accurate method of novel staging with diagnostic value, therapeutic value, guideline recommendations along with it. Coming to staging, yes, lymph node dissection is the most accurate, reliable staging procedure for detection of lymph node invasion, and this is based upon the studies published in BJY 2018 and recent study in 2021. And they said that it should be a baseline against which any modality to be compared, whether it is MR or PET-CT. If we talk about diagnostic value, if we have accurate pathological information, that is end status, we can appropriately plan adjuvant therapy and also determine the follow-up. And this is very well explained by a paper published which says that if we have end stage, we can start immediate ADT in patients of CA prostate, and with improved overall survival, cancer-free survival, and progression-free survival in these patients as compared to deferred ADT. And similar is true for adjuvant RT. Manivannan group has published an article 2018, and they said that in this subgroup of patients where you have more than 3 to 4 lymph node positive or less than 2 lymph node positive with other risk factors, they have definitely a survival benefit with adjuvant RT. And this will only be true if you have to know the end status. Yes, oncological outcome, the most common factor in a trifecta, they have said, the article review published says there is a clinical benefit of, perioperative nodal dissection during radical prostatectomy, and it has shown improved oncological outcome in terms of BCR, whether you do lymph node dissection versus non-lymph node dissection and the external lymph node dissection. And there comes the role of extent of lymph node dissection. Now we all are convinced that lymph node dissection is definitely yes. So there are studies, they have said the extended pelvic lymph node dissection has a better BCR-free survival as compared to standard or limited pelvic lymph node dissection based on a study published in Annals Journal of Surgical Oncology. And now if we talk about the number of lymph nodes removed, so they say that the better BCR-free survival or cancer-free survival in patients with more lymph nodes removed, and that's why at the time of lymph node dissection, there comes also extended pelvic lymph node dissection in high-risk patients. The number of both lymph nodes removed and the positive lymph nodes both are important. So it's not necessary that the number of lymph node, even if they are negative, it has its importance. And the study says that more than 10 lymph node removed has a better survival, BCR-free survival as compared to less than 10 lymph nodes removed. So this is almost like a cutoff we follow. And yes, now comes that not only in PN plus disease, we have improved survival in PN0 disease too. And there are studies in Journal of Prostate. They have shown that even in PN0 disease, they have a better survival rate as compared to PNX disease. And there comes the importance of lymph node dissection and the lymph node yield. They say that increased number of lymph nodes, resected lymph nodes, or had a favorable outcome following salvage RT in patients with increased PSA after prostatectomy. And as per the study published in European Urology 2018, so if you have N0 disease but a better lymph nodes removed at the time of BCR, they have a better prognosis and favorable outcomes following salvage RT. Now let us study this. If we do lymph node dissection, 30% patients, those who are coming in lymph node positive, PN plus disease, definitely has a benefit, survival benefit. And among them, 40%, those who are RM0, no distant metastasis, they are the best patients, those who are having lymph node, dissection and survival benefit. But yes, even 60% patients, those who are having distant micrometastasis, still they have a benefit. And the patient, those who are PN0 disease, also has a benefit. So in totality, all patients after lymph node dissection have shown some sort of benefit after lymph node dissection, whether in the form of staging, oncological outcome, BCR-free survival, or overall survival. So I think now with this, we all are convinced that yes, there should be a big yes, it is not a surgical exercise, and we should go ahead with lymph node dissection in case of CA prostate surgeries. Thank you.
Now we start the rebuttal. Dr. Abhishek, what do you have to reply for that? Start Abhishek's rebuttal, please.
Thank you for a wonderful presentation, Dr. Ankur. But let truth prevail. Let's see what happened a few days back.
I'd like to say PLND in CA prostate is curative.
I hope this does not happen to you. What happens when you consider N plus disease? Let us see its implications. All these patients are likely to have unfavorable factors like seminal vesicle positivity, extraprostatic extension, margin positivity. These patients are going to require adjuvant therapy. So then what is the advantage of PLND? Look at the EAU guidelines now. They clearly tell us that performing PLND during RP does not improve oncological outcomes, including survival. And there is no RCT between no PLND and a PLND. Therefore, the statement that PLND is the standard of care is false. Look at this particular review of 66 studies when it compared PLND and no PLND. When you look at BCR, there were 18 studies, out of which 3 were for ePLND. There was no statistical difference in terms of BCR. In fact, 2 studies showed that the group that did not have PLND actually had better biochemical recurrence. What about distant metastasis? If you look at these particular 2 studies, one study showed 100% unequal survival at 60 months. And the study by Boehm et al. Showed a lower risk of distant metastasis when no PLND was done. And what about the cancer-specific survival or overall mortality? It was no different when 6 studies were analyzed. So I would say PLND and its extent are associated with worse intraoperative and perioperative outcomes. Direct therapeutic effect of PLND is not evident from literature. Robust and adequately powered studies are needed to prove or disprove importance of PLND. Modern imaging like PSMA PET scan will help us identify lymph nodes with greater accuracy. PLND. Risk stratification will improve as the imaging improves. ePLND at present can be undertaken only considering its benefit as a staging modality. Thank you for a patient listening. I rest my case. Thank you for a wonderful.
Dr. Kalana, you can invite the next for rebuttal and then for the next expert comment.
Yeah, can we have the next rebuttal, please, Dr. Ankur Mittal?
So we are back. So I am pretty sure my dear friend Abhishek is now convinced about the role of lymphadenectomy, and yes, the answer is yes, that is not a surgical exercise. And he is now, I think, pretty convinced that why we cannot omit lymph node dissection. And yes, the answer, without prospective randomized data, the argument to omit lymph node dissection is not substantiated here. He may argue about in favor of MRI and PSMA PET4 staging. My dear friend, the positive and negative predictive value for these investigations are around 65 and 85% based on the article published in BGI 2021. And these imaging, they lack sufficient sensitivity to supplant lymph node dissection. One can argue about the prediction of lymph node invasion can be done without aid of prediction models, but the significant variation in the predictive accuracy, they underestimate the true presence of lymph node invasion. So again, the answer is yes for lymph node dissection. And the argument that, okay, these lymph node dissection, if we do, it leads to complications. Oh my God, the most frequent complication, which is lymphocyte, is around 0 to 8%. And the rate of these grade 3, grade 4 complication is around 0 to 5%. There is a very low likelihood of serious complication disease when we do these robot-assisted lymph node dissection. But yes, I am pretty sure that my friend Abhishek will definitely say that there is no all survival benefit, and he will definitely quote an article where there is a shared database and propensity score matching analysis. But I have already in my previous slide, I have shown that even in PN0 disease, there is a survival benefit, not only the PN plus disease. And if we go in detail about this study published in 2019, showing the reasons for not showing overall survival benefit is that the lymph node dissection patients, they had highly aggressive tumors, and they were also having associated concomitant positive surgical margin, extracorporeal, extra capsular extension, and SVI invasion, leading to negative outcomes. And they have concluded that the cutoff point of 5% probability might be too low to show benefits of lymph node dissection in this series. But that doesn't mean that it is a surgical exercise. So to conclude, the lymph node dissection is the most accurate method of staging with appropriate adjuvant therapy, has improved BCR-free survival, improved survival even in PN0 disease, and with all major guidelines backup. And I'm pretty sure as of now, after this debate, my friend will continue doing lymph node dissection in his routine practice as he do, and is now convinced that yes, it is not a surgical exercise. Thank you for your patient hearing.
Can we have Dr. Ginil Kumar for the expert comments, please?
First of all, let me thank NOS for giving us this opportunity. You have heard a great debate by two young dynamic urologists, Ankur and Abhishek, about this topic. Is lymph node dissection with radical prostatectomy useful, or is it just a surgical exercise? We are not discussing about lymph node positive patients. Earlier days when we were young, we were told that if there is a lymph node positive patients, just leave the patient. There is no benefit by going for a radical prostatectomy. But we are discussing about a routine lymphadenectomy in radical prostatectomy. Initially, I thought that it is a clean sweep win for Ankur because all the guidelines say that the lymph node dissection has to be done in 2 to 5% probability of lymph node metastasis. We know that there is survival advantage for lymph node dissection. Is a good prognostic indicator. And we can avoid radiation in quite a number of patients in lymph node positive. And there are a lot of papers on survival advantage for lymphadenectomy. But the story is not as easy as that. Abhishek has come out with his objections. Yes, a recent systematic review did not show any clear-cut benefit for a routine lymph node dissection. There are some other data to say that there is benefit, but highest evidence recently published do not show any benefit for lymph node dissection. Also, there was no difference between extended versus limited lymph node dissection. So the question comes, can we avoid lymph node dissection? As Abhishek has told, present guideline clearly say that a lymphadenectomy has to be the way to go, but we can lift the cutoff if you are using other tests like PSMA, PET-CT, PSMA, PET hybrid, molecular studies, and genetic subtyping to identify the aggressive disease, sentinel lymph node scan. If you are having a better risk predictor using PET-MRE and other tests incorporated, may predict probability of lymph node dissection in a better way and can avoid unnecessary biopsies. So if you ask me who has won, we know that no test can substitute lymph node biopsy, but as Abhishek has rightly pointed out, the use of technology may help us to appropriately select the candidates who will be benefited, and an unnecessary lymph node biopsy could be avoided in the future. So both has highlighted the points rightly in the debate, and the trophy goes to both. Thank you.
Well, I think with that we come to the end of the session. I must congratulate the scientific committee, especially Dr. Adhikari, for charting out a very nice oncology session. I think given the due importance to our lymph node management in all the common oncologies, CA bladder, RCC, and prostate. And of course, two common problems of RCC medical and the metastatic RCC medical and surgical management also addressed. So I think all this full session was extremely useful to a general urologist who see these problems day to day. They are in the controversy, they are in dilemma. And I must thank all the speakers who have done a wonderful job. So with this, I, along with Dr. Kalana, close this session and hand over mic again to Dr. Pawan Chalise and Dr. C.S. Agrawal, please. Over to you, Dr. Agrawal.
Thank you. Thank you, Dr. Samnish and Dr. Kalana for chairing this session. And thank you all the speaker of this session. So by this, we conclude the session 2 on uro-oncology. Now I invite Dr. Rajiv TP and Mahesh Bahadur Adhikari to convene the next session on reconstructive urology. Thank you.
Okay, we'll continue the session. I would invite Dr. Muqtad Ahmad and Dr. Suren Gilbia to chair the session on the reconstructive urology.
Hello.
Dr. Surendi, are you available there?
Yep, I am. Yep.
Okay.
Good evening. Sorry. Is Dr. Mumtaz Ahmed joining us, or am I to chair this?
I think you continue the session and he will join, I think.
Okay. Good morning to everyone. Let's start. The next session is on reconstructive urology. Let me invite the next speaker, Dr. Rishi Nair. He'll be talking to us about managing long-length urethral strictures. Over to you, Dr. Rishi Nair.
Well, thank you. Thank you, Nos and
SOS for having invited me here to this UROCON 2021. And I'm going to talk on management of long length uretral strictures. I have no disclosures to make. If you go by literature, there are no specific guidelines how to manage these long ureteric strictures, and actually there is no specific definition as well. Some would say that anything which requires more than a ureterostomy should be considered as a long stricture, whereas others consider anything more than 3 to 5 centimeter as a long ureteric stricture. As regard the etiology, GUTB remains a common cause in our part of the world. However, of late, the iatrogenic surgical causes, particularly endoscopic surgeries like ureteroscopy, and sometimes even pelvic surgeries can also result in long ischemic ureteric strictures. Radiation is also one common cause in the as the etiology of these particular long strictures. The management, of course, needs to be individualized to the patient depending upon the site, size, and the length of the stricture. And of course, whether the ipsilateral renal function is there or not, and overall complexity of the reconstruction can be well tolerated by the patient. Accordingly, the procedure has to be chosen between the patient and the surgeon. As regard the management of the unilateral strictures, I'm not going into too much of the details. We all know that the urothelial based approaches constitute a major chunk of all these repairs and provide a very good long-term outcome. The endoscopic procedures are generally not recommended because of their poorer long-term outcomes for long strictures. Recently, augmentation and graft procedures have picked up, but again, the long-term results with these augmentation procedures are not available, though the initial short-term results do appear to be comparable and very good. Sometimes ileal replacement of the ureter may be required, and for right-sided mid-ureteric strictures, even appendix has been described for management of unilateral long strictures. As regard the bilateral strictures, the options available to these type of patients are really very limited. For patients who have a bilateral complete loss of ureter, long ileal chimney kind of a procedure can be done, but this procedure requires a very long length of the bowel, up to 40 to 45 centimeter, and sometimes even longer, and therefore this type of procedure should be avoided in patients who have a poor renal reserve. And this configuration of the chimney may be reverse 7, straight 7, Y configuration, and sometimes even bilateral ileal separate segments can be used, and even ileochelicostomy has been described as a different case series in literature. Even bilateral auto transplant has been described for complete uterine loss on both sides, but I would tend not to recommend this procedure because one increases the complexity of the surgery because of the use of the vessels on both the sides. And God forbid if patient ends up with having requiring renal replacement therapy subsequently, one would have to go much higher up for doing a kidney transplant. Option of a bilateral Gori flap is available only to patients who have bilateral lower ureteric involvement. In those patients, bilateral Gori flap can be made if the bladder capacity is sufficient enough to form bilateral Gori flap. A long unilateral Gori flap has also been described with the transposition of the ureter onto the Boari tube underneath the mesentery, and this procedure can be used in patients who have a relatively preserved upper ureter at least on one side. For patients who have a CKD, the options are very limited, and use of bowel in the form of a Yang-Monty ileal segments provides a very good option for reconstruction in these particular patients. And I would give you just few examples in these patients. This was one patient, a young male who had a bilateral complete requirement of a bilateral complete ureteral segmental loss. As you can see on the nephrostogram on the right side, there is only a trickle of dye going into the ureter, and he also had a megaureter on the lower obstructive megaureter and the lower aspect, a refluxing megaureter on the left side, and again a complete block at the just below the PUJ level on the left side. So in this patient, because he had azotemia, we used the Yang-Monty segments and replaced the complete ureter. And this was the outcome 3 months later after surgery. For the right side, we used a very long body flap, long U-shaped flap from the bladder was used, which was further cut into half and flipped upwards to be anastomosed to the calyx. And this was the outcome at 3 months post-surgery. And he continues to remain symptom-free, and his azotemia level has not worsened over the last 2 years. This was another lady who had received ATT, empirical ATT 4 years back because of the miduritic stricture along with the DJ stent somewhere outside. And she presented now to us with pain, but her renal function had not deteriorated any further. So we used the balloon dilatation in this patient, and as you can see, the stricture was not very tight and could be easily dilated without any elbowing at any level. And she was doing well on the symptomatic front as of now. This was another young patient developed bilateral aortic strictures because of the pancreatitis and had the azotemia as well. And he is planned for a long Boary tube on the left side, and the right ureter would be transposed underneath the mesentery to be anastomosed to the Boary tube. But he's waiting because of the pandemic. He could not be operated as yet. One important issue in these patients is whether to put a stent or a PCN before the surgery and to provide a ureteral rest with PCN. We generally tend to prefer PCN, and there is some evidence that is coming up in literature that the prior ureteral rest with PCN does provide a higher success rate and a lower blood loss. And this is probably because the surgeon is able to identify the stricture more better, and there is less utilization of the graft uteroplasty because this stricture contracts more, and therefore surgeon tends to excise that segment and repair it with a much more vigor than one would do with a graft uteroplasty. Just a word about use of indocyanine green. Robot-assisted reconstructions have used indocyanine green under infrared light just to identify the stricture site, but this is more important for short segment strictures than the long segment strictures. Tissue engineering remains limited to the animal studies as still, and there are no clinical studies for use of tissue engineering or grafts for long segments repairs. Extra anatomic stents I would not recommend in any specific patient, though they have been described in some moribund patients. So finally, I would just say that the bilateral long strictures are very rare. The management of any long segment aortic stricture needs individualization, and the surgeon should be well versed with the various techniques available at hand for giving best outcome to a particular and specific patient. So thank you very much once again, Nepal Association. Thank you very much. Okay.
Thank you, Dr. Rishinaya, for an excellent overview of long ureteral strictures. Shall we get on to the next one? And that's optimizing outcomes of augmentation cystoplasty by Dr. Apul Goel. Over to you, Dr. Goel.
Thank you, SARC Association, Urological Society of India, and Dr. Pawan Raj Chalase of NOS for giving me this opportunity. I'll be discussing how we can optimize the outcomes after augmentation cystoplasty. To my mind, there are 4 key areas that need to be addressed: choosing the correct patient, performing meticulous surgery, avoid bowel interposition into the urinary tract, and avoiding complications. As certain complications are inherent to this procedure, increased awareness both by the urologist and the patient is essential to optimize outcomes. Before moving further, we need to ask whether augmentation cystoplasty achieves its goal. Does it fail? Typical indication of performing augmentation cystoplasty are poor bladder compliance, refractory bladder overactivity, and a small bladder capacity. Re-augmentation is rarely needed with an incidence typically less than 5%. Augmentation cystoplasty for patients suffering with interstitial cystitis is considered controversial. However, if it is done, Better results are anticipated in those patients who have a small bladder capacity because of Hüller's lesion. One big issue of augmentation cystoplasty is the use of bowel as interposition in the urinary tract. This can be avoided by use of tissue engineered patch or by performing a ureterocystoplasty. Typically, ureterocystoplasty is indicated in patients who have a dilated ureter and a non-functioning kidney, where you remove the kidney, perform a nephrectomy, and use the dilated ureter as an augmentation. However, people have now started performing this procedure even in patients who have a functioning kidney by doing a transureteroureterostomy and using the lower end of the ureter as a ureterocystoplasty. Or else, because these ureters are often dilated and tortuous, you can do a direct ureteroneocystostomy and still use the lower end of the ureter for ureterocystoplasty. The commonest segments of the bowel that are used for augmentation cystoplasty are the ileum and the sigmoid colon, and they are equally fitted. Literature suggests that bowel is higher when you do an cystoplasty. Similarly, certain complications are commoner with the use of sigmoid colon, like excessive mucus production, higher risk of urinary tract infection, and a higher long-term risk of malignancy. Augmentation cystoplasty is a major abdominal surgery, and like other major abdominal surgeries, it is associated with certain complications like those involving the cardiovascular or the respiratory system and the thromboembolic complications. Similarly, early bowel-related complications are seen in the form of a small bowel leak and ileus. The stone formation is perhaps the commonest surgical complication after augmentation cystoplasty. An interesting observation is that patients who have a continent catheterizable abdominal wall stoma in a form of a Mitrofanov or a Ponti procedure have a higher risk of stone formation as compared to those patients who catheterize themselves per urethra. The reason being that patients who have a Mitrofanov procedure, they perform catheterization in a sitting posture, and the most dependent portion of the reservoir may fail to empty. We can avoid this complication by ensuring better emptying of the reservoir and regular washing of the reservoir. A subset of patients who form bladder stone develop recurrence. Now, investigators have looked into the reasons behind it, and they have noticed that metabolic abnormalities are more common in patients who have recurrent bladder stones. However, correcting those metabolic abnormalities have not shown any decrease in the incidence of recurrent bladder calculi. Reservoir perforation is a feared complication and can be avoided by regular emptying of the urinary bladder and use of a lubricated catheter and the gentle catheterization method, thus avoiding trauma induced by a catheter. Metabolic disturbances are also commonly seen after augmentation cystoplasty, the commonest being hyperchloremic metabolic acidosis. Vitamin B12 deficiency is another complication and is usually because of the resection of the terminal ileum. This can be prevented by use of ileal segment that is located 25 to 40 centimeters from the ileocecal valve. Mucus production is another big issue after this surgery, and it has been shown that the amount does not reduce substantially over time, despite a time-related villous atrophy of the mucosa. Various pharmaceutical agents have not proven efficacious in reducing the amount of mucus produced. So the best method is to perform weekly or even daily bladder washouts. Augmentation cystoplasty is often performed in children or young adults. So we need to anticipate problems later on in their lives. In case of pregnancy, prefer vaginal delivery because cesarean section may injure the bladder or the pedicle of the augmenting bowel. In case cesarean is required, an upper segment section rather than a typical lower segment section is preferable. Augmentation cystoplasty is often combined with other procedures like creation of an abdominal wall stoma in a form of a Mitrofanov, reimplantation of the ureters, bladder neck closure, or use of the stomach as an augmentation. So these are associated with their own set of complications. A feared complication after this surgery is the development of malignancy, which are typically adenocarcinomas and they develop after more than 10 years. However, first cystoscopy is indicated at 4 years, after 4 years, and then every 2 years. Thank you so much.
Thank you, Professor Apul Goyal. That was a very informative and a very interesting presentation. Our next speaker is Dr. Ata-ur Rahman Khan, who will be talking to us about total bulbar necrosis. What next? Over to you, Dr. Rahman.
All right, thank you very much, everyone, the organizers, for giving me this opportunity to be on this.
One time, okay. Yeah. No, you can rehearse it, okay. And you can rehearse multiple times.
We can rehearse it. It's one time, okay.
Yeah. No, you can rehearse it, okay. And you can rehearse multiple times, sir. No worries.
The light is okay, or you want more lights?
Yeah, is this fine? Can you see my slides, Can you see my slides?
Sorry, Prof, I can't see your slides yet.
All right, okay. Is it okay now? Can you see this now?
We can see you only yet.
You cannot see my slides.
Yes, okay, now we can see.
Okay. Yeah. Okay. No, you can rehearse it, okay. And you can
see my
yes,
slides.
Yes, now we can.
Yes, okay, or you want to tell me when I can start? Okay.
Yeah.
Right.
On this,
carry on.
Okay.
Say 3, 2, 1, and then
to the dreadful conflict of this, and this is a topic which is not really very common. It's very uncommon, and we do come across this in the pelvic fractures, which is associated with the urethral distraction defect, or maybe with repeated urethroplasties or failed urethroplasties. And this is one of the dreadful complications in posterior urethral injuries. And what I mean, basically, when one has to understand the posterior urethral injuries, one has to see all these diagrams of blood supply, because normally the posterior bulbar urethra would not necrose until unless it has injury to the dual blood supply. So therefore, the blood supply is very important to know, and similarly the nerve supply, because these are the two common problems encountered in the posterior urethral injury is urinary incontinence and ED. And therefore, it is important to understand the anatomy. When I see these injuries, which is very dreadful, but I mean, it may be associated with the rectal injuries, and it may be associated with other injuries of the body, with the road traffic accident or firearm injuries. And a lot of people may be involved. What I mean is, and urologist is one of the person involved in these sort of scenarios. And I've just quote the Richard Warwick saying that urologists will have to share with the patient the burden of any residual disability when the thoracic, abdominal, and even the orthopedic surgeons are probably long forgotten. Therefore, it's important to consider the patient as whole. And what is our aim of or goal of treatment in the beginning? Important thing is resuscitate the patient and preserve the sphincter mechanism at the bladder neck. Because once the external sphincter is damaged, the bladder neck is the only sphincter which is left, which would maintain the continence. Immediately divert the urine from the injury site and avoid jeopardizing the sexual function residual to the trauma. And for all these, as we know what I mean, we required imaging. And therefore, anterior posterior pelvic x-rays with ultrasonography, which can be combined with the Dopplers, which would tell us about the blood supply to the posterior urethra. And this is a very important investigation of retrograde urethrophy, avoiding cystourethrogram, which would tell us the upper and lower part of the urethra, and we would can calculate, we may involve a CT or MR scan, rarely, but we have to know the length of the defect and to know exactly the necrosis, the area which is necrosed or devascularized is pudendal angiogram, which is again rarely needed. As I already mentioned, the bulbar necrosis is rarely encountered, but is a difficult and challenging problem. Radiological investigation in the patient with these fractures should be arranged according to the patient clinical condition. And as I told you, in these cases, important thing is really to surely avoid the damage to the bladder neck and fully preserve the urinary continence. And immediate management, what I mean, basically, if I take this complete rupture, we need to divert the urine, which is very important in the form of suprapubic cystostomy. I'll just quote what I mean, going to my real target of posterior urethral injuries, which involves the bulbar necrosis. I'll just quote a few papers, and this is the one which is from the Rachel C. Barrett and from UK, and they looked at the this injuries and their outcome. And for males with the posterior fracture urethral injuries, restrict repair, and it offers the best overall outcome and should be the treatment of the pelvic fracture urethral injury. And if we look at these pictures, which is again in this article is mentioned, these are the different type of injuries. So therefore, it is important to know where is the impact. It is lateral, it is AP compression, or is vertical one. And therefore, you can see the distraction and the gap in this diagram. And if you see here the different fractures, it can involve injury to the other structures in the surroundings as well. And this is from the same article, different colleagues, Andy from the University of London, where he has used the bowel to really replace the gap of the bulbo-membranous, and particularly where there's a big gap, and salvage procedure for the bulbo-membranous structure disease or trauma. Defect after trauma, where interposition of a tailored intestinal flap, which I've already mentioned, and this can be intestinal flap, can be small bowel, large bowel, stomach, colon, and it normally would be tailored to the caliber of 26 to 30F, and anastomotic contracture and stone have been observed in these cases. So therefore, it is important to consider these factors. And this is another very important article by Suresh. He has concluded is urethral defect, a long one, either required a stage substitution, buccal mucosa, which is one of the common, and a successful one, and preputial or penile fasciocutaneous tube. So fasciocutaneous tube for the long gap, and particularly the bulbar necrosis, with a big gap, which can be considered. This is another important article which I was going through the different articles, is from Indian Journal of Urology, the current concept in the management of pelvic fracture urethral destruction defects. And pelvic fracture may be associated with disabling complications such as recurrent stricture, urinary incontinence, and erectile dysfunction. And if
Can you hear me? Can you hear me?
Yes.
Yeah, can you see the slide?
No, no.
No,
Sorry,
can't see.
Prof.
Now, is it?
No.
You cannot see it.
No, we can't.
All right. Okay. Can
Hello?
you hear me? Can you hear me?
Hello, hello, hello.
Yes.
Dr. Mumtaz, we have some technical problem. We'll be back in a minute.
Okay. If you want, I can just talk the last couple of slides.
Yes, right. Yes.
But I mean, yeah, you can hear me now.
Yes, we
But
can
I mean,
hear you.
basically, what I mean, looking at this article, which has really given insight into this problem, and what I've seen that there's a defect because of the bulbar necrosis, and it's a long defect, and it is a very difficult and challenging problem. So one can have like a pedicle flap, and particularly there's a one mention of the forearm pedicle flap on the radial artery, which can also be interposed in between, or as I mentioned previously about the Tony Mundy, which mentioned about the intestinal flap. And thirdly, what I mean, if there is severe stricture and the patient condition is not good, one can have suprapubic cystostomy, or one can have a metrophenol for the urinary diversion. That is another thing should be considered. But again, to fill the defect, I think the best thing is to have a pedicle flap, and the pedicle flap would give rise to some solution. But again, this is not without complication like infection divertically, and what I mean, this is not an easy part to treat because of the necrosis. But the main aim should be to excise all the stricture area, the fibrous tissues, and make it vascular. People have used buccal mucosal graft in 2 stages. Yes.
Hello. We are resuming your slides again, sir.
Okay. Okay, sir.
Okay.
Okay, sir.
Consideration in this case is one has to completely excise the scar tissues. particularly in that area. If it's a bulbar necrosis, it has to be totally excised. If it is in the initial period of where it is not necrose, it is ischemic, so it needs revascularization. So lateral fixation of pliable prostatic mucosa and tension-free anastomosis, mucosa to mucosa. And approaches could be perineal, abdominal perineal, or pepectomy added to this. And Hosseini et al. Added flexible cystoscopy to come from the top and going from the bottom and look at the different anatomical variation and abnormalities. In these cases, Wang et al. Mentioned about urethral pull-through. And for this, for the treatment of the lung defect in these cases, this is one of the other approaches mentioned in these review articles, posterior sagittal pararectal approach. The success rate of urethroplasty varied widely from 77% to 95% in various series. Pediatric injuries are significantly surgical challenge to the clinician, and because of the smaller pelvic confine and a smaller caliber of urethra as well. The success rate of anastomotic urethroplasties in children is the range of 89 to 98%. And therefore, what I mean, basically, if you look at these patients with a failed urethroplasties or with a long gap, in these cases, substitution urethroplasty using a perineoscrotal fasciocutaneous flap, that's with a perineal ureterostomy in the beginning. It means in stage procedure. And very difficult to treat, but success has been achieved. I have a series of 10 cases where I use the gracilis. So rectus abdominis can be used, bulbocavernous muscles, and subcutaneous dartos can be used. And as I already mentioned, plasty, as already I mentioned, in stage procedure and with a perineoscrotal fasciocutaneous flap. And secondly, a bowel can be used in the area with the that is another concern, can be intervention, cannot be one is like and volume, the large volume where it is done and expertise are available. And I think the success would also will be achieved successfully when we have the fellowship program in the centers with dedicated and provided the funds are available and the people are trained and they are sent to the trained centers or dedicated center where they can develop their expertise and continue the training program in a dedicated center. So at the end, I would thank again, Pawan.
Do we have Professor Mumtaz Ahmed? Do we have Professor Mumtaz Ahmed for comment? Okay, in the absence of Professor Mumtaz Ahmed, let me thank Professor Ataur Rahman Khan for that excellent review of a terrible situation when the bulbar necrosis happens. Those surgeons who've seen this would realize it's a disaster. And thank you very much for giving us a comprehensive summary of this difficult problem. Thank you, Professor. Let me invite the next speaker, Dr. Rajiv. He will be talking to us about posterior urethral dissection in the technical nuances. Over to you, Rajiv.
At the outset, I would like to thank Nepal Association of Urology and SARC for this opportunity. PFUDD, also known as a pelvic fracture urethral injury, is a bulbomembranoprostatic urethral injury, commonly as a result of shearing force, resulting in partial or complete avulsion or disjunction. Here is the case of PFUDD causing posterior urethral stenosis, also confirmed on MRI. The dissection starts posteriorly around the bulb. The dissection continues both ventrally and dorsally by dissecting the bulb of the perineal body. It continues safeguarding the rectum and preserving as much healthy urethra as possible. After the disjunction, the distal segment is dissected up to the penoscrotal junction. It is spatulated by excising the fibrous tissue. Proximal end then is found with Haygrew's dilator as seen here with palpating finger, or cutting for the light as seen here, or by Husseini's technique with needle. A 18-gauge needle is used, passed through the apex of the prostatic urethra, confirmed, and a guide wire is passed. The guide wire is seen here endoscopically coming into the bladder. Following this, dissection continues around the needle or the guide wire. Sometimes you may have to dilate it. This part of PFUDD operation, namely the excision of the fibrosis around the diseased urethra, is the most important single step. Complete and thorough excision of the fibrous and cartilaginous tissue is done by either excising with needle like this or incising with knife. After the completion, you will see that there is a healthy, pink and supple proximal end. Following this, 6 40 stitches are taken at 2, 4, 6, 8, 10 and 12 o'clock according to the face of clock, both proximally and distally. You can see the spatulation here. This is the completion of the 6th stitch. Following this, a 14-French stylastic catheter is passed, and then the distal segment is parachuted and knots are securely tied. A tension relieving suture is taken after the completion between the spongiosa and the corpora to relieve the tension on the anastomosis. Sometimes additional steps are required. George Webster described techniques to shorten the course of the lost urethra to bridge the gap as seen here. The first one is crural separation, which is separating the proximally fused crural bodies as seen here. The second one is an inferior pubectomy, starting with anterior periosteal vertical incisions safeguarding the deep dorsal arteries and dorsal vein of penis, seen in red and blue respectively. Hammer and gouge is used to excise the bone fragment to create adequate space for further dissection and to shorten the course. The third step is a supracrural rerouting that is infrequently required. The urethra is rerouted around one of the crura with wedge osteotomy of the inferior rams. There are some special situations like seen here. A transpubic approach is required in children young individuals, females, and situation like this, which is pie in the sky bladder. In bulbar urethral necrosis, especially in redo cases, interposition of a tube is required, and a commonly done is a preputial tube. A flap is harvested like this, rotated, tubularized, and interposed. In summary, the principles are a thorough removal of fibrous, cartilaginous, and avascular tissue of the diseased urethra, adequate mobilization to get healthy, pink, and supple proximal end, optimal mobilization of the distal segment to get tension-free and wide anastomosis with the proximal end.
Please bear with us. Looks like we've just lost the video link.
Yes, you can continue the session, sir.
Okay. Thank you, Professor Rajiv Kore. I'm sorry we lost the last bit of your presentation, but I'm asked to continue. So let's go to the next topic. It is harvesting of buccal mucosa, the technical nuances. This will be presented to us by Dr. Pankaj Joshi.
Good morning to all members of Nepal Urology Association and the SARC Urology Congress. I thank the organizing committee for the opportunity to speak on the oral mucosa harvest for urethroplasty. Whenever it comes to the harvesting of oral graft, it can either be an oval graft or a rectangular graft. In case the oral cavity is not good, we may have to harvest it from the lingual region, but we do not prefer harvesting a lip graft. As far as the steps are concerned, we always prefer having a nasal intubation. We apply a retractor, which helps in opening the mouth. Always identify and mark the Stenson's duct so that we stay far away. Mark the graft. We do a submucosal injection of lignocaine with adrenaline, which is available in a standard combination, and then perform a dissection. The donor site, in case we harvest an oral graft, we can close. But if we harvest a rectangular graft, we tend to leave the grafted area open. I'm going to show you a video of an oral graft harvest. I'm harvesting this graft from the cheek. This is a Boyd Davis retractor commonly used by ENT surgeons for tonsillectomy. Kindly note there has been a nasal intubation. I'm marking the Stenson's duct, which is opposite the second molar. As far as the width of graft is concerned, we prefer harvesting about 1.5 centimeter oral mucosa. I'm using a scale which is commonly available in the school box. I'm marking a rectangular graft because this is a long stricture. I'm leaving a margin of about 1 centimeter from the oral cutaneous margin or the vermilion border. Through one edge, I'm injecting lignocaine with adrenaline solution. The advantage is it causes hydrodissection as well as provides anesthesia in the post-op recovery period. Usually, I can go up to the anterior tonsillar pillar. Using the same scale, I'm going to retract the graft and make a sharp incision over my marking. The most important principle in an oral graft harvest, or to matter any surgery, is traction and counter traction. So I'm joining both the lines of incision. I'm using a 3-0 silk sutures, which will be used as a stay for my colleague. My colleague is using and retracting the oral graft, while my left hand, I'm retracting the cheek, and now I'm incising the area in between the submucosal plane. I'm keeping my scissors parallel to the graft. The idea is to drop back all the muscle and go in the submucosal plane. Usual harvest time is about 7 to 10 minutes for a long graft. I'm marking the tonsillar pillar. It is still best to avoid going beyond the region of the third molar. I'm disconnecting the graft from the underlying surface. I'm removing any muscle bits that have come. Technically, the graft harvest is about 10 centimeters. The width is 1.7 centimeters. This is the donor area. In case the oral cavity has oral submucous fibrosis or black spots due to chronic tobacco chewing, and we need to do urethroplasty, the second choice of graft is the lingual mucosa. It's best to stand on opposite side of the patient. So if I'm harvesting the left lingual mucosa, I would be standing on the right side of the patient. I'm going to mark the midline so that I do not cross the midline. The usual width for a lingual mucosa, though it is dependent on the size of the tongue, would be around 1.2 centimeters. Other principles remain standard. Injection of lignocaine with adrenaline.
Hello? Hello, Dr. Suren?
Yes.
Sorry, we are having the electricity cut and we'll be rejoining in a few minutes, 1 minute time. Just be with us, sir.
Okay. Yes.
This is donor area. In case the oral cavity has oral submucous fibrosis or black spots due to chronic tobacco chewing, and we need to do urethroplasty, the second choice of graft is the lingual mucosa. It's best to stand on opposite side of the patient. So if I'm harvesting the left lingual mucosa, I would be standing on the right side of the patient. I'm going to mark the midline so that I do not cross the midline. The usual width for a lingual mucosa, though it is dependent on the size of the tongue, would be around 1.2 centimeters. Other principles remain standard. Injection of lignocaine with adrenaline. The lingual mucosa is tentatively much less thinner as compared to the oral graft. So we need to handle it carefully. I'm making incisions on both the sides. I'm going to take a stay stitch at the apex of the graft, which will be used for retraction. I'm going in the plane just below the mucosa. Once we come in the correct plane, you just make the scissors parallel to the graft. So this will avoid any muscle tissue coming onto the graft. We have used bilateral lingual graft even for a panurethral stricture. This is an oval shaped graft. We always need to close the tongue after harvesting a lingual graft. The choice of suture can be polydiaxone. And this is a completed lingual graft harvesting. Good morning to the all members of Nepal.
Okay. Thank you. Thank you, Dr. Pankaj Joshi. That was a very, very clear video demonstration of a buccal mucosal and buccal mucosal harvesting. Thank you. Can we get to the...
Dr. Suren, Dr. Soren Pereira is not available. So I think we'll conclude this reconstructive urology. So any question and answer you can conduct.
Okay. So can we open the video platform as well as the floor to any questions? Are the speakers still with us?
Sanjay Kulkarni sir is raising hand. So please, sir, Sanjay Kulkarni sir. I think he's...
Hello.
Hello.
Yeah, Dr. Sanjay Kulkarni from Pune, India.
Yes, yes, Prof. Yeah.
So Dr. Pankaj Joshi's presentation was excellent. And Dr. Ataur Rahman's presentation on bulbar urethral necrosis was excellent. Our first choice of treatment for bulbar urethral necrosis in India is a pedicle preputial tube. And if it doesn't work, then we'll have different techniques. But this is the commonest technique that we use. I'm really happy that I can see my friends here, Dr. Tohid, Dr. Mumtaz, and then all people from Nepal. Thank you very much.
Yeah. Right. Thank you. Thank you, Dr. Kulkarni, for that comment. Thank you very much.
Thank you.
So we will conclude this reconstructive urology session, then we'll have a 5 minute tea break. So we'll join again after 5 minutes.
Respected panelists and the presenter for the next session, please be with us as a panelist in the Zoom, please, sir.
Chairperson online
Hello. Hello. Yeah, we're going to start the next session on renal transplantation. Yeah, we're going to start the session on renal transplantation, and I'll invite Dr. Malika Arjun, Dr. Toid Hussain, and Dr. Ajay to chair the session and conduct the sessions. Thank you.
Thank you, Mahesh. Wonderful seeing you on the stage. Hopefully, where is Tohe? Tohe is online. Hello.
Hello, sir. Dr. Mallikarjun, just carry on.
Hi, Mahesh. How are you? Good to see you.
Okay.
You had a wonderful session. You are much ahead on time, I think. I'm before on time. That's great show by you all guys. Anyway, Tawhid is here. Yeah. Tawhid.
Yes, sir.
And Ajay is also there. That's wonderful. Thank you, Ajay. Okay, let us go on to the session rather than on this renal transplantation. The first thing is going to be a risk reduction strategies for donor nephrectomy by Anup from Delhi. Anup is a very well-known robotic transplant guy from Safdarjung Hospital, New Delhi, and a very, very energetic and cheerful guy. Can we go on to Anup, please?
Yes, our first presenter is Anup Kumar Gupta with risk reduction strategy for donor nephrectomy.
Yep.
Good morning, everyone. I would like to thank the organizers of South Asian Association of Urological Surgeons for giving me this opportunity. I will be talking on risk reduction strategies in lab donor nephrectomy. Tips and tricks of lab donor nephrectomy in some tricky situations. And nowadays, lab donor nephrectomy has become a standard of care. Even for a patient with multiple renal vessels, the options they have been listed here, but I will mainly focus on the lab donor nephrectomy. Definitely left side is preferred of the right side because it's technically easier. And in multiple renal vessels, as you know, we are taking more and more because of the shortage of donors. I will just show you small videos how can we take care of the these multiple vessels lab donor nephrectomy. This was a 35-year-old female, and she was having on the left side 2 arteries and single vein. And we planned for a lab donor nephrectomy, and we do all the surgeries by a 3D laparoscopic technique. This is our standard port configuration in the lateral position. We use typical 3-port and sometimes a 4th port in obese patients. So there was a discussion on obese patients. So we routinely do lab donor nephrectomy in all obese patients, and we have done even up to 35 BMI lab donor nephrectomies. We start with the colonic mobilization, in which I want to show that even in multiple renal vessels, on the left side, we are showing this video. So the technique is standard, which you do in all any kind of lab donor nephrectomy. Ureter dissection we started, and we dissect normally the ureter along with the gonadal vessel as a common complex. Although it's not necessary, but it prevents any vascular devascularization of the ureter. So as you can see there, we are lifting the whole thing up and going towards the psoas muscle, making a window, and then we mobilize towards the hilum area. You can use an energy device if you want. Otherwise, you can use a normal scissors and bipolar current also, as per your choice. And then we go to the hilum dissection. So the hilum dissection is very important for multiple renal vessels. You have to be careful not to injure these vessels. At the same time, you should have adequate length. So as you can see here, we are dissecting the hilum, and this is the accessory vessel. You can see there, we are dissecting. This is the main renal vein, and this is one of the tributary of the vein which is coming in front of this artery. So we dissected this artery. First, we looped it, and then we went for the dissection of this the accessory vein. And as you can see right there, we decided to clip this tributary so that we have good access to this accessory artery. And then we proceeded further for the dissection of the accessory vessel. The main aim is to go right up to the aortic origin so that you can have a good length of these vessels. Now we are clipping the gonadal vein. This will further give us good access to the artery, right? We can go up to the aortic origin. So this is very important to have a good length of the arteries. Vein is not a problem on the left side, but the artery should have good length. And as you can see here, we are going to dissect the vein on this side, and we are going to loop it. The main vein is looped now. And then we're going to dissect this is the main artery there. The main renal artery has been dissected. So our main aim is always to preserve vessels, whether it's a small artery, we still try to preserve it, and we can anastomose later on. And now we are taking care of the lumbar. This is a very tricky vessel. You have to be very careful, otherwise it can cause a lot of complication. And now that's a main renal vein being looped here on the proximal portion and right there. And now we are going for the main artery right there. That's the main artery. So this is how we try to go right to the aortic origin, and we loop these vessels. So once you have looped all these vessels, now it's a simple job. This is the aortic origin you can see there, and then you have to just mobilize the kidney all around, and then you have to clip the ureter. So I will skip this in the interest of time, but I just want to show on the right side. Right side, we know it's a very technically difficult surgery. So what are the tips and tricks you can use on the right side? So small video, 1.5 minutes video, and I'm going to show that on the right side, again, you start with dissection of the ureter and the gonadal vessel as a common complex. You might do, you might not do, because here the gonadal vessel is draining into the IVC. So in this case, you can see I'm not taking the gonadal along with the ureter, but you always try to maintain the vascularity of the ureter. This is the hilar dissection, and that's the main renal vein. And so the problem is if you have a early branching of renal artery on the right side, and plus also you want to have the maximum vein length. These are two issues you have to take care. So now the main thing is you always dissect the kidney two-window technique as described, below and above, and then you flip the kidney to the middle side, as you can see here. Now we can see the artery right there, and we can do the retrocable dissection. So that's a very important step. Even in the case of early branching, we can do this, and we can take care of the early branching. And now once you have done that, you flip the kidney back, and then we are going to take care of the renal vessels one by one. So here what we do, this is the ureter being dissected. Go to the hilum directly, apply a clip right there in the artery, and then we take care of the vein first. Now this is one technique in which now we are using an endovascular stapler to take care of the vein. And after taking care of the vein, then we go to the artery again. Now this gives us extra length on the artery, and we can go proximal to the first clip and apply a clip proximal to it. So this will give us some additional millimeter of the length. So this is what I wanted to show in the right side. Rest of the things are common to the other side. Lap donor mastectomy has become the standard of care, and that's why even in the challenging scenarios, it can be done. There is no adverse effect on the long-term graft function survival, even if the multiple vessels are there or it's a prolonged pneumoperitoneum. In the end, I would like to again thank the organizers.
Okay, thank you, Anup. Is Anup there or Mahesh? Do we invite questions or anything or a comment on this? Well, Tauhid, you want to comment on the video? Possibly.
You can comment on the things.
Okay, thank you.
Presentation,
Thank you.
yeah.
Thank you. I would like the other panelist. Who was the other panelist? Tauhid is one, and another panelist can have a comment on this video, Dr. Anup's presentation. He has presented one right donor nephrectomy and one left donor nephrectomy, and the complexity of the vessel's anatomy there. Tauhid, you want to comment on this?
No, thank you, sir. It's a great honor for me to chair with you in a very special meeting organized by the Nepal Urology Association and also the SARC Urology Association. The video demonstration of the Anup is excellent. Those who are performing the donor nephrectomy, I think he covered all the tips and tricks how you handle donor nephrectomy. So we can go forward, sir.
Oh, good. Tauhid, I think before we announce, possibly one specific point, what Anant was very clear in saying, Anup was clear in saying is saving as much length as possible. But the same time, why we should understand is, too much of clipping there around also at the hilum is going to be a troublesome during our repair, and we end up in taking out the clips. So try to decrease the number of clips also at the hilum at that one point, which is my personal opinion on having too many clips around the hilum, especially when you're doing a donor nephrectomy. If there's no other comment, and Tauhid is finished, and I don't know that other panelist, who was it? Ajay, who was that? If there is,
I think we can call up on the next speakers.
So go ahead, Tauhid. You can call up.
So our next speaker is Dr. Nirosan Virani. He will talk on the renal transplantation post-urological malignancies, how long to wait, and factors to be considered. Dr. Nirosan, please.
to talk on renal transplantation post-urological malignancies. Transplantation has evolved as the gold standard for renal replacement therapy. Therefore, it is offered as many patients as possible, especially in SAARC countries, as chronic dialysis is a costly exercise. In preparation of a kidney transplant, a potential candidate must undergo pre-transplant screening in 4 key areas, of which presence of active malignancy needs to be ruled out, as it is one of the significant cause of long-term mortality in kidney transplant recipients. In the early times, the transplantation of pre-existing cancer was a rare finding, but today, malignancy is now increasingly prevalent in the aging population. Active listing of patients with pre-existing malignancies, however, was often postponed or delayed. When a kidney transplant patient is listed who had had a cancer previously, the initial recommendation was based on Spence finding in 1997. The overall risk of malignancy was 21%. Based on his cautious recommendation, a 2-year wait time was recommended even for low-risk cancers to avoid risk of mortality if they were transplanted too early. Even longer waiting times for high-risk groups were recommended. This was in an era where the understanding of the tumor biology, staging, treatment options available was different to what it is today. Waitlisting of patients with prior malignancy usually conducted very cautiously because of the fear of cancer recurrence and the effects of post-transplant immunosuppression, which is often incriminated in reactivating and aggravating the malignant disease. The absolute long-term risk of mortality due to cancer recurrence seems to be relatively modest at 10%. The relative risk is 2 to 4-fold. The counter-argument is no longer transplant is done, then these patients undergo dialysis, have a 5% risk of death annually, as well as developing high risk of de novo malignancy. A high relative risk after transplantation should not be the sole reason for withholding a kidney transplant, especially if the relative risk is equally high in the dialysis patient. The relative risk for a kidney cancer is almost twice in the transplant group. But if you look at the prostate and testis cancer risk is much more lower and is higher in the dialysis group. One must also appreciate that the relative risk of having a death due to a cardiac event with a pre-existing heart disease is 1.88. The immunosuppressive drugs result in reduction in the tumor immunosurveillance and activation of human oncogenic type viruses, result in the sarcoma and lymphoma, which are higher in this group, but which is not seen in the urological malignancies. In 2017, a meta-analysis of 37 studies were not able to show convincing evidence in support of recommending that longer intervals between cancer diagnosis and renal transplant might decrease the risk of tumor recurrence. Interestingly, more important fact was that at 5 years, almost all patients were surviving. Therefore, a lack of recurrence after 1 to 2 years virtually suggested a complete cure of the tumor, and a relatively short waiting list period may be possible before the patient can be transplanted. Recommendation in terms of renal cancer is if there is a T1A or T1B tumor with favorable grading is to proceed with transplantation without a waiting time. This was also shown by the paper from Nicole, where he transplanted 43 patients with excision of a small renal mass of 3 centimeters, and all patients did very well. However, if there is unfavorable histological grading as Furman grade 3 or 4 in T1B tumors, it is recommended to wait for 1 to 2 years. In case if there is T2, T3 or T4 tumors, the general recommendation is to wait for 2 years. However, if there is unfavorable histological type such as sarcoma, collecting duct, medullary carcinoma, or in case of lymph node positivity, it is not recommended for transplantation. In terms of prostate cancer, if it's very low risk disease where the PSA is less than 10, Gleason 6, clinically T2A tumors, it is recommended to proceed with transplantation without waiting. However, if there is intermediate risk, it is important to look at the nomograms and predict the cancer-specific death over the next 15 years, and if the risk is less than 10%, to proceed with transplantation without a waiting time. The main limitation of these tools are the nomograms have not been validated in transplant patient groups that require immunosuppressive drugs. Also, if there is metastatic castration-sensitive disease, a stable disease for 2 years, then one can proceed with transplantation. In terms of bladder cancer, non-muscle invasive cancer with low or intermediate risk, a wait time of 6 months is recommended. However, if there is high risk or muscle invasive cancer undergone cystectomy, a 2-year wait time is recommended. The factors to be considered prior to transplantation is multiple. Organ failure factors, patient factors, cancer factors, and immunosuppressive factors needs to be considered. The allocation of donor kidneys with low immunological risk is generally recommended. Protocol biopsy is recommended so that early detection of cancer is possible in the transplanted kidneys. And switching from calcineurin inhibitors to the mTOR inhibitors is recommended, not because of the increased risk of urological malignancy, but to reduce the risk of malignancies of the skin. So, it is evident that remarkably the mortality due to malignancy has essentially remained unchanged, and it may become the most significant cause of death with a functioning graft as the transplant population continues to age. While the risk of elevated in transplant patients to certain malignancies, urological malignancies do not seem to occur more often after transplantation. In any case, the detection to waitlist a transplant candidate with a history of malignancy should be made by special agreement with an oncologist, considering the histologic, the genetics, the recurrence risk, and the availability of novel therapeutics. Prior treated advanced cancers should be individualized with wider consultation with a broader multidisciplinary team. Thank you. At the outset,
Perfect. I think Niroshan is there. I think he's seen there. I don't know whether he's there.
Yes, sir, I am there.
Wonderful, Niroshan. Wonderful. It's a fantastic talk. I think, what do you mean? We understood the tumor biology better than what it was before. So we are not looking at a lot of waiting period in a better prognostic tumors. You mean to say that is your bottom line of thinking now?
Yes, sir. The main thing is by waiting, keeping patients on the wait list. The patients are losing themselves because of the annual mortality is 5 years on dialysis. So you unduly keep them long without transplanting. But the evidence is shown that they do better with transplantation. And now, because of the better diagnostics and properly grading the risk profile is possible. So therefore, I think the tendency is to transplant these patients much more earlier than previously.
Are there any specific diseases where you don't plan a transplant? Any specific malignancies in that case? Are there any?
Yes, lymphomas and skin malignancies, especially melanomas in the West, they have a very, very high threshold not to transplant these patients. So I don't know whether you saw in one of the slides, the relative risk goes up to about 30% with skin disease. So these are generally people don't consider for transplantation.
Perfect, dear. You made a mark on your presentation. Fantastic. It was a very nice presentation, Niroshan. Let us go into the next presentation. Wonderful. Congratulations on a beautiful presentation. Multiple vessel anastomosis, technical nuances, but none other than Dr. Ramesh from Bangalore, India. Ramesh.
Good morning. At the outset, I would like to thank the Nepal Association of Urological Surgeons for inviting me to this meeting. Today I'll be presenting a little data on multiple vessel anastomosis in renal transplantation. One of the challenges for doing transplantation is anatomical variants that we encountered. And of these, the multiple renal arteries are the most common variants that we encounter. It is there in almost 20 to 30% of all potential kidney donors. It could be unilateral in 25% and bilateral in 10%. And generally, over a period of time, it's been considered that donors with multiple renal arteries are a relative contraindication for donating these kidneys owing to the complications that one could encounter both in the donor surgery and in the recipient surgery. However, current data has proved that this to be untrue. And today, all of us accept donors with multiple renal arteries because there's a limited donor pool and the large list of recipients in the waiting list. So one would choose to go ahead and do the transplantation, even if the donor has multiple renal vessels. Specialized vascular techniques, which involves either bench reconstruction or in situ reconstructions, have been adopted to choose kidneys even with 2 or even sometimes 3 renal arteries to do the transplantation. When one considers donor surgery, it is obvious that donors with multiple renal arteries require more time for doing the dissection, and thus it's technically more challenging and potential for complications such as graft injury or bleeding. Because of the longer ischemic times and spasm of these vessels, there's a good chance that kidneys can go in for ATN with increased graft immunogenicity and chances of rejection and premature graft loss. In the transplant, in the recipient, in patients with donors with multiple renal arteries, there's a chance for more vascular complications like arterial thrombosis, renal artery stenosis, increased risk for renovascular hypertension, and poor graft survival. In spite of these potential, both in the donor and recipient, long-term data has suggested that there's no difference in the long-term graft outcomes and survival in donors and recipients with multiple renal arteries. The various techniques have been adopted for both bench and in situ reconstruction of kidneys with multiple renal arteries. One could either perform an end-to-side anastomosis of a small artery to the main renal artery, or one could perform a side-to-side anastomosis of similar sized arteries if there are 2 arteries or sometimes 3 arteries. These vessels could also directly be anastomosed to the internal iliac, external iliac, or the common iliac arteries. The inferior epigastric artery is a useful adjunct to be used when you have a lower polar vessels which is smaller in size, because one would not want to salvage these lower polar vessels for fear of ischemia to the ureter. These are a few pictorial diagrams of anastomosing 2 renal arteries. If they're equal in size, they could easily be anastomosed side to side and put onto the external iliac artery or internal iliac artery. If one of them is smaller than the other artery, then the smaller one could be piggybacked onto the main renal artery to have a successful outcome. Sometimes we have an artery which is smaller in length, and then we would need to interpose a graft between the normal sized artery and the smaller artery. A useful vessel that is available there readily is the inferior epigastric artery that could be grafted in between. If the main renal artery is small, then we could extend the length of the main renal artery by taking a piece from the internal iliac artery of the recipient and extending the length. If both the vessels are small, then we could use a dual graft of the inferior epigastric artery and the internal iliac artery to extend the length. It's not too much of a problem when we take a diseased donor, because invariably a diseased graft is always accompanied by a patch of the aorta, and it's a simple job even if there are multiple renal vessels to put this patch onto the external iliac artery. If the gap between the 2 arteries are too long and the patch is too long, then we could excise the intervening patch and reconnect them to make it a smaller patch, make them as 2 separate patches and put them onto the external iliac artery. I'll run through a few examples of procedures which we have done on multiple renal vessels. This is a donor who had 2 renal arteries on the left side and 1 on the right side. We choose deliberately the left side because his GFR on the left side was 42%, and we wanted to leave the better kidney with the donor. And you see these 2 vessels are almost identical in size, and we have anastomosed them side to side, and the main stump has been anastomosed to the external iliac artery. Sometimes we have a situation where a confluence of both these vessels just takes place very close to the aorta. There's a very early branching. In this situation, what we did, we could mobilize a good length of aorta, put in a cross clamp at the aorta, took this graft along with the cuff of aorta, and then put this as a comfortable patch onto the external iliac artery. The aortic patch was sutured directly to the external iliac artery, and this guy had a good outcome. This was a donor who had 3 vessels on both the sides. We chose the left side, and you can see the 3 vessels here. What we did was we anastomosed 2 of the vessels side to side, and the smaller of the vessels was anastomosed to the inferior epigastric artery. Though the ischemic time was 63 minutes, the outcome of the graft was very good because this patient put out urine on the table. There's another situation where one could use a gonadal vein that is radiolabile in the recipient field. The gonadal vein could be opened up, and then the 3 vessels could be anastomosed to the gonadal vein, and this put as a patch to the external iliac artery. This was published in the journal, and I've taken these pictures from that journal. And they claimed that it had excellent results with good urine outputs on the table. When you look at the data on the outcomes of transplantation in multiple renal arteries, meta-analysis from Netherlands showed that though the multiple renal grafts, artery grafts were associated with the high risk of complication and delayed graft function, there's comparable long-term outcome for graft and patient survival. My tips for a good anastomosis when there are multiple renal arteries would be to have good magnification, good vascular instrumentation, and good teamwork. One would need to practice well with working with smaller size sutures like 7/0, and one would also want to do bench surgery if required to have these kidneys under cold ischemia. In conclusion, both the donor and recipient outcomes with kidneys with multiple renal vessels are good. There are long-term data which suggests that as safe and as the outcomes as good as donors with single renal arteries, with comparable long-term outcomes for both graft and patient survival. Thank you.
Nice, Ramesh. Tawhid, do you have any questions to Ramesh? Tawhid, if Ramesh, let me ask you one simple question.
Yes,
most of the time we come across is, what is your preference? You have 2 arteries on the left side and on the single artery on the right side. Will you prefer a right or a left?
If the vessels are of good caliber, we would comfortably take the left side. So we are happy taking 2 arteries. There's no issue at all. We can either do side to side or put both of them into side onto the external iliac artery. So because we get a longer length of the vein. Working with the vein is more difficult than working with the arteries, though the vein diameter is good, but the feel and the suture holding on the vein is much more difficult when you take a right vein. It's a shorter vein, so it's much more complex operating with shorter veins or multiple veins. So any day, if there are 2 vessels on the left side and a single right, I would still prefer taking the 2 on the left if the vein is good and there's no other issue.
It's always better to have a risk with artery rather than the vein, because the repair is going to be much more easier for the artery rather than the vein. Ajay,
Again, the nephrologists are a little fussy about the GFR also. There's a debate which is going on next.
There's a debate, so I didn't ask that question. Yeah,
exactly. So there's a lot of other issues that need to be considered, which we'll listen to from the debaters. That will be very interesting to listen to.
Wonderful.
Dr. Ramesh, thank you very much for your nice tips and tricks regarding the multiple vessels anastomosis. You have the 3 artery, such 2 into the hilum and 1 in the lower polar. How can you deal with?
So if the 2 of the which are normal size, equal size, we can put them side to side and put them onto the external iliac artery. And if the lower pole is small, we always, when there are so many vessels, we always keep the inferior epigastric ready. And if it matches in size, we go ahead and suture it end to end to the inferior epigastric artery.
Yeah.
Before we go to the next, Ajay was commenting on something. Ajay, will you want to have a short comment before we go to the next?
Sir, I saw one of the images in which you said retrieving the aortic patch in live donor. Yeah. Is it advisable? Is it safe to do?
Generally not advisable. It is not advisable. This guy was a young guy and we had got a good mob. We normally don't do it. I would not recommend it as a routine, but it's one of the options. Since this was a presentation on multiple renal arteries, it would not be a primary option, but it could be considered as an option.
No, it's a most common tendency of a surgeon to show the rarest things and possibly most controversial things in their presentation.
I expected a comment. That's why I put that slide.
So, we hope that
it is not a routine. We don't do it routinely.
Because I had done it twice in my career and I am not very happy about doing it.
That's wonderful. We'll go to the next one.
I fully agree with you.
Yeah, Tawhid, we'll go to the next one. Can you tell the
next? So thank you. Our next presenter is Dr. Manish Pradhan. He will talk on the lymphocyl, very one of the commonest post-surgical problem, lymphocyl, the post-transplant, post-renal transplant, prevention and management strategies. Dr. Manish, please go ahead.
Also giving me.
Good afternoon. At the outset, I'd like to thank the organizing committee of NOWS for giving me this opportunity to present here today. The topic of my presentation is lymphocyte post-renal transplantation, its prevention, management strategies, and in brief, I'll be discussing our experience here at Nepal, TU Teaching Hospital in Kathmandu. Coming to the definition, there is no accepted definition that, for lymphocyte or lymphoria. Consensus group recently have come up with a proposed definition of lymphoria as fluid leak more than 50 ml per day from the drain, which is not urine, blood, or pus, or from the drain side after the removal of drain for more than 1 week. Lymphocyte has been defined as fluid of collection of any size near the grafted kidney after urinoma, hematoma, and abscess has been excluded. The reported incidence in literature varies from 0.6 to around 34%, and this wide gap is because of different definition that is used in the literature and diagnostic modalities that have been used in the study. The peak incidence is in 6% per day, that ranges from 2 weeks to 6 months. Donor and recipient-related risk factors have been proposed, as shown in this figure. At our center, we did an RCT for a year, and in that univariate analysis showed that multiple renal arteries and graft rejection were significant risk factor involved for lymphocyte formation. However, in multivariate analysis, only graft rejection was statistically significant to predict lymphocyte development after transplantation. Talking about the diagnosis, ultrasound is the matter of choice. Both CT and MRI can be used to rule out other differential diagnosis. Lymphocytes are usually asymptomatic, but whenever they become symptomatic, they may present with these features as highlighted in the slides. The same consensus group proposed to grade the lymphatic complication into A, B, and C according to the treatment required. Grade A, where there is no treatment requirement, only diagnostic or therapeutic expiration has been done. For grade B, non-surgical intervention like external drainage or sclerotherapy may be used. And in grade C, those requiring surgical options have been placed. Talking about the treatment, usually these lymphocytes are asymptomatic and resolve on their own and do not require any kind of treatment. But for those symptomatic lymphocytes, there is no uniform treatment that is agreed upon, and different approaches have had variable success. Whenever we are choosing any treatment, and we need to consider the severity of symptoms, the size of the lesion, the complication that these therapy may have in the patient. We need to consider the clinical condition, and every department involved in transplantation should have a defined standard to handle the lymphocyte. This slide basically sums up the treatment approach. The aspiration, external drainage, sclerotherapy, or surgical approach are used mainly for dealing with lymphocyte. In the past, subcutaneous octreotide were used, but now this has been mainly replaced with these treatment modalities as proposed from University of Heidelberg. The first line is external drainage through aspiration or drain placement. Second line is sclerotherapy using povidone iodine or ethanol. And if that fails, then we go to third line therapy of fenestration using laparoscopic or open approach. All these modalities have different success rate, with least success being in aspiration and drainage group, whereas highest success rate are found in surgical approach, and also surgical approach has least recurrence rate. All these have their own complications, mainly local infection in drain placement, sclerotherapy, and aspiration therapy. Grave complication of even graft loss have been reported in sclerotherapy group. Open and lap surgeries have intraoperative complication of visceral injuries, bowel injury, ureteric injury, and post-surgery complication of wound lesions, infection, and pneumonitis have been reported. So as far as possible, we need to prevent lymphocyte development because it carries higher healthcare costs because of diagnosis and treatment costs involved. It increases patient discomfort and prolong the hospital stay. So different strategies to decrease the formation of lymph in the first place has been proposed. That is, we need to be very meticulous in dividing and ligating all the lymphatics around the hilar hilum of the kidney and also in the back table dissection. And the careful dissection should be done around the iliac vessel during graft bed preparation. Patching the graft into the common iliac vessel have been also proposed, where the lymphatics are less dense, and even avoiding immunosuppressive agents like mTOR inhibitors in the first month of transplant have been proposed to reduce lymph formation. Briefly about the studies that we have used in our center. RCT was done where we compared the traditional Sikh ligation with the bipolar sealing devices. However, it did not show any statistical significance in reducing this lymphatic complication, although the total drain volume was less and lymphatic complication was less numerically. We did not find any statistical significant difference between these two modalities, which was similarly reported by other studies as well. Talking about studies to increase absorption, prophylactic fenestration during transplantation has been proposed, which is shown to reduce the complication from 15 to 3%. However, meta-analysis and systemic review have shown that only few studies have done this technique, and we need to have large volume study in multicentric trial to endorse this as modality for treatment. Lastly, I would like to discuss the lymphatic complication at our center. After 630 transplant, lymphuria has been seen in around 3.8% and lymphocyte in 1.2%. Most of them had been managed conservatively. Octreotide were used in initial days of our transplant. These days we deal with them with pigtail placement and sclerotherapy using betadine iodine. And one successful lab fenestration has also been done at our center. With that, I come to the end of my presentation. I'll be happy to answer any question at the end of the session. Thank you.
Nice presentation, Sujit. Congratulations. I would say, what is your protocol now? You said silk versus bipolar sealing of the lymphatics there. What is your protocol now?
Sorry, I didn't get that.
No, what is your protocol now? You had a study where you did silk ligation of the lymphatics, and on some group you did a bipolar sealing of the lymphatics, which are there around the hilum. So what is your adopted protocol now? You continue to still continuing the study, or you're adopted to one protocol now?
No, so we've gone back to the traditional silk ligation because it did not show any improvement in outcome. The bipolar device.
No, don't you think that it is going to be much easier to do it with bipolar device than silk ligature? If you look at your laparoscopic donor nephrectomy, which has replaced every part of anything else, where everything is done by bipolar way, why do you resort to a silk ligation when it has not shown any better or you're inferior when compared to bipolar?
Yes, sir. We did find the time saved was significantly more during the bipolar device use. But we're still in the initial phase of the study. We will continue this. For the time being, we prefer silk ligations.
Yeah, that's a good study, dear. I think I don't think anybody would do, but only you got a big volume of patients now being done by laparoscopic way, where they are adopting only to the bipolar way, not about a silk ligature. But it has not shown an increase in the incidence of lymphocyte just because you're doing it laparoscopically. That itself suggests possibly these two entities may not make much a difference regarding incidence of lymphocyte is concerned. But anyway, your study is going to be of a great help in future too. Ajay, you want to have a comment on that?
No, sir. I'm fine with that. And for me, ligation is the way of reducing lymphocyte incidence. That is what I believe, and that is what we practice.
Yes, ligation, it appears, you see, as Sujit was talking very clearly, not only in the donor, but in the recipient too. Majority of the times people give a lot of importance to the ligation in the donor and they least bother about the recipient, wherein in fact I would say I would rate the recipient is more important than the donor, rather which majority of the times are not really taken keenly interest on. Would you accept it, Tawhid, what I said? You're muted here. Yeah.
I just add one thing. Just very limited dissection over the vessels. That is very important in recipient. Where just only the site of anastomosis site, you should, if you dissect only that site, that is minimize the chance of lymphocyte formation or lymphoria in the recipient. And the other things in the donor side, in our center, we do practice the most of the cases, we do the open donor nephrectomy. So we usually coagulate with the diathermy. And if there is a major lymphatic vessel, then we ligate it with the silk or bicril.
That's exactly there. See, the very fact that laparoscopic donor nephrectomy has not increased the incidence of lymphocytes itself means that the importance of retaining the lymphatics, ligating and preserving the lymphatic channels in the recipient takes a very, very important step when compared to donor, not donor alone, but even recipient is very, very important. Let's go on to the next presentation. That is, that's a debate point of view. Do we need what Ramesh was talking just now? Do we need a DTPA renogram being done for every donor to decide which kidney to be taken, which need to be left in the donor, and which need to be taken to the recipient? There is a debate between Sujit and Ajay, two senior guys on this, and yes, that is Sujit. Let us listen to Sujit first, and then go back to Ajay later. Sujit.
Good afternoon, everyone. I will be speaking for the statement need of TTPA for pre-transplant donor evaluation. So isn't it straightforward? A big yes to the statement. Let's see. So donors are not patients. We all agree with this statement. They are healthy individuals. So they should be investigated from every aspect, and there's no place for the error. We shouldn't create patients out of them. So our goal is to ensure donor lives a healthy life despite donor nephrectomy. So GFR is an important parameter during donor evaluation. Why? We all know it has direct impact on donor as well as recipient. So there's a study by Join et al. Which has compared 1901 kidney donors with around 32,000 healthy matched controls, and they have found that at 15 years, end-stage kidney disease was 0.5% in donors compared to 0.07% in non-donors, with hazard ratio of around 11.9. So what they concluded, kidney donors at increased long-term risk for end-stage kidney disease, cardiovascular and all-cause mortality compared to non-donors. Similarly, a study by Muzale compared kidney donors with non-donors, and similarly, they have found that end-stage kidney disease at 15 years to be 30.8 per 10,000 in donors compared to 3.9 per 10,000 in healthy non-donors, with risks attributable to donation 26.9 per 10,000. So on the study by Grams, they have shown that with presence of lower GFR, and as the donors tend to be younger with additional risk factors, there's higher risks of end-stage kidney disease. So GFR is very important parameter, and so British Transplant Society have given GFR threshold according to age and sex for donation. Similarly, GFR has a direct impact on graft outcome as well. Graft survival tends to be worse when pre-donation measured GFR was lower. So there are different GFR determination techniques. One is measured GFR with DTP, which we all are using most of the time. Other are measured creatinine clearance and estimated GFR. So coming to their accuracies, inulin clearance, we all know it's the gold standard. Then followed by EDTA, DTPA, and measured creatinine clearance and estimated GFR are the least accurate. Why? Purini et al. Has studied 70 studies comparing estimated GFR with measured GFR. So they have found that estimated GFR often differed from measured GFR by more than 30%. And these errors are unpredictable and comparable for both equations based on creatinine and cystatin C. So what was their conclusion? Estimated GFR was unreliable tool to assess renal function in health and disease, as well as in clinical practice and research. Similarly, a systemic review by Sober et al., they have found that endogenous creatinine clearance was the inaccurate method with strong evidence. So why TTPA? It's obvious. Estimated GFR by creatinine clearance is not equal to measured GFR, which is more accurate. And we also can determine split renal function from DTPA, such that kidney with lower function can be donated, and it's a guide to potential donors and recipients of the anticipated level of the kidney function after donation. Similarly, Suker et al. Has studied the role of DTPA in selecting the site for donor nephrectomy. They have evaluated 300 donors, and they have found significant difference in clearance value between kidneys to be 6 ml per minute, which is around 5% of the average GFR. And this difference was expected in about 40% of the healthy individuals, which is quite high. So split renal function should be integral part of the evaluation of potential kidney donors, they have highlighted. Similarly, on the study, they have studied the split renal function and its impact on outcome in donor, considering the difference to be considering the 10% difference to be significant. And they have found donors who donated the better functioning kidney have poorer renal function after donation. So at last, what KDIGO 2017 guidelines have to say? Whenever there is available, measured GFR should be taken. If it's not only available, other parameters should be taken. And on the thing, they have stated that whenever there is difference in function of 10%, more severely affected kidneys should be used for donation. So to conclude, a big yes to DTPA for pre-transplant donor evaluation, and donors should be provided the best option available. Thank you.
Wonderful, Sujit. Let us know why Ajay doesn't want to do a DTPA. Ajay, are you ready with it? Ajay?
Sir, my presentation has been recorded and submitted.
Yeah, I know. There must be. The studio must be on. Can we have Ajay's presentation, please? Yeah.
So, respected teachers and dear friends, good afternoon. Please allow me to state the obvious. Isotope scan is not essential in preoperative evaluation of a living kidney donor. Let us see how and why. When we investigate a donor, our aim is to estimate the total GFR, measure the split renal function, and assess vascular and collecting system anatomy. Another aim is to leave a better kidney with donor while giving an adequate renal function to the recipient. At the same time, assuring the donor of adequate renal function after donor nephrectomy. Donor undergoes a majority of investigations out of these, and CT scan is always done. So why not use it to measure the function also? Is it possible? Let us see. Nuclear scintigraphy has many potential sources of error. User-dependent marking of region of interest, significant error due to attenuation of gamma rays in tissue, variations in depth of the kidneys can reduce accuracy, so much so that the influence of left versus right kidney depth variation can lead to a change in the side selected. Moreover, there is no universal cutoff value for nuclear split renal function in evaluation of living renal donors. Moreover, it does not predict the extent of adaptive changes in renal structure and function in healthy subjects with reduced renal mass following unilateral nephrectomy. And of course, calibration of unit also gives rise to more than 5 to 7% of variation. Well, CT scan is always done because it provides a wealth of information about function and anatomy. Question is, can it provide satisfactory information about GFR? Let us see why the answer is yes. This study did a pre and post donation measurement of renal function by inulin clearance and also assessed the predictive value of CT volumetry versus DTPA, and splendidly concluded that CT volumetry can replace preoperative examination for renal function by DTPA. Apart from providing a goldmine of information, CT also measures GFR accurately. I would say as accurate as isotope GFR. Then why do we want an isotope scan? I shall not go into technical details for want of time, but there is a mathematical correlation between CT contrast clearance and measured GFR, as you can see here. Moreover, there are certain advantages of CT scan over renal scintigraphy. Background activity has been the bane of nuclear scintigraphy, and CT scan definitely overcomes this challenge. It also correlates well with split renal function on DTPA. It is a better predictor of renal function at 1 year post-nephrectomy. It gives you reduced burden of investigation for living kidney donors and significant cost savings for organization or donors. Of course, it gives brilliant depiction of anatomic variations of the kidney. There are 3 main techniques of renal volumetry. Of them, renal cortical volumetry is the best, which shows agreement between CT volumetry split renal function and MAC3 split renal function. Then why do we do radioisotope scan? This is a study of 105 donors. It concluded that total kidney volume was significantly associated with pre-donation measured GFR. Not only that, it shows preserved kidney volume was also strongly correlated with post-donation measured GFR. It was the first study to look at correlation of CT volumetry with GFR and post-donation residual function. Friends, when I counsel a donor, I need to assure him about the post-donation residual renal function. Well, CT scan is a better tool to do that. This is a study which concluded that post-donation eGFR correlated with split renal function measured by MAC3 or CT volumetry. Measuring kidney volume by CT volumetry is a cost-effective alternative to MAC3 for evaluating split renal function and predicting post-operative donor renal function. So here you are. CT gives you the complete set of information, not only anatomy, but function as well as split renal function. These are 2 quite interesting studies from which I note that CT-based volumetry and depth led to a side change of selected kidney in significant number of renal donors, living donors. So, to conclude, CT scan is not only essential, but it is also better in many aspects. Thank you. So,
not planned any rebuttal. Let me understand. You see, in the last 30 years, we have seen an era wherein we were doing a donor nephrectomy based on an IVP and a traditional angio to understand the arterial anatomy. And we have evolved over a period of time to do a CT angiogram, which are very beautiful now. And that itself gives the anatomy of the pelvic calyceal system. And now we are splitting the functional studies into the each kidney, whether CT can be made better or a DTPA can be made better. Well, it appears that DTPA is reserved in some situations wherein whenever we have a doubt or there is any change or any question which is there, the routine use of DTPA has not been very popularized of late, but some centers are routinely doing it. Ramesh, do you do a routine DTPA in these cases?
Yes, all our donor workup includes a DTPA scan, and it's only based on the better functioning kidney that is left with the donor. That is the way we choose our donors.
That's
exactly the protocol we follow in our.
How do you?
What I agree, though, what Ajay put up a few presentation, the volumetric method of assessing the GFR is purely going to be subjective. It depends on the radiologist's interpretation of the data. So there is not too much of data available in the literature for consistently mapping out the volume and predicting the GFR based on the cortical volume. So
at the same time, there are so many fallacies of measuring the DTPA, the functional GFR on a DTPA also, which are there mentioned many a time.
Yeah, I agree. There are a lot of fallacies in even the radioisotope imaging.
Yes.
But among these 2, I think the functional assessment is doing a scintigram is far superior than doing a volumetric assessment.
Tauhid, you want to have a comment?
Yeah, my comment is the CT urogram and CT angiogram is very much essential for evaluating of a donor in the live related or unrelated session, because you know the anatomy, you know the vessel, you know the ureter, either it is single or double, you will see the volume, but you cannot say the differential function of the kidney. So for the differential function of the kidney, you must do the DTPA renogram, isotope renogram, and that is evidence-based. You can counsel the patient attendance. So this is a 55 ml GFR and this is 46 ml GFR. So we decide to harvest the 46 ml GFR. So this is one way. This is adjunct. Dr. Ajoy said that he well said the volumetric assessment of the ultrasound, CT. That is okay. But the CT cannot say the differential function of the both either kidney. So for decision to take the kidney and appropriate counseling of the recipient and donor and other members of the transplant team, as it is not only a transplant surgeon, it is nephrologist, and there is very major part. So you can rather do that. It is not too much costly, and it is available in every district town now.
Had it been very expensive, we would have not been discussing it. It has become cheap. That's the reason why we are discussing it. Once upon a time, it was not available and was expensive and had to go around for long distance to get it done. So nobody got it done. Now it is cheap, readily available. So we are discussing whether to get it done routinely or not. But I think there is an element of subjective assessment, subject to variability of assessment, both in DTPA and the CT volumetric analysis of the thing. I don't deny that fact. But we need to evolve. We saw IVPs and did donor nephrectomies once upon a time, and we never had DTPS at that point. And then we went ahead and did it. We take last comments from Ajay, what he says, and we were looking at the other speaker who was there.
So I want to make two comments here.
Yeah, go ahead.
Sir, if you compare the subjectivity of CT scan versus DTPS scan, the subjectivity is more in DTPS scan. Second, CT scan is available at every taluka place in India now. But DTPS scan, it is available only at regional headquarters. It is not yet available at taluka level in India at least.
No, I understand. You see, that's exactly what I'm trying to say. It is subjective. The more the calculation, we feel it is objective, but even the calculations are based on subjective assessments there. That just because we have calculations there doesn't mean that they are objective assessments. Is Sujit there? Sujit Podial, who is the other speaker, is he there? Any comments?
Sir, there was a rebuttal in this session.
He was? That's exactly.
There is a rebuttal in this session.
Is a rebuttal there, Sujit? I am not able to see.
No, that is not mentioned in the
it's not mentioned
program.
in the.
No. Sir, we have recorded rebuttal. I have recorded my rebuttal.
Okay, where is Sujit? Is Sujit there?
Yes, sir. There is rebuttal, so I'll request
go ahead,
technical team to clear that.
Okay, go ahead, please.
Listen to the rebuttal now.
We want to see and hear.
And conclude the session.
So, Dr.
But in the program, it is not mentioned.
CT volumetry for determining GFR and split function. But I have some questions for him. Can CT volumetry give accurate GFR? It only measures the quantity and size of enhancing nephrons along with tissue other than the nephrons. It doesn't show the quality of the nephrons. So there are only few studies showing the correlation between CT volumetry and GFR. So I cannot say CT volumetry reliably gives accurate GFR. So another question is, can it match DTP renogram, which has been studied and used for decades to measure GFR? Obviously, no. There are studies highlighting the role of CT volumetry for measuring GFR, only few studies, but DTP studied for decades, and we are using it routinely. So we cannot replace DTP with CT volumetry for measuring GFR. And what about split renal function? There are only few studies coming up which shows the role of CT volumetry for split renal function. And most of these studies are retrospective. So we still cannot say CT volumetry can give reliable split renal function. So I would like to start with the meta-analysis. Recent meta-analysis given by Hebus et al. And they have clearly stated for every 100 CT volumetric examinations performed, 14 would be false negative. That would result in the wrong kidney being chosen. There is still 14% error. Can we accept 14% error in donors? Probably not. The meta-analysis has given other conclusions like split renal volume and split renal function did not correlate reliably and routinely across different transplant centers. Even in our center, split renal volume has weak correlation with split renal function. And another thing is its impact on clinical decision making needs to be assessed. Has still to be proven. So I want to say CT volumetry still has to prove more before it is used in donors. Thank you.
Thank you, Sujit. Let us go to Ajay's presentation. Rebuttal of Ajay. As fast as you can, please. We are exceeded by 3-4 minutes. Is Vikas Jain there for the expert comments? Are you here, Vikas?
I think his rebuttal was pre-recorded.
Yeah, I know. I just want Vikas to give the last. Okay, go ahead, Ajay.
So I agree with my friend Dr. Sujit totally that we should measure GFR of the donor and we should leave better kidney for the donor. But what is the method to do that? In my humble opinion, nuclear medicine is unclear medicine. Let us see how. This is the DTPA scan of same donor. This is the first scan in which there is a significant difference between right and left kidney split GFR. And total GFR is excellent. But this significant difference in split renal function made me do another DTPA scan from another lab. And lo and behold, he has equivalent GFR on each side, but the total GFR is significantly less as compared to this GFR. If this is not unclear medicine, Dr. Sujit, please explain to me what is unclear medicine. Well, in our part of the world, economics is crucial. We need to tailor the workup according to economics. Moreover, nuclear scintigraphy has pitfalls. It is extremely user dependent. There are errors galore. There is depth variation. There is too much of normal variation on nuclear split renal function and measured GFR. And DTPA doesn't answer the question of post-donation residual function. And of course, machines are not calibrated as good as they should be. So, in conclusion, when GFR is there to provide you all the information, especially the total GFR, the split renal function, and the post-donation residual function, why do you need a DTPA scan? Thanks.
Thank you, Ajay. I think it's a wonderful discussion. We leave the options for the House to decide whether to do a DTPA routinely or not. It is still a very dicey topic. Wherever it is available, it is being done. Do you have Vikas there? Vikas is logged or not?
So Vikas' presentation is also recorded.
Is it?
Yeah.
Vikas? Okay, last. I think that we'll end the session after.
Good afternoon to all of you. Thanks, Dr. Pawan and the organizing committee for giving me this opportunity to give my comments on this topic called need of DTPA for transplant realization. I'll just use one slide to support my comments. Is why do I order an investigations? Whenever I'm ordering an investigation for a patient or even a donor, I have these few things in my mind. Is it going to change my management or treatment plan? Is there any alternative investigation available which can actually give me the same information as the investigation that I'm going to order? Is it harmful for the patient? For example, if you want to do a contrast CT in a patient who has got a serum creatinine of 1.6 or 1.8, then what is the cost involved and what is the availability of that particular investigations? So if I go from below upwards, availability of DTPA scan, which we are debating today, is not a problem anymore. It is an easily available investigation, and it's freely available. The cost involved, I don't think it's much of a cost involved in a surgery like transplant, where we are operating on two different patients. I feel the cost in a city like Delhi, it's around 4,500 rupees. The cost, I don't think, is an issue to any one of us. Is it harmful for the patient? Are we giving any contrast which is going to hamper his renal function or something like that? The answer to this is no. It is very safe investigation and does not cause any significant side effects or complications. Is there any alternative? As Dr. Oswald clearly mentioned, that CT is a good alternative to DTPA scan. Agreed with him to some extent that it gives can give you a good estimation of GFR, but to calculate split GFR, it is, I don't think, a very good investigation. CT has got its own pitfalls. And is it going to change my management and treatment plan? I think both of them have agreed that split GFR will ultimately change our treatment and management plan. And so many times we have changed our plan based on the split GFR. In my opinion, if it is available and it's available, I think we should do a DTPA renogram. It has been a standard of care, and all of us have been using for years together. My opinion, my comment is DTPA scan should be standard of care for the pre-operative evaluation of a donor. Thank you so much.
Thank you, Vikas. I think we have over exceeded the time by 5 minutes. Thank you, the South Association, for this opportunity for all of us to participate. Thanks from Tawheed. Thanks from the rest of the participants who have shared it. Thank you very much.
Thank you, Dr. Mallikarjun, Dr. Toyib Hussain, and Dr. Ajay for chairing this session. We'll continue with the South program, and we have a concluding session. I invite the General Secretary of the South, Dr. Pawan Chalise, to give remarks on the activity of the South.
Thank you, Dr. Mahesh Bahadur Adhikari, Scientific Chairman of the UROCON 2021 and Scientific Coordinator of the Second South Congress as well. Indeed, takes us a great pleasure to thank all of you, especially thanks to President, General Secretary, and all the executive office bearer of Urological Association from South Asian countries. We had a 4 session today. We have the very exhaustive scientific list, but we will be able to finish it on time. I'm very thankful to the conveners of the session, chairperson of the session, and I will also like to thank the speaker of this session and all the participants. In the morning, we started with inaugural session, a small inaugural session, and we should be thankful to our chief guest of honor for the inaugural session, our Secretary General of SARC, His Excellency Mr. Isal Arwan UROCON. We sat with him for few minutes after the inaugural session, and he has assured that looking at all our enthusiasm, he has assured that this South will soon be getting the legal ground from the SARC Secretariat. I'm also thankful to the executive team of SARC, South Asian Association of Urological Surgeons, and all this credit goes to the visionary leadership of Dr. Madhu S. Agrawal and Dr. Rajiv TP, who extend his apology because of his ill health today. You could not attend the session, but I'm also thankful to the UROCON 2021 organizer. Especially, I would like to thank President of NAUS, Professor C.S. Agrawal, and Vice President and Scientific Chair of UROCON 2021, Mahesh Bahadur Adhikari. These are a few of the pictures that we started. I would like to mention that the registration process of this newly formed association is already been started, and the process started from the registering it in Nepal as a South Asian Urological Association as per the Nepalese rule and regulation. After that, we need to move forward to the Ministry of Foreign Affairs to get the SARC recognition, and I'm already in contact with the SARC Secretariat and meeting all the directors and responsible person to get it done. If you go to the SARC website, we can see there are many associations that has been registered as a recognized bodies. There are also medical associations like SARC Academy of Ophthalmology, SARC Surgical Care Society, SARC Dermatology Association. They all are already had a recognized status, and I'm sure this Urological Association, we are also going to get this recognition. We should be very thankful to the Director of Human Resource Development, current Human Resource Development Director from Afghanistan, Fazul Rahman Rahmani. He is the one who is taking lead, and he assured us that we'll get this status soon. So in this small breakfast meeting today in the morning, we discussed a lot about our association and how to go ahead and get a legal ground. So with this, I think that the NOWS and all other urological association in the South Asian region will take this leadership to have a common platform in the South Asian countries. And I'm sure as the SARC Secretariat is in Kathmandu, the NOWS will take the leadership to get its legal formalities completed. Thank you, sir. And again, thanks to all the participants for bearing with us. Thank you.
Dr. Madhu and Dr. Rajiv Tipi is not available. So I would like to request the President of NOWS, Dr. C.S. Agrawal, to finally conclude this SARC session.
Thank you, Mahesh. First of all, I would like to thank the House for giving NOWS the opportunity to host this conference. We are about to close this session. And once again, I would like to thank all the conveners, all the chairpersons, all the speakers for their valuable inputs. In the last, all the participants who has joined us virtually or really. And I declare the SARC session closed. Thank you very much.
Any sufficient advanced technology is indistinguishable from magic. Being medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make urology surgery familiar with the generation of latest innovative technology in the field of urology, bringing loving care to healthcare. Any sufficient advanced technology is indistinguishable from magic. Being medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make urology surgery familiar with the generation of latest innovative technology in the field of urology, bringing loving care to healthcare. Any sufficient advanced technology.
The intensive care unit
It's a place where patients believe they get well. But it is also a place where dangerous infections lurk. There are multiple causes of hospital-acquired infections, one of which is the use of infusion systems. Infusion systems are an important part of overall surgical and ICU care. These systems are either open or closed. Examples of open infusion systems include glass and plastic bottles, while that of closed systems include intravenous bags. Research has revealed that open infusion systems are more prone to increasing the risk of hospital-acquired infections. Closed infusion systems are superior to open systems in preventing hospital-acquired infections. Hence, it is now time to break this chain of hospital-acquired infections. Fresenius Kabi has pioneered 100 years of excellence in clinical nutrition and volume therapy products. It is recognized by European regulatory authorities for promoting good manufacturing practices. The intensive care unit. It's a place where patients believe they get well. But But it is also a place where dangerous infections lurk. There are multiple causes of hospital-acquired infections, one of which is the use of infusion systems. Infusion systems are an important part of overall surgical and ICU care. These systems are either open or closed. Examples of open infusion systems include glass and plastic bottles, while that of closed systems include intravenous bags. Research has revealed that open infusion systems are more prone to increasing the risk of hospital-acquired infections. Closed infusion systems are superior to open systems in preventing hospital-acquired infections. Hence, it is now time to break this chain of hospital-acquired infections. Fresenius Kabi has pioneered 100 years of excellence in clinical nutrition and volume therapy products. It is recognized by European regulatory authorities for promoting good manufacturing practices. Introducing the new innovation from the leaders in volume therapy worldwide, FreeFlex, the DEHP-free, non-PVC, environment-friendly solution to infusion therapy. Innovative injection port. Rigid injection port ensures the safe connection, prevention of needle stick injuries and damaging of the bag during drug reconstitution. Self-sealing septum in the injection port to prevent leakage after removal of the syringe. Sterilized at 121 degrees centigrade within the overwrap to maintain sterility until the bag is opened. Environmentally friendly compared to PVC bag.
Hi, thank you. Hello. Dear faculties and delegates, now it's almost 1:30 Nepalese Standard Time. Soon our uro-oncology session is going to start. At the outset, I would like to welcome all the faculties and delegates to this forum, both virtually and very, very limited physically. As the theme of our conference is Uro-oncology expanding the horizon, we wanted to reach to many experts in the world. We have eminent faculties from India, then Egypt, not only from there, from Australia, and from Italy also. So for coming approximately 3 hours, the time will be dedicated for uro-oncology. Please stay with us. Soon we'll be starting the session.
Rigid injection port ensures the safe connection, prevention of needle stick injuries, and damaging of the bag during drug reconstitution. Self-sealing septum in the injection port to prevent leakage after removal of the syringe. Sterilized at 121 degrees centigrade within the overwrap to maintain sterility until the bag is opened. Environmentally friendly compared to PVC bags. Easy handling infusion. Check the solution composition, lot number and expiry date. Inspect the container for damage or leakage. If damaged, do not use. Use opening aid to remove overwrap. Identify the blue infusion port. Break off the blue tamper-evident cover from the free flex infusion port. Membrane below cover is sterile. Disinfection of the membrane is not necessary. Insert the spike until the clear plastic collar of the port meets the shoulder of the spike. Use a non-vented set or closed air inlet. The self-sealing septum, which is a unique feature in free-flex bags, prevents leakage of the fluid, even as the bag is repeatedly spiked. Hang the bag on the infusion stand. Connect and adjust the flow rate. Easy handling. Drug preparation with a syringe. Use opening aid to remove overwrap. Identify the white injection port. Break off the white tamper-evident cover from the free-flex injection port. Transfer drug from the syringe into the free-flex bag. Use 18 to 23 gauge needles. Mark the injection port with a red cap.
Dear friends and faculties, soon our uro-oncology session is going to start. I would like to welcome myself is Dr. Bhojraj. I am the convener, one of the conveners for this uro-oncology session, and I have my friend and senior brother also, Dr. Nirmal Lamisane from Bharatpur Cancer Hospital. You'll be with me for coming these 3-4 uro-onco dedicated sessions. Without much wastage of the time and proceedings, we'll start with thematic talk. As the theme of this conference is uro-oncology expanding the horizon, we all of us know that uro-oncology in Nepal is in toddler stage and we want to go up with combined effort and team effort. So thematic lecture will be given by Dr. Nirmal Lamisane. He's a consultant uro-oncologist at BP Koirala Memorial Cancer Hospital, Bharatpur, Nepal. He's one of the urologists in Nepal who has helped to modernize the uro-oncology service and to expand the uro-oncology service in Nepal. I have great pleasure to invite him to give a thematic talk on uro-oncology in Nepal, past, present, and future. We'll be playing the pre-recorded video. We'll go ahead. Thank you very much.
Respected chairpersons, audience is present physically as well as virtually in this UROCON 2021. I'm going to present on urological malignancies, past, present, and future in Nepalese perspective. In early 1970s, urology was a part of general surgery, and many general surgeons tackle urological and uro-oncological patients as per concept of treatment that prevailed then. During the last 40 years, uro-oncology as a subspecialty has slowly and steadily evolved, and a lot of urologists are getting interested in this subspecialty. At the same time, uro-oncology remains affiliated to the urology, the parent specialty. I acknowledge here the pioneer general surgeons and urologists for taking uro-oncology services to the highest standard when they started in this country. At the meantime, they are indebted for starting Indo-urology in uro-oncology as part of the world timeline. At the meantime, it's their effort to start NOWs and other professional forums for academic discussions to foster the science of urology and the uro-oncology is a particular. Streamlining of urology subspecialties occurred after the establishment of NOWs in 2005. At the meantime, different fellowships and MCS programs started in the country, and the urology oncology practice evolved and developed in due course of time. I would be categorically talking about the imaging facilities, treatment facilities, and some newer things in this talk. Evolution of newer imaging techniques over the years has not only made early diagnosis of cancer possible, but also helped in planning the therapy with improved survivals. Ultrasound emerged as a great tool. Ultrasonography became available in around 1980 and was a significant landmark and was of major help to image urinary tract. Detecting renal masses, testicular tumors, and prostatic lesion was possible with ease, and the routine USG of abdomen found a lot of incidental renal tumors, and these are being treated early. In the meantime, transrectal ultrasound for prostate imaging has become an important supportive investigation for carcinoma of prostate. CT scan similarly became available in around 1982, which was a major breakthrough in imaging any part of the body since total body could be scanned with thin slices in coronal as well as in sagittal fashion. It is widely used in primary disease workup, metastatic workup, and angiographic planning of nephro-sparing surgery in oncology. MRI became available in around 1986, and it's very useful in bladder and prostate cancer. And we know that PIRADS and VIRADS are as good as histology diagnosis most of the time. Nuclear medicine, which was introduced in medicine in 1960, and is very useful in detecting skeletal metastasis from urological cancers, and it is also useful in measuring the renal functions in improvised renal status. PET scan is one of the latest addition to the armamentarium of imaging modalities. A combination of functional and anatomical imaging to detect distant metastasis has been an ultimate investigation to scan the entire body for possible spread of disease. It became available in around 2005 with dedicated machine available from 2007 and is now being widely used in oncological arena. USG or CT guided needle biopsy with their help to reach the histological diagnosis. And the MR fusion biopsy is quite common for difficultly accessible prostate cancer biopsies. Talking about tumor markers, in around 1980, PSA became available, though in Nepal it took some time for the laboratories to have it done in standardized fashion. PSA with its different fractionated components has become an important tool to make early diagnosis in prostate cancers. Other extremely useful biomarkers like alpha-fetoprotein and beta-HCG also became available in 1980s, and initial enthusiasm for using NMP22 as a marker for bladder cancer for initial diagnosis as well as for detecting recurrences has held its ground over the years. Treatment strategy-wise, in around 1970, the treatment planning took into consideration of local regional spread of disease, and hence there was a clear consensus about radical nephrectomy and doing a radical cystectomy, which essentially included thorough dissection of the draining nodes from retroperitoneal or from pelvic area. But now, for example, bladder cancer, non-muscle invasive bladder cancer and muscle invasive bladder cancer are categorically differentiated. And non-muscle invasive bladder cancers, transurethral resection and intravesical treatment of some sort suffices. But for muscle invasive bladder cancer, cystectomy and pelvic lymph node dissection is carried out. Trimodal therapy for muscle invasive bladder cancer is also being evaluated, and role of neoadjuvant chemotherapy has become definite and is being widely used nowadays. I would like to briefly mention about the stomach care here. Our stomach clinic was established in Patna Hospital in the 90s and in BBKMCH in 2002. And a stomach care clinic provides total stomach care, including preoperative counseling, stomach marking, providing urinary collection bags, as well as postoperative stomach care. And this stomach today they are from 80. The routine role in for them, bilateral orchidectomy was the standard of uniform treatment. For patients with bone pain, focused radiation therapy was being given with a suprapubic cystectomy for urinary obstruction. With the help of PSA assays, transrectal ultrasound, and increased awareness in population, there is increase in rise of the early stage diseases in Western world. And this pick up quickly in the Western world, and radical prostatectomies were done in USA, Gallup from 1982 onwards. The first reports of high volume radical prostatectomies were coming from Johns Hopkins and Mayo Clinic. And since then, radical prostatectomy for patients with organ-confined prostate cancer has become a routine procedure. Penile and testicular cancers are also commonly seen in our part of the world, and surgery in the form of partial penectomy and inguinal lymph node dissection for penile cancer and transinguinal orchidectomy and RPLND in select cases in testicular cancers is possible in our country. Talking about oncology, we cannot not mention about the radiation therapy. The radiation therapy was another modality to treat cancer patients with conventional machines like cobalt-60, deep X-ray available in those days with a palliative intent, especially in muscle invasive bladder cancers and large retroperitoneal metastatic lymph nodes. And the radiation therapy, however, plays a limited role in urological oncology and is preferred in select patients with seminoma, is a part of bladder preservation protocols for muscle invasive bladder cancer and for selective prostate cancer patients. Chemotherapy, this modality to treat cancer was in its infancy in around 1970 and was hardly used in urological. The prime objective of cancer control shifted from control of local regional disease to subclinical or evident systemic control. TC has changed the scenario. With further trials with less toxic combination of drugs, improved survival rates were reported when used in the neoadjuvant or in the adjuvant fashion along with the surgery or radiation therapy. Nowadays, there is another entity in the treatment of cancer called as targeted and immune therapy. In recent years, the concept of molecular targeted therapy has evolved with many agents available for various cancers. The tyrosine kinase inhibitors and angiogenesis inhibitors for renal cell carcinoma have shown encouraging results. At the meantime, the understanding of tumor biological features has led us to the use of atezolizumab and pembrolizumab has shown a great results like 23% overall response rate for 15.9 months in a cisplatin ineligible groups. You can see how useful these are. Nowadays, in practice of oncology, international guidelines like CNCCN, EUA, NICE are widely being used and adopted in the management of urological cancers as well. A case discussed in multidisciplinary tumor board meetings helps to decide what would be the most beneficial for this particular patient. At the meantime, the cost-benefit ratio, side effects of therapy, additional survival benefits at the cost of impaired quality of life are extremely important factors that must be taken into consideration while embarking on the treatment. To deliver optimal and high quality treatment with improved outcomes as opposed to those who are treating a wide spectrum of urological diseases. It is most essential at this stage that we carry out randomized clinical trials in our patient, since the patient population from the Western world may be different from one in Nepal. Department of Urological Oncology at large institutions can take up the challenge to script the management guidelines for our patients. So coming to us, so more and more nephron-sparing surgeries and more and more use of targeted and immunotherapy in the uro-oncology. Talking about management of cancer, we have to know what is the burden of these diseases in our society. Cancer registry helps us to show the idea about these things. And from the inception of this BP Memorial Cancer Hospital, we have cancer registry, essentially hospital-based cancer registry and population-based cancer registry. Hospital-based cancer registry essentially consists of major hospitals of Nepal, major 12 hospitals of Nepal, and a population-based cancer registry covers 14 districts around the Chittagong district. If you see this script of urological cancers from the HBCR 2015, you see bladder cancers. Total of bladder cancers were 222, kidney cancer was 126, prostate cancer was 91, and penile cancer was 63. Category and carcinoma of prostate falls in the 10th category. If you categorically see top cancers in male, so you can see the burden. Bladder 172 and prostate 106. This is the data from the 2015 for 14 surrounding districts. If you see the data from population-based cancer registry detailed by NHRC in Kathmandu area, you can see the carcinoma of urinary bladder is the 4th most common cancer in Kathmandu Valley in male patients. So from these two slides, you can guess that urinary bladder cancer, prostate cancer, or per se the urological malignancies are the most common cancer in Nepali population. How do our health system delivery occurs? There are central hospitals, regional hospitals, and the specialist hospitals from the government side. At the meantime, there are large hospitals and medical colleges from the private sectors. So I would conclude urological malignancies in a male is among the 10 most common cancer. Regional and above level hospitals should be able to cater urological oncology care for the sake of its commonness. At the meantime, now subspecialty committee dedicated to uro-oncology will be helpful in guideline formation and policy influence to promote the uro-oncology care in this country. With this, I would conclude my talk, and I thank you for your patience. Thank you.
Thank you very much, Dr. Nirmal Lamisane, my co-convener, for delivering a very, very balanced talk on thematic lecture on uro-oncology in Nepal, past, present, and future. Uro-oncology can be prosperous by help of multi-specialty, radiation oncology, immunology, and not only that, from imaging, all those things. So by the help of everyone, we can go further and we can expand our horizons. So this uro-oncology session have been divided into 4 sessions. First 2 sessions are dedicated for RCC, localized RCC, then second session is locally advanced and metastatic RCC. The third one is about carcinoma prostate, and fourth one is carcinoma of the bladder session. So without much delay, I would like to invite the chairpersons for the first session that will be more focused on the localized renal cell carcinoma. I would like to invite Professor Chandrasekhar Agrawal, President of NAUS, Dr. Mahesh Bahadur Adhikari, Vice President of NAUS, and Dr. Pawanraj Chalise, General Secretary of Nepal Association of Urological Surgeons, to chair the session. Up to you, sir, chairpersons. Thank you very much, sir.
So now we are going to start the first session, that is on localized RCC. And Dr. Uttam Sharma will be talking about open partial nephrectomy. Dr. Uttam does not need any introduction. We all are familiar. He is heading the Department of Urology and Transplant at TUTH Hospital. Dr. Uttam Sharma, please.
Respected chairpersons, I'm going to talk on open partial nephrectomy its tips and tricks. So there are a lot of indications for T1 renal tumors. Whenever it is feasible that we have to do for the T1 renal tumors, even in the absence of identifiable renal insufficiency or its threat. There are indications for the solitary kidney, bilateral or familial renal tumors, or chronic renal insufficiency, in whom radical nephrectomy would result in dependence on dialysis. So EAU guidelines in 2020 says strongly that larger complex mass has to be open approach is the safest one. Do not perform minimally invasive surgery if this approach, which compromises the oncological, functional, and perioperative outcomes. So perioperative preparations and evaluation has to be done. Imaging is the hallmark that we have to do. Imaging to delineate relevant regional anatomy, intrarenal anatomy, and vasculature to minimize blood loss and damage to adjacent renal parenchyma. As we know that there is cardiac, pulmonary, and renal evaluation has to be done. Urine should be sterile and the patient has to be properly hydrated. So the CT abdomen angiogram with urography has to be done to delineate the anatomy and the planning for the surgery. For the planning for the surgery, nephrometry and anatomical complexity has to be in our mind for the better preoperative planning and counseling to the patient, and reliable comparisons of morbidity rates among the different techniques, surgeons, and institutions. This nephrometry correlates well with ischemia time, complications, and pathology, which we can compare later on for our own sake. So there are different types of nephrometry scores like renal, Padua, preoperative aspects and dimension used for anatomical classifications, centrality index, risk of surgical complications score, DAP, diameter axial polar. Different types of nephrometry scores has come to the market. So whichever is suitable for the surgeons can use. We have been using renal nephrometry scores. The principles of doing open partial nephrectomy is surgical approach. It has to be good exposure. The vascular control and mobilization of the kidney is the prime thing. Complete excision of the tumor with maximal preservation of normal parenchyma and minimization of the ischemic injury is the hallmark of open surgery. Renotherapy, hemostasis, watertight closure of the collecting system, and repair of the renal defect is very, very essential. Selective use of disease stenting, which can be done before incision or during intraoperative period also can be done. And drain placement, we usually, in almost all cases, we put it. So the open approach, the incisions, it depends on the position of the kidney in relation to the ribs and the location and size of the tumor. It could be supra or subcostal flank incision, thoracoabdominal incision, upper polar tumors, which will accessible through above, anterior subcostal can be given. The mobilization of the kidney and vascular control is very, very important, and mobilization of uninvolved portion of the kidney with the renal fat overlying the tumor is undisturbed so far, and identification, dissection, and non-occlusive control of the renal artery and vein with basal lobes, and identification of ureter for the future maneuver. So this picture shows mobilization of the kidney and exposing tumor site, and vascular pedicles are taken in control, and tumor excision can be done either in the fully perfused kidney or with vascular clamping. The vascular clamping, it gives the reduced intraoperative bleeding, improved visualization, and reduction in renal tissue turgor. Improves the access to the intrarenal structures also, so with the vascular clamping. Renal hypothermia, if clamping is employed, will be easier, and ischemic time can be little bit prolonged. Different clamping techniques are there. There is artery vein clamping or the artery only clamping. Benefit of artery only clamping, particularly in cases with prolonged ischemia time, if you are expecting more than 25 minutes, but that is not desirable. Super selective versus main artery clamping. Super selective clamping does not lead to higher complication rate and may lead to better postoperative renal function in the remaining tissues. So there are which compares the renal ischemia and function after partial nephrectomy. Ischemia time is very important. Modifiable predictor of the postoperative renal function is the ischemia time. It's the benefit of keeping it within warm ischemia time in less than 25 minutes. Cold ischemia safely facilitates longer duration of ischemia. So there are the treatment plan in the perfuse or versus clamping, off clamping, or with the perfused kidney. In the meta-analysis has shown that comparable in the both cases, comparable perioperative safety in the off-clamp partial nephrectomy, equivalent oncological outcomes, and superior long-term renal function preservation. So tumor excision principles has to follow. We have to completely excise the tumor with negative margins and maximal preservation of benign adjacent parenchyma. Enucleation, polar segmental nephrectomy, transfer resections, wedge resection are other variants of partial nephrectomy. Extracorporeal partial nephrectomy with renal autotransplantation can be done in the tumor which are more in the hilar regions, and the larger one which cannot be, there is a fear of damaging the renal tissue or the vascular tissue. So we have to do autotransplantation after partial nephrectomy. So marking the margin to be resected is very essential before giving the incisions. It has to be several millimeters away from the lesions. And resection of the tumor will be done by small tenotomy scissors or the scalpel to divide the renal parenchyma. Pen-filled spatula to retract normal parenchyma from the specimen. And resection of the tumor can be, after doing the resections, small vessels is palpated with suction device. It has to be grafts, coagulated and cut. Cut should not be used deeper than the corticomedullary junction or near the collecting system for the obvious reason. Larger vessels at the base has to be ligated and cut. So calicography and hemostasis before releasing the clamps is essential. Transected blood vessels on the renal surface secured with figure of 840 absorbable sutures. Rent in the calyces can be confirmed with retrograde injection of methylene blue if we have put the ureteric catheter beforehand, or the ureteral stent may be placed through the defect or before the start of the procedure. Hemostasis is prime thing. Hemostasis after releasing the clamps, cut surfaces and hilar branches, checked for significant bleeding after releasing the clamp, and rhinography over the Surgicell's bolster. It, as it's shown in the picture, the cortical edges approximated over the bolster with simple plagiated interrupted 20 polyglactin sutures, or perirenal fat can be used for the same purpose. Suture lines should be tension-free, and the kidneys should be reconstructed in such a way that the renal pedicle is not keying. So margin of resections, the traditionally 1 centimeter margin was advocated, but for this purpose, less than 1 millimeter is safe. Even some author says that 1 cell negative margins are sufficient. Negative margin is the priority. Margins is surgeon discretion taking into the account the clinical situations, tumor characteristics, that is growth pattern, interface with the normal tissue, that is the AUA guidelines. So partial nephrectomy versus enucleations, there are a lot of papers around about this one. There is a meta-analysis showing the outcome of the partial versus enucleations. These are equivalent post-surgical margins. Cancer-specific cervical outcomes are equivalent. Saturn study or the record project all says the same thing, that there is no changes. The partial nephrectomy versus enucleations is tumor enucleation should be considered in the patient with familial RCC, multifocal diseases, or in severe CKD to optimize parenchymal mass preservations. So use of intra-op frozen sections. So there are a lot of controversy about these ones during the partial nephrectomy. There are a lot of papers, and what they have come out with some of the informations is that frozen section in partial nephrectomy is relatively high false negative rate. 6% still had positive surgical margin. It reduces the positive margin from 8.5 to 6.5, not that much significant. The controversy over the prognosis of a positive margins is still there. So we have to think about the frozen sections. Other methods of excisions is extracorporeal partial nephrectomy, as I have already said before, with re-auto transplantation of large complex tumors which are near the hilum. So in Tribhuvan University teaching hospitals, we have done 43 cases over the period of 5 years, with the age ranging up to the 56, 20 to 90 years old. Right and left are equal in number. The mean size is 3.5 plus minus 1.6 centimeter, ranging from 1 centimeter to 7 centimeter. So perioperative outcomes are mean ischemia time is within 25 minutes. Mean hospital stay was 5 to 14 days. Mean is average is 5 days, and mean hemoglobin drop was 1 gram, and transfusion, none of them needed transfusions, and the complication resulted in 3 cases in the form of pilocuteneous fistula in 2 cases. Interpolar mass was there, pellicalicial system was open, and it was managed by DJ stenting. One of the cases had superficial skin infection, which managed conservatively. Thank you very much for patience hearing. Thank you.
Patient was a 43 years old diabetic lady presented with incidentally detected left renal hilar mass. On CT evaluation, she had a left renal hilar enhancing mass 3.5 cm by 2.9 cm and left adrenal adenoma of 3 cm by 2 cm, which on metabolic evaluation was non-functional in nature. 12 mm and 5 mm laparoscopic port placements as per the picture. Left colon mobilization done. Transection of the splenorenal attachments being done. On further dissection, the adrenal adenoma was revealed. Then the renal veil isolated. Here we can see the periadrenal dissection. Adrenal adenoma with its tissue was separated from the surrounding structures and from the upper pole of the kidney. Adrenal pedicle is being controlled with ligature. Then kidney lower pole mobilization done along with the isolation of the ureter. Then further hilar dissection done. Here is the control of the lumbar vein. Then gonadal vein is isolated. It is being clipped on both the sides and was cut between the clips. Further renal hilar dissection was done to isolate the renal vessels. Here we can see a main renal artery on the left side and a accessory artery directly arising from the aorta on the right side. Further dissection is done to make a space for the application of the clamps. The aorta is being dissected out from the renal parenchyma. We can see the demarcation of the renal mass. The mass is being demarcated with a monopolar cautery hook. We had no facility of the intraoperative ultrasound. Here we required an additional fourth port for application of the vascular clamp. Satinsky clamp being applied for en masse clamping of the renal hilar vessels. After clamping, excision of the mass was done with adequate margin. Here we can see the mass appears to be well encapsulated. Further dissection being carried out. Excision done on all the sides. The small internal vessels during the course of dissection was controlled with ligature. On further dissection, we can see a direct venous tributary to the mass. The venous tributary being clipped with a hemlock clip and it is being cut. Thus the mass was separated. Here we can see the resection bed. Then the rhinography was carried out using V-lock 20 suture. Here we are overseeing the renal bed. Here we are approximating the margins of resection with V-lock suture. Then hilar declamping done, and we can see there is no active bleeding from the surgical bed. We applied a hemostatic agent Sargicel over the area and flow seal was applied. Partial nephrectomy specimen was removed in an endobag. Postoperative ultrasound Doppler showed normal renal perfusion with resistive index of 0.46. Operative time in this case was 96 minutes with blood loss of approximately 200 ml. Patient had uneventful postoperative recovery and was discharged on second postoperative day. Thank you.
The patient is a 53 years old female patient referred with an incidental finding of a right renal mass. She has a history of mastectomy 6 years back. Contrast enhanced triphasic CT scan revealed a 4.5 by 3.2 cm right renal hilar mass which was well encapsulated and heterogeneously enhancing as shown in these CT films. The nephrometry score was 10A. The patient was placed in the left lateral position and two 12 mm and two 5 mm ports were placed as depicted. Colon was medially reflected at the white line of Tolt. An avascular plane was created between the posterior mesocolon and the Gerota's fascia. The hepatorenal attachments are released. The second part of the duodenum is cauterized to reveal the inferior vena cava. The psoas muscle is identified here. Two renal veins are seen here. The renal vein is further dissected. The hepatorenal attachments are further freed. The Gerota's fascia is defatted from the renal capsule, leaving only a small portion overlying the renal tumor. The renal artery is seen here. At the end of hilar dissection, two renal arteries and two renal veins can be seen entering the right kidney. Intraoperative ultrasound was not available. The proposed line of tumor excision is circumferentially marked on the renal capsule using monopolar hook. Laparoscopic Satinski clamp is applied to the renal artery and renal vein. Tumor is excised using a combination of sharp dissection using cold scissors and blunt dissection and counter traction using suction irrigation. An artery supplying the tumor was identified and was ligated using 3,0 PDS in a figure of 8 fashion. Rhinorrhaphy of the renal resection bed is started. Running 2,0 V-lock suture is used across the base of the resection to close any collection system of vascular injuries. 2,0 V-lock is then continued in running fashion to approximate the renal parenchyma, and a hemolock clip is applied after each wall-to-wall throw. Hilar Satinski clamp is released. Abgel is applied over the rhinorrhaphy. Ferracrylum is instilled. The specimen is extracted in a retrieval bag by extending the 12 mm working port. A drain is placed in the right paracolic gutter. The operative time was 92 minutes. Blood loss was approximately 250 ml. Warm ischemia time was 39 minutes. The patient had an uneventful postoperative recovery and was discharged on the second postoperative day. Histopathology report, case 1, left partial nephrectomy specimen, clear cell RCC, WHO ISUP grade 2, tumor confined to the kidney, no lymphovascular invasion or sarcomatoid transformation, resected margins free, adrenal mass shows features of adrenal adenoma. Histopathology report of case 2, right partial nephrectomy specimen, clear cell renal cell carcinoma, WHO ISUP grade 2, right kidney. The tumor is confined to the kidney, no lymphovascular invasion is seen, no sarcomatoid or rhabdoid transformation is seen, resected margin of the kidney is free of tumor. Thank you for your patient hearing.
Patient was a 43 years old
Thank you very much for this wonderful opportunity. I'll be talking about robot-assisted partial nephrectomy today. As you know, robotic partial nephrectomy can be done for tumors of various different complexities. And you have different types of tumors. For example, this is a easy lower polar renal 6A tumor, which everybody would like to operate, whether open or robotic. And then there are these more difficult tumors. For example, this renal 10X tumor, which is there in the mid pole and the lower pole of the right kidney here, which is almost entirely endophytic and also growing into the renal pelvis here. So irrespective of the complexity of the tumor, however, the basic steps remain the same. The initial setup, which is positioning and port placement, renal mobilization, hilar dissection, tumor excision, and renorrhaphy. Now, if you have an XI or the X system, you can actually put all the ports in the straight line. In case of patients who have right-sided tumors, of course, you need to put this liver retractor as well. And then you can put 1 or 2 assistant ports depending upon what your usual practice is. This port positioning really makes it convenient because you can apply it on all the tumors and standardize your technique. And you don't really need to worry about clashing with the XI or the X system. The initial step is, of course, mobilization of the colon. I'll be showing some techniques for right-sided tumors here. So this also involves mobilization of the duodenum and cauterization of the duodenum. One of the really good landmarks to follow is actually the inferior vena cava. The initial mobilization involves going just lateral to the inferior vena cava and going and finding the anterior surface of the psoas and lifting the kidney up from the psoas so that you have the entire lower and the mid pole lifted up from the psoas muscle. Along with that, the ureter also gets lifted up and mobilized. On the right side, of course, you can leave the gonadal vein down. So you can start this a little bit on the higher side, almost close to the hilum, so that the gonadal vein stays down. Whereas on the left side, you tend to lift the gonadal vein along with the ureter when you're mobilizing it. Subsequently, while doing the hilar dissection, one has to go above the hilum here, again trying to find the surface of the psoas muscle there, so that now you can lift up the upper pole of the kidney. And when you do that, you are able to find this clear shot around the entire hilum. Now, in most of the cases, unless you believe in a selective arterial clamping where you want to do just the artery clamping and you want to leave the vein unclamped, unless you want to do that, you don't really need to dissect the vein and the artery separately for most partial nephrectomies. So what I usually do is that I take a long vessel loop, a double vessel loop, take it around the artery and the vein in one shot, so I don't have to do a dissection between the artery and the vein, and cinch it. The subsequent mobilization before the hilar clamping, of course, is required, and that depends upon the location of the tumor. So if you have a tumor which is anterior lower pole, like case 1 in our demonstration here, you don't really need to mobilize the upper pole of the kidney. In any tumor which is posterior, and in most tumors which are upper polar, whether anterior or posterior, you do have to mobilize the upper pole of the kidney as well. In fact, for posterior tumors, you will probably have to flip the kidney completely to be able to approach the tumor from behind. So you have to tailor the extent of mobilization depending upon how much, where the location of the tumor is. So this is the easy one. This is the easy case where you can see this T1A tumor right in the anterior lower pole of the kidney. The next step is, of course, marking out the tumor, clamping the hilum, and then cutting out the tumor. So couple of things that you have to remember is that we should keep a little bit of fat on top of the tumor here so that you can hold it and retract the tumor in all the directions. You should score the tumor completely from all around, and all the cutting of the tumor that you do should be cold cut so that you can identify the normal and the abnormal areas very clearly. In the more difficult tumor here, you are going to maybe do something else because you definitely need an intraoperative ultrasound here. In the intraoperative ultrasound, we find that the tumor is actually going into the pelvis of the kidney here. And subsequently, we would need to mobilize the hilum of the kidney and maybe divide these small vessels which are going into the lower pole of the kidney, which has to be separated out. So once you cinch this double vessel loop, put a clip on it, and then put a couple of bulldogs so that they get adequate compression. You continue with the tumor excision, cut out the normal areas first where you have been able to identify a clear junction between the tumor and the normal parenchyma. But in this particular case, you also have to divide the pelvis because the tumor is protruding into the pelvis. So this is almost like dividing the pelvis into half along with doing a heminephrectomy, making sure that you're not manipulating the tumor too much here. You should not touch it with your suction. In fact, in this particular case, after doing a tumor excision, I put it in a bag separately, even while the patient was under warm ischemia to avoid further spillage. So here the heminephrectomy has been accomplished along with a division of a part of the pelvis here. So this is the tumor that can be seen. Again, coming back to case one, rhinorrhaphy. Well, there are a number of different techniques that you can follow here. What I usually like is that I like to close the pelvic calycial system with a 4-0 PDS using interrupted sutures, and then after that take an inner rhinorrhaphy using a 3-0 V-lock. So you bring a 3-0 V-lock from outside to inside with a clip applied at the end and underrun the entire base of the tumor, making sure that all the major bleeding vessels are taken care of and the hemostasis is ensured. So you can bring the needle out from the other end and put a clip on top of it. In most cases now, I would actually open up the clamp right now and do what we call as the early unclamping technique, thereby saving some warm ischemia time in this process. At the same time, this also helps in identifying any obvious bleeder that may be there, and we can control that instead of letting it bleed inside once you've already closed the outer layer and done the external rhinorrhaphy as well. The external rhinorrhaphy is done with the sliding clip technique. This is a number 1 vicryl with a CT1 needle. You take a couple of horizontal mattress sutures and cinch down the parenchyma so as to achieve good hemostasis and to ensure that the reconstruction is complete. So the instrument in the left hand is the force bipolar, and that force bipolar is a very versatile instrument. You can actually change the grip of the instrument from a soft grip of a fenestrated bipolar to a hard grip of a progress forceps. And that is something that really helps in the suturing because sometimes the small needle tends to rotate if you're holding it with a fenestrated bipolar. But with the force bipolar, you can hold it tightly with a tight grip and do a good rhinorrhaphy. Subsequently, you can cover this area with fat to provide that little bit of extra satisfaction in terms of being able to achieve a complete reconstruction. However, in more complex tumors, the reconstruction can become a little bit more complex. So this is case 2, where we have done a heminephrectomy and the reconstruction is being shown here. So this entire pelvis has to be reconstructed. It's almost like you're doing a robotic pyeloplasty. And because of this large defect here, in this particular case, we have put in an antegrade stent. Otherwise, in more than 95% of the cases, even when we repair pelvic calycial systems, we don't usually put a DJ stent or a ureteric catheter. So in this case, the pelvis has been reconstructed and closed over a double J stent. And here, again, the 4-0 PDS is being used to go ahead and control the major bleeding vessels here. So that was a small arterial branch. This is it's probably a segmental vein here. So a branch of the renal vein, which we are again closing with a 4-0 PDS. We are right on the hilum here. These are the major vessels. So we can't really underrun this with a V-lock. So we unclamp at this time, again, doing an early unclamping technique, and go ahead and use a number 1 vicryl to do an external rhinorrhaphy. So just a spot closure of the bleeders and an external rhinorrhaphy with a number 1 vicryl with the sliding clip technique again. With this, we are able to achieve good hemostasis in this particular situation. But again, for that extra security, in this case, we have used a hemostatic agent. In most cases, we don't. So we use a new knit and close the fat over it to provide some extra compression here. So these are all the steps and the tips and tricks of partial nephrectomy. This is our experience of partial nephrectomy in the last 5 years or so. Done about 112 partial nephrectomies, with more than 90% of them being robotic partial nephrectomies with a mean warm ischemia time of 24 minutes. 47 of them have been done with an early unclamping technique. We have had no intraoperative complications and only one major complication, which was a urine leak requiring stenting and pigtail drain placement for the same. Thank you so much for your attention, and thank you for the invitation again. Thank you very much.
Good afternoon, ladies and gentlemen. First of all, I would like to thank organizing committee of UROCON 2021 for providing me this opportunity to talk in laparoscopic radical nephrectomy. I'm Professor Dr. Prem Gewali, Executive Director from Syed Dharmabhakta National Transplant Center. Before talking about the laparoscopic radical nephrectomy, we should always remember Dr. Ralph Kleman, who did his, not only his, in the world first laparoscopic radical nephrectomy in 1991. It was my privilege and opportunity to meet him in Goa in March 2020, while he was presenting a paper how he started his first laparoscopic radical nephrectomy in 1991. You can imagine how difficult it was at that time when he didn't have such type of the instruments which we use in 2021. Even though those are the pioneers of the urology, we started laparoscopic radical nephrectomy. So, laparoscopic radical nephrectomy is gold standard for localized renal cancer. Its indication for the radical nephrectomy is T2, T3, T4 cancers with or without multifocal ipsilateral renal masses. And the specimen which is removed during laparoscopic radical nephrectomy is the entire kidney, including fascia of aorta, and depending upon the site of the tumor, ipsilateral adrenal gland, and if needed, lymph nodes also. The contraindication for laparoscopic radical nephrectomy is similar as in the other laparoscopic surgery. Coagulopathy is absolute contraindication, and morbid obesity is also, it is actually not absolute contraindication, but better to avoid morbid obese patient for the laparoscopic surgery because the length of your working instrument may not reach to the targeted organ. And patient, if he cannot tolerate pneumoperitoneum, laparoscopic radical nephrectomy should be avoided. Other like infection, intestinal obstruction, such type of the condition also are relative contraindicated in the radical nephrectomy. My advice for the novice who are just starting their career in laparoscopic urology, they should be familiar with the open radical nephrectomy. If you are not familiar with the open radical nephrectomy, do not go alone in the laparoscopic radical nephrectomy. As previously mentioned, avoid morbid obese patient and very thin patients, because in very thin patients also the dissection will be difficult. You should not compromise with hand instruments and coagulation devices for the radical laparoscopic nephrectomy. Open surgery set must be ready on the operation theater. It should be displayed on the table. You should not pack it and wait when it is required. It requires immediately. If you are trying to start the laparoscopic radical nephrectomy, be patient. I remember Ralph Kleman has taken 9 hours to do his first laparoscopic radical nephrectomy, and for myself, I took about 5 or 6 hours in the beginning. Once your expertise increases, when your experience increases, then the time will come down. Always you counsel your patient about possibility of conversion to open surgery. While positioning the patient for the laparoscopic radical nephrectomy, after the anesthesia, you should keep catheter and nasogastric tube to decompress the abdomen, decompress the stomach as well as bladder, because distended stomach and distended urinary bladder will make it difficult to walk in the targeted area. You should mark the location of the extraction site in the supine position, because if you mark it in the lateral position, you may not exactly mark or incise while retrieving the specimen. Patient is kept in the modified lateral decubitus position on the edge of the table with 30-degree angle from the ground. I usually do not break the table for the laparoscopic surgery, but if patient is obese, you may require to flex the back. Flex lower leg and extend the upper leg and keep pillow in between two legs. Auxiliary roll to prevent the neuropraxia. Each bed placed beneath the axilla, back support, padding of the prominent bones, and patient should be secured on the table. This is the patient for the left nephrectomy, and this is the position of the patient. Patient was relatively obese, so I needed to flex the table for laparoscopic radical nephrectomy. So access of the laparoscopic radical nephrectomy can be obtained by varus needle or Hassan open technique. I prefer the varus needle in the adult, only in children, and abdominal surgery multiple times, and where I guess there may be the adhesion inside, I go with the Hassan open technique. Otherwise, more than 90% cases, I go with the varus needle. Once we inflated the abdomen, it should be inflated up to the 15 to 20 millimeter of mercury to place the first trocar, that is the camera port. And here in the picture you can see I have marked that the tentative my port will be like this after the pneumoperitoneum, but the site of the port will be changed after the pneumoperitoneum. So you should mark the site of the ports only after the pneumoperitoneum. 12 mm camera port is kept at the level of umbilicus, depending upon the near to umbilicus or away to umbilicus, depends upon the habitus of the patient. In obese patient, it goes lateral, and in thin patient, it comes nearer to the umbilicus. And one mistake, what frequent mistake we make while putting the 12 mm working port, we make a line in between the anterior superior iliac spine and umbilicus. No. The line should be made from anterior superior iliac spine and the camera port side, and in between you should put the right working port, 12 mm port. So those are the basic instruments which are required to make the access. This is the varus needle, which I prefer. It has the sharp inner needle, and there is the hollow outer needle. While making the pneumoperitoneum, you will feel two pricks. I will show in video later on. This is the Hassan cannula for the open technique, and there was the working trocars from where you will put the 12 mm working instruments, and those are the 5 mm instruments, and those are the reducer. If you have 12 mm port and you need to put the 5 mm working instrument, then you should reduce with the reducer, sleeve reducer or auditory reducer. So those are the instruments where you should never compromise in the quality of those instruments. They are the very vital or heart of the surgery. Once you have those good instruments, your surgery becomes very easy. Those are the clip applicators which are used to secure the blood vessels. So Liga clips, envelope applicator, they are also different sizes. And this is the coagulation device. I prefer the ultrasonic coagulation device. This is the Harmony. And some people, they like the bipolar, or they can use the Ligasure, whatever you prefer, you can use that one, but should not compromise with the quality of the machine. And this is your visual part. So here is in the procedure, after putting the first trocar and inserting the camera, we should inspect the nearby structure. While creating the pneumoperitoneum, we can injure the nearby structures. So you should inspect mesentery, or you should inspect intestine. Should be inspected. Only then, after under vision, the rest of the trocars are put. The mobilization starts from the white line of the throat. But some people, they start after mobilizing the spleen, they go for the white line of the throat. You should create a plane between posterior mesenteric and anterior prerenal fat. Only then after you will reach retroperitoneally toward the kidney. In the beginning, mostly the surgeon, they get lost in this plane. You should, once you do more surgery, then you with your experience, everything comes online. Hepatic and splenic flexures should be incised. If you are operating on the left side, you should completely mobilize and drop down the spleen in block. Gonadoureteric packet is lifted on the left side, and on the right side, only ureter is lifted. On the left side, lumbar, there are multiple lumbar veins. You should secure and address those lumbar veins, gonadal vein and adrenal veins. Once you completely mobilize the spleen and block, spleen falls down and it lifts off the tail of the pancreas. Then it is easy to tackle in the hilum of the kidney. And a specimen, in case of the radical nephrectomy, you are dealing with malignancy of the kidney. So the specimen should be retrieved after putting on the pouch or disposable devices, and you should not take it out with a bare hand, because tumor cells can be spread in the peritoneal cavity. So here is the short video about the laparoscopic nephrectomy. Before doing any laparoscopic nephrectomy, we should have contrast CT scan, where you can see the artery vessels. And here I am showing you how to make a pneumoperitoneum with the varus needle. Varus needle is kept at the level of the Palmer's point, or you can put it in the lower quadrant, depending upon the site where you are, from where you are going to make a pneumoperitoneum. In most of the cases, more than 90% of the cases, I do it in the Palmer's point. Then when you insert the varus needle, you will feel two clicks. One while piercing the fascia of the muscular fascia, and second in the pneumoperitoneum. When you enter the peritoneal cavity, you feel suddenly loss of resistance, and we do the progress. Well, here, so we believe and actually in radical nephrectomy we do not see the kidney from inside the fascia of aorta because it is covered with the fascia of aorta and perirenal fat, and specimen it should be removed with the specimen retrieval devices. So guys, believe in yourself. You are braver than you think, more talented than you know, and capable more than you imagine. Thank you very much for your patience.
हलको आवाज बाहिर आइरहेको छैन.
It will be virtual live. Virtual live is there. Then we can go directly to second presenter, please.
The second presenter is
Ragazzi,
hi everybody.
Silenzio un
I'm
attimo
very
che-
happy to present you some
Italy.
data regarding the role of lymph node dissection in renal cell carcinoma. I would like to thank the scientific committee for the invitation. It's a great honor. I'm very happy, and I will try in 10 minutes to give you the main data available regarding lymph node dissection, why to perform it, when, and how. Regarding the reason to perform a lymph node dissection, obviously the first question if there is any effect on cancer control in performing lymph node dissection. And in this specific setting, we have some papers recently published, only one single randomized clinical trial that was published more than 10 years ago. And we have a bunch of papers that were actually retrospective, usually single institution with multivariable analysis control for confounders. However, only a couple of papers showed the benefit in terms of cancer control when performing a lymph node dissection in this specific scenario. And the majority of papers, including the prospective randomized clinical trial, were finally negative. It's important to highlight that even the randomized clinical trial and all these papers actually have very important flaws and limitations because the populations of patients included were mixed, non-standardized, and it's difficult to draw a final statement in this specific setting. Let's have a look to the randomized clinical trial that was published by the EORTC more than 10 years ago. They compared patients treated with radical nephrectomy plus lymph node dissection with patients treated with radical nephrectomy alone. The endpoints were time to progression, overall survival, and cancer-specific survival. And you can observe that virtually the two curves are the same, and this means that in this specific study cohort, actually no benefit in terms of cancer control was observed when patients were treated with the lymph node dissection. However, it's important to highlight that many flaws affected even this randomized clinical trial. The main drawbacks are that low-risk cases were included. All these patients are non-metastatic with no lymphadenopathies, and moreover, more than 70% of patients have organ-confined small renal masses. The patients were treated with a limited lymph node dissection. They didn't use a standardized lymph node dissection template, and we don't have information regarding the number of nodes removed or the number of positive nodes. So many drawbacks even in the randomized clinical trial. It's very interesting to see in this post hoc analysis of this prospective randomized clinical trial that if we consider only those patients with a clinical T3 tumor, however, still not a very high risk patients because again, without lymphadenopathies, without metastases, but you can see a trend in terms of cancer control benefit for patients treated with the lymph node dissection. But obviously, we cannot make any final statement. However, as also for other oncological settings, cancer control and survival are not the only reasons to perform a lymph node dissection. We can have also purposes in terms of staging and prognosis. Indeed, in patients with organ-confined disease, actually the proportion of patients with lymph node invasion is very low. So in this specific category, probably even for prognosis staging, lymph node dissection is not important. However, you can see that in locally advanced disease, this is a very elegant paper published by the Mayo Clinic. In this specific cohort with T3 tumors, even if there is no lymphadenopathy within the retroperitoneum, the proportion of lymph node invasion is up to 30%, so very, very high if we want to have a staging accuracy in this specific cohort. And please remember that lymph node invasion is a very important predictor, is an independent predictor of the natural history of metastatic progression and cancer-specific survival in the overall cohort of RCC patients, but even in patients with distant metastasis. And the recent papers indeed suggested that patients with lymph node invasion should be considered as already metastatic, since the natural history is virtually the same relative to patients with distant metastasis, with a median MFS less than 9 months and a median survival of 2 years, so comparable with patients with distant metastasis. When we should perform lymph node dissection? According to a limited, probably no effect in terms of cancer control, and an effect, an important staging and prognosis purposes, but only in locally advanced disease, probably we should perform a lymph node dissection in locally advanced disease. Indeed, this is a nomogram that we published some years ago, and you can see that the most informative predictors to find the lymph node invasion in the patients were TNM and clinical tumor size. So in larger tumor or patients with locally advanced disease or patients with lymphadenopathies, you are going to find, if performed a lymph node dissection, a lymph node invasion. We were able in this paper to include also lymph node progression to avoid the flow that false negative patients were included, because indeed there is no surgical series in the setting of kidney cancer of patients treated with a systematic and extended lymph node dissection. So we included LNI progression together with LNI to avoid or to limit this flow. Again, this is another very nice paper published by Boris Jeschman from the Mayo Clinic, and the diameter of the lymphadenopathy is probably one of the most informative predictor to find finally a lymph node invasion at final pathology. For all those reasons, you can see that the proportion of patients that receive lymph node dissection nowadays is very, very limited after the RTC trial paper publication, but also for the other papers that I showed you before, the proportion of patients that nowadays receive a lymph node dissection is virtually very, very low, below 20%, and only usually in a very locally advanced disease. Finally, how? This is the most difficult part of the presentation, because, as I said, we don't have a systematic extended lymph node dissection performed in all the papers published in the literature. So we can only use anatomical and autoptic papers to draw some conclusions. You know that kidney cancer has a very high predilection for hematogenic dissemination. If we take patients with distant metastasis and we perform extended lymph node dissection, only half of the patients will have a lymph node invasion, because the metastases go directly through the hematogenic pathway. The lymphatic pathways can directly go to the thoracic duct in 1/3 of the patients. And finally, many possible different lymphatic routes are possible in normal retroperitoneal anatomy, and even is more difficult to predict the lymphatic routes if locally advanced disease are present. And just consider that more than 10% of patients have the first landing sites in the ipsilateral iliac and supraclavicular nodes, so outside the normal retroperitoneal field. If we want to draw some conclusion, if a lymph node dissection is performed, should include the precaval and retrocaval nodes in the right kidney tumor, in the para-aortic nodes in the left kidney tumors, and interaortocaval nodes if the tumor is very, very large and locally advanced. So in conclusion, Probably there is no benefit for lymph node dissection in terms of cancer control. In low-risk tumors, there is no doubt. Maybe there are some few cases that may benefit in terms of cancer control in locally advanced disease. However, for staging and prognosis, lymph node dissection remain important, especially for adjuvant therapy and follow-up strategies, and especially in locally advanced disease, since up to 30% of those patients will be LNI if a lymph node dissection is performed. Again, I wanted to thank the scientific committee for the invitation, and thank you very much. Hi.
Since he is not with us now, first we'll do the third presentation. A changing landscape in management of metastatic RCC in 2021. Dr. Kamal Raj Soti, please.
Good afternoon, everyone. Today, I will be presenting on the changing landscape of management of metastatic RCC in 2021. My presentation will include how RCC can be classified into 3 prognostic risk groups and 2 major histological groups, treatment tailored to these groups, the scope of cytoreductive nephrectomy and active surveillance in metastatic RCC, and the evolving role of molecular classification for better personalized care. Historically, 2 prognostic models were devised, MSKCC and IMDC model. MSKCC model was used in the interferon era, while IMDC model was used from the VEGF inhibitor era. In addition to MSKCC model, IMDC model includes platelet and absolute neutrophil count as independent adverse prognostic features. LDS has been excluded because it was found to be of no statistical significance. When patient has no favorable risk, no risk factor, they fall into favorable risk. Patient having 1 to 2 risk factor, they fall into intermediate risk, and patient having more than 3 risks, they fall into poor risk groups. The median overall survival for these patients range from 7 months in poor risk as high as to 43 months in favorable risk. With the use of interleukin-2 in 1992, the medical therapy of metastatic RCT was started. The clinical outcome improved when VEGF inhibitor like sorafenib was introduced in 2005, sunitinib later on, and mTOR inhibitor like everolimus in 2009. Nivolumab immunotherapy came into play since 2000. 3 years later, nivolumab was combined with another immunotherapy, namely ipilimumab. Now, since 2019, we are using a combination of immunotherapy plus VEGF inhibitor. Immunotherapy in the form of pembrolizumab, abiliumab, or nivolumab or ipilimumab, combining with the VEGF inhibitors like axitinib, lenvatinib, or cabozantinib. Slowly, we are heading towards triplet therapy. That means use of nivolumab plus ipilimumab combining with cabozantinib. When we see trials of these combination therapy, it has shown to be of overall survival benefit when compared with sunitinib. Based on these data, NCCN guideline recommends for all the risk groups categories, use of pembrolizumab plus lenvatinib as category 1 recommendation. But for poor and intermediate risk groups, only pembrolizumab plus axitinib or nivolumab plus ipilimumab has been advised. Recently, phase 3 RCT trial have been carried out, which has been compared with the same sunitinib comparator arm. The patient features in all these trials is similar. Patient with treatment name advanced or metastatic RCC with clear cell histology and some sarcoidoid histology are taken who have good performance status, and tissue is available is stained for PD-L1 staining. These therapy are given till the patient become progressive or intolerant to therapy, but in checkmate trial, nivolumab is given till maximum of 2 years. The primary endpoint for these trials were progression-free survival, while the secondary endpoint was overall survival and objective response rate. It is not appropriate to compare the results of all these three trials, though the comparator arm is the same sunitinib. However, I have tabulated it here for easy understanding. Why we can't compare? Because the patient population might differ. As we can see here in CheckMate trial, the sarcomatoid variant, which is seen to be of more aggressive and malignant potential, has not been included in the CheckMate trial. And the median follow-up period also differ for these trials. If the median follow-up period might be less, the chances of capturing event might be low. We can say that the median progression-free survival for these trials in combination therapy ranges from 15 to 23 months. The overall survival in the combination arm lived twice as compared to the sunitinib group. The objective response rate is as high as 70% with 16% complete response in clear trial. The adverse event in the two arms are comparable in the three trials. Can these patients be put on active surveillance? A recent prospective observational data published in 2021 in Cancer Journal says active surveillance is safe. In an accompanying editorial, Bex writes that there is always a challenge to identify patients who can be enrolled in these trials, because the challenge is to prospectively define such patients, and it is even difficult to define oligometastasis and patients of low volume disease. However, we can do somatic mutation to identify patients who are candidate for active surveillance, and we need to have better follow-up strategies to put this patient on surveillance. Lately, some of the immunotherapy society have reached to a consensus to say that limited or symptomatic metastasis with favorable IMDC can be considered for active surveillance. Cytoreductive nephrectomy, when was combined with the interferon since 2001, it had a survival advantage when compared with interferon arm. But with the advent of VEGF inhibitor, patients had two main concerns. The outcome of the VEGF inhibitors, simply VEGF inhibitors, the outcome was better. And they were concerned about the perioperative complications and the delay of start of systemic therapy. To address these issues, initial nephrectomy versus deferred nephrectomy was investigated in a prospective trial. We saw deferred nephrectomy had longer overall survival, but this trial was underpowered. After that, Carmina non-inferiority RCT phase 3 trial was carried out to see whether patient receiving only sunitinib arm compared to the patient group receiving nephrectomy, sunitinib, are these two groups non-inferior. The results showed that only giving sunitinib is non-inferior compared to patient receiving nephrectomy followed by sunitinib. However, the trial was clearly underpowered because it could enroll only 450 patients as compared to 576 patients as previously planned. And most of the patients were of poor risk who had less likely benefit from cytoreduction. And these patients, this trial didn't enroll any favorable risk patients. Though we see here that there is no clear evidence to give cytoreduction for patients, but from the practical point of view, the favorable patients with a minimal tumor burden or patients having local symptoms can be offered cytoreduction, while systemic therapy can be offered to patients having poor risk groups, intermediate group requiring prompt treatment, favorable risk with extensive therapy or extensive disease or systemic symptoms. Patients having systemic symptoms can be offered systemic therapy. There is no definite role of doing a metastectomy in metastatic RCC, no established role of adjuvant therapy. That's why many ongoing trials are going on in the neoadjuvant and adjuvant setting. Maybe to find a specific answer based on the site of metastasis, complete versus incomplete resection, or based on the timing of systemic therapy, we might come up with some answer. In subsequent therapy, the late entry is tivozanib in 2021, which has been compared with the sorafenib in the third-line agent, and it has shown to be of benefit in progression-free survival. Treatment of non-clear cell carcinoma has been extrapolated from the clear cell carcinoma. Basic distinct change is the use of bevacizumab plus erlotinib in papillary carcinoma with hereditary leiomyomatosis, and the use of cytotoxic chemotherapy in collecting duct subtypes. Molecular classification in RCC have come up with 7 subtypes of RCC. So we can better identify the indolent patients who can be offered active surveillance. And some of the reports have come up saying sunitinib fare well in especially angiogenic subtypes, while patients with T effector proliferative subtypes, they do better with atezolizumab and bevacizumab. Radiation therapy can be offered to brain and bony mets or with local renal recurrence, but there is conflicting role of bisphosphonates in bony mets. There are still many unanswered questions, especially the use of triplet agents, as I previously mentioned, the treatment duration, sequencing of immunotherapy with VEGF inhibitors, timing of cytoreductive therapy, use of immunotherapy in metastastomy, and especially the efficacy of the novel agent HIF alpha inhibitor, belzutifan. So ongoing trials are going on. Maybe we will come up with some answers to these questions. In this short summary, in this short presentation, we can summarize that combination immunotherapy or immunotherapy with VEGF inhibitors are the first line of management in clear cell carcinoma. Systemic therapy can be offered to poor risk groups, intermediate group requiring prompt treatment, favorable risk patients with extensive disease, or patients having systemic symptoms. Despite of clear evidence from practical point of view, cytoreduction can be offered to patients with favorable with minimal tumor burden or patients having local symptoms. Molecular classification is needed, and we need to do further study on this to ideally choose who are the right person for active surveillance and to predict response to therapy. Thank you, everyone.
Thank you, Dr. Kamal, for highlighting in detail the various aspects of immunotherapy and targeted therapy. Since Professor Amlesh Seth is not with us, with this session comes to an end, and I would request Dr. Bhojraj to take over, please.
Thank you very much, dear chairpersons and presenters. I would like to thank Dr. Umberto Capitanio from all the way from Milano and Dr. Kamal from Maldives, Male. We all give big vote of thanks to both of you. Thank you very much. Please be with us. Next session is on locally advanced metastatic. Next session is about carcinoma of the prostate. So we'll be going for that. For this session, I would like to request Professor Pukar Maske, Professor Asaf Shah, and Dr. Robin Joshi to take the chair. Yeah, please.
Warm welcome, everyone, to the ongoing UROCON session. Now we'll be continuing with a session on carcinoma prostate, and we'll be having altogether 4 speakers, 1 from Nepal and 3 from India. And without wasting much time, I would like to call upon Dr. Ganesh Bakshi to speak on open radical prostatectomy step by step. Dr. Ganesh Bakshi is a renowned uro-onco surgeon from Tata Memorial Hospital, India. And I hope that all of us will definitely benefit from his lecture on the steps of open radical prostatectomy. Thank you. Welcome, Dr. Ganesh.
Good afternoon. I thank the Nepal Association of Urological Surgeons for giving me this opportunity in UROCON 2021. My topic, open radical prostatectomy step by step. I acknowledge Campbell Walsh Urology textbook, video by Dr. Patrick Walsh, and Hinman's Atlas of Urologic Surgery. The evolution of this surgery began long back in 1901 when first perineal prostatectomy was described by Young, and later In 1970s, Dr. Patrick Walsh described and revolutionized the technique. Most surgeons who do open radical prostatectomy follow his technique today. Indications today in the era of robotic prostatectomy: no access to the robot, financial problems, not suitable for steep Trendelenburg position we used in the robotic, and not suitable for a GA. The trifecta of this surgery: cancer control, preservation of urinary continence, preservation of erectile function. There are certain preoperative considerations in the MRI: the size of the prostate, size of median lobe, thickness of bladder wall, presence of T3 ABDCs, enlarged pelvic nodes. We optimize cardiac and pulmonary status. Usually there is a 6-week interval between the biopsy and the surgery. Reserve blood, thromboprophylaxis, antibiotic prophylaxis, and bowel preparation is optional. So the special armamentarium includes a Balfour retractor, choice of loops and headlamp, bipolar forceps and other energy devices, and a judicious use of clips. We use general plus epidural anesthesia. The patient is positioned as shown, supine with 15 degrees Trendelenburg. Table is flexed to open up the pelvis, and a 14 or a 16 French catheter is placed. It's a lower midline incision, and we stay extraperitoneal. We enter the space of Retzius and mobilize the peritoneum laterally of the iliac vessels till the crossing of the ureter. We place a Balfour retractor and use it for an adequate exposure. Pelvic lymph node dissection is pre-decided. An extended PLND includes external iliac, internal iliac nodes, obturator nodes, common iliac nodes till ureter crossing, and presacral if enlarged. Now coming to the incision of endopelvic fascia and lateral dissection. We clear off the fat from the anterior and lateral surface of the prostate, expose the endopelvic fascia and the puboprostatic ligaments and superficial DVC in the center. The superficial DVC is controlled. The puboprostatic ligaments then come into the view here. And then we make a cut on the endopelvic fascia. The cut is made well away from the prostate to avoid bleeding from the lateral tributaries of the DVC. Cutting the puboprostatic ligaments. The endopelvic fascia is divided from the base of the prostate till the puboprostatic ligament. Small perforating vessels may be clipped. The puboprostatic ligament is divided. The apex of the prostate with the overlying DVC should be clearly visible. Then coming to the ligating of the DVC. The DVC complex is held with the Babcock forceps as shown in the picture. A figure of 8 stitch with vicryl or monocryl is taken. For this stitch, the surgeon faces the patient's head and the stitch is taken in the horizontal plane so as to avoid the anterior tissue of the urethra. The suture over the proximal DVC is placed. This prevents bleeding from the proximal end of the DVC when it is divided. Now dividing the DVC. The DVC is divided and lifted off the anterior surface of the prostate. Downward and cephalad traction on the prostate with a sponge and slight counter traction on the DVC help in opening up this plane. The urethra beyond the apex of the prostate comes into the vision after the cutting. Sometimes there is bleeding from the proximal DVC and a V-shaped suturing of this fascia can be used to stop that. Coming to the division of the urethra, we can pass a right angled clamp under the urethra just beyond the apex and divide the anterior 2/3 of the urethra as shown. Next step is placing the sutures at the urethra. So sutures are placed at 12 o'clock, 2 o'clock, 10 o'clock, 7 and 5 o'clock using a 5x8 needle on a 2O or a 3O monocryl suture. This is how it looks. dividing the posterior striated sphincter, that is the urethral plate. As shown in the diagram and the video, we divide it not very closely to the prostatic apex to avoid injury to the neurovascular bundle, divided midway between the prostate apex and the urethra. If we are doing a nerve-sparing radical prostatectomy, the neurovascular bundle has to be preserved. We release a superficial lateral pelvic levator fascia over the NVB. The neurovascular bundle is released till the level of SVs, and dissection continues just anterior to the rectum, maintaining the denonvillous fascia on the prostate. As shown in the video. Coming to the posterior dissection up to the seminal vesicle. The dissection continues towards the base of the prostate, staying on the anterior surface of the rectum. The seminal vesicle are released after dividing their arteries, and then the vasa are divided. The seminal vesicles are being dissected as shown, artery to the seminal vesicle. It's dissected fully free, and the last part is the vasa. Now coming to the division of the bladder neck. The bladder neck can be divided with a scissors or with a diathermy. Many surgeons nowadays also do the bladder sparing technique, where you might get a narrow small bladder neck. And this completely removes the specimen. Now coming to the bladder neck reconstruction. Continuous interrupted sutures with 2O-vicryl or PDS are used. We have to take care of the ureteric orifices. And the bladder neck is reconstructed. After this, the bladder neck is matured as shown in the adjoining picture. This is the maturing. A small wash is given to remove any clots. Now coming to the bladder neck intussusception, commonly posterior is done, sometimes also anterior, and we call it buttressing. These sutures prevent the bladder neck from pulling open as the bladder fills, and note that usually the bladder neck is continent after this step. Take care not to tighten too much, otherwise it may cause a stenosis. Coming to the last part, the anastomosis, the catheter had just entered the urethra. The sutures on the urethra were placed earlier. Now we are taking the sutures on the bladder side. The same sutures in the mirror image. Once all the sutures are placed, usually after the posterior sutures, the catheter is put in. After that, we would tie the sutures, that is parachuting of all the sutures, push the bladder down, carefully tie them, gradually release all the tension on the bladder. Has to be a well coordinated movement, and check the catheter in the end. That completes the procedure. Thank you so much. Good afternoon. I thank the
Thank you very much indeed, Dr. Ganesh Bakshi, for a very nice talk on the tips and tricks and the important steps of open radical prostatectomy. Indeed, as you mentioned, the most common indication for doing open radical prostatectomy in our setup is lack of robot. We don't have a robot as of yet in our country. And most of the urosurgeons, uro-oncosurgeons in our country are still doing open radical prostatectomy. And if there are any questions from the crowd, any questions? that anyone would like to ask to Dr. Ganesh Bakshi? If there are no questions, I think we'd like to go to the next talk. The next talk is going to be by Dr. Mallikarjun from Hyderabad, Asian Institute of Nephrology. Everyone knows Dr. Mallikarjun. I think he's like a local guardian to us, to the Urosurgeons of Nepal and to Nepal Association of Urological Surgeons. All the Urosurgeons from Nepal who does laparoscopic urology, they should owe something to Mallikarjun sir, because we have learned laparoscopy from him in one way or the other, through his live demonstrations, through his videos. So he's also the current president of Urological Society of India. And without wasting much time, I would like to invite, I'd like to call upon Dr. Mallikarjun sir, to speak on laparoscopic radical prostatectomy, steps and troubleshooting. Thank you.
Laparoscopic radical prostatectomy step by step. Thank you for this opportunity. Port position. If you see that right-sided port, it's towards the midline, and the left side port's away from the midline. That's the way we do it. Posterior, I start always with the posterior dissection by giving an incision into the peritoneum just behind the rectovesical pouch, and starts creating a plane between this peritoneum, behind the seminal vesicles and the prostate. I don't dissect the seminal vesicles beforehand, right? Get into the prostate, right posterior to the prostate. You start realizing that you see the denonular fascia. That is the denonular fascia. You can go anterior to it or posterior to it, depending upon the type of prostatectomy you want to plan. That is the dissection which is happening. Following which you start dissecting the vasa and divide the vasa, and then separating the vasa, and you expose the seminal vesicles, tip of the seminal vesicles, and you hold the seminal vesicles and start dissecting on either side. That's one-sided vesicles, both vesicles which are completely taken. Incision into the denonular fascia. Once you dissected and you decided that you have to incise onto the denonular fascia, exposing the perirectal fat there. That's the completion of the posterior dissection. It then starts with the dropping of the bladder, which is easily done. And majority of the time we require a monopolar energy only. You may not be requiring any specific energy source. You dissect and drop the bladder as much as possible. I would say from one internal ring to the other internal ring, the whole peritoneum is divided so that it's completely exposed. You can see that external iliac vein also, which is very well exposed. So that gives a complete picture of it. Defatting of the prostate. You take out all the fat anterior to the prostatic fossa. Keep the prostatic gland. It's completely barren the prostatic gland on either side. Expose the endopelvic fascia with its reflections completely. So that is what is very, very essential. Take some time out and start doing it, defatting it and exposing the anatomical landmarks very well, and exposing the endopelvic fascia very clearly in front of you. That will give you a lot of easiness in controlling them, controlling the vessel later. Division of endopelvic fascia happens depending on type of prostatectomy you want, whether it is intrafacial, interfacial, or extrafacial. I always come out of the veins and try to retain rest of the tissues lateral to the veins so that you can preserve the nerves which are there in the lateral pelvic fascia. So internal to the inside the vein, if you dissect, it will become an intrafacial dissection. That's endopelvic fascia. You divide a little and reflect or divide the endopelvic fascia just next to the lateral to the veins. That is the veins which are there medial to it under the forceps, and divide and push the rest of the tissues, what is there left onto the lateral part of the vein towards the pelvic wall, and that retains some element of nerves. That's one side. And on this side, it's a left-sided tumor, so I started dissecting extrafacially. So I go just next to the levator vein muscle and retain all the nerves towards the tumor. So that is an extrafacial dissection on this side. DVC control. Laparoscopically, I always do a DVC control, and so I get the DVC in my laparoscopic prostatectomy. A division of the puboprostatic ligaments, a little division will help in taking this bite and ligating the DVC. Bladder neck division. Identify the bladder neck by pulling the Foley's balloon and then identifying it and start dissecting it. Most of the time, the better plane is seen on the lateral aspect of the prostate, not in the midline. The lateral aspect shows that groove between the bladder and the prostate, and you start dissecting into it, and you find a nice plane with some amount of irregular tissue or a fatty tissue inside. and on both sides it is done, and that exposes the middle part of the urethra, the bladder neck, and you divide into the bladder neck. Majority of the time, I would avoid, I use only a monopolar scissor, nothing more than that. You need to divide and take out the attachment right up to the 5 o'clock position and the 7 o'clock position on that side, and then start understanding it, the anatomy of trigone and the location of the ureteric orifices. That's the location of the ureteric orifice which is confirmed, and following which you start dissecting into the middle part of the bladder neck area. The posterior surface, posteriorly it is already dissected off, and so it is easy to create an opening into that dissected area already, and separating the bladder neck from the prostate at that point. That's a nice dissection which has happened and separated the bladder neck from the prostate. Having done that, you need to know how to control the pedicles, and what is left behind now is at 5 o'clock and 7 o'clock is nothing but the pedicles of the prostate. You see that the whole pedicle is there, and the vessels into the prostate are being there. Posteriorly it is dissected, laterally it is dissected. You try to decrease the size of the pedicle. You need to dissect and decrease the size of the pedicle so that you can clip that and start separating the neurovascular bundle to a certain extent posteriorly. And some nerves along with the prostate are always sacrificed now. So that is a clipping of the pedicle, and following which you separate the neurovascular bundle area from the lateral aspect of the prostate. So dissecting laterally and posteriorly prior will help in identifying these vessels and keeping it a narrower will be easy way of preserving the neurovascular bundles. The same thing is done on the left side. This being an extrafacial dissection, you're going to clip whatever is there and then divide the vessel, divide the pedicle. Now you see this curvature of the concavity is there anteriorly. The scissor is going to divide between the prostatic surface and the deep venous complex. There is a specific plane which is available there. A little traction onto the prostate will expose that. And then that's an apical dissection or division of the segment, division of the attachments at the apex. Now you can see the periurethral tissues are divided. Preserving these periurethral tissues is very important in having a good continence. Don't strip the urethra completely. So after division of these periurethral tissues, the urethra gets exposed very well, and that is the urethra which is exposed, and then you divide the urethra. That is the urethra which is divided. Withdraw the catheter, and the urethral stump is very well seen. Don't cut into the apex of the prostate. Understand the prostatic anatomy much ahead before dividing it, so that you don't sacrifice on the urethra, but at the same time don't retain a part of the apex. That is the posterior urethral tissues which is being divided. And that separates the prostate completely. That's the prostate which is come out. Look into the hemostasis completely. You have 3 or 4 clips on either side of the prostate which controls the pedicles. And that is a ROCO stitch. This is my way of putting a ROCO stitch. I take a 1-0 or a 1-0 vicryl and make a box-like suture and push these two tissues together so that the urethrovesical anastomosis is easier. I take a Van Wanthoven technique or a monocryl 3-0 with a CT1 needle and take this in this fashion, make a knot and get both of the needles towards bladder, and then on either side from the urethra. Having done that, I take it towards the bladder again and pull it. You see that? That happens the correct base or a posterior aspect of the anastomosis. That's how. Then there will not be any problem in passing the catheter. And you can complete the anastomosis by using the curvature of the CT1 needle and a proper direction or proper rotation of your instrument so that the suturing is made easy. Whatever extra bladder what you have can be closed here like an anterior racket, like what we have done just now, an anterior racket. I would avoid a posterior racket, and that is the completion of the anastomosis. Thank you for this opportunity.
Thank you very much, Mallikarjun sir. You made laparoscopic radical prostatectomy look much easier than laparoscopic radical nephrectomy indeed. So definitely the haptic feedback which we get while doing laparoscopic radical prostatectomy would not be obtained with a robotic prostatectomy. So what is your experience after you have shifted to robotic prostatectomy these days? Do you think that lap radical prostatectomy still has a role in a country like ours where we don't have a robot?
Of course, I would say If you have a robotic prostatectomy is the ideal thing to do. I have shifted myself to a robotic prostatectomy because I have a robot. But in absence of a robot, I still say laparoscopic radical prostatectomy is doable. It's a difficult job. Anything learned, anything in initial stages is a difficult job. But as you start doing it, as the numbers go up, it is a doable job. The only thing what I consider possibly in majority of the urologists is the number of cases they are exposed to it is not so much. If they cross around a 50 to 100 laparoscopic radicals per year, I don't think even a robot is not necessary. You'll be as perfect with your laparoscopic skills than the robot itself. So at present, we should be, whenever there is no robot, laparoscopic radical prostatectomy is doable. Careful selection of the patient is very, very important.
Can I ask you one thing, sir?
Sure.
If I have to start a laparoscopic radical prostatectomy, what advice would you give to a starter, sir?
I would always advise, at least
any tips and tricks when you started first?
Number one, I didn't have this opportunity when we started the laparoscopic radical prostatectomy. I'll take a minute of my time, but I'll tell this. Number one, read the MRI properly. That is the landmark. That gives you a lot of information. I didn't have when we started it. Nowadays, we do read MRI before we start the procedures. Read the anatomy very well. Understand the anatomy very well. Read it through the video. That's number one. Number two, don't port. You see, majority of the times the mistake people do is port positioning according to the robot and do a laparoscopic surgery. That's not correct. The problem here is people are more educated on robotic port positioning than the laparoscopic port positioning. We need to look into how to port positions in laparoscopy. That is very, very, very important. It's not possible for me to explain everything now, but that is the most important. Spend some time. There are some videos on YouTube which shows this how to position ports for laparoscopy. Don't copy the same thing in robotic. Number three, do the port to posterior dissection first. That's the most important thing, as patiently as possible. The best posterior dissection, it is the easiest way to do a prostatectomy. Number four, make your pedicles as narrow as possible. The mistake what happens is incomplete lateral dissection, incomplete posterior dissection. You have a large, thick pedicles to be clipped, which cannot be clipped by your Hemolock clips at all. So make the dissection posteriorly as lateral as possible, laterally as low as possible. So the moment you lift the seminal vesicles at the end, you have a narrow pedicles which can be easily tripped. That is one thing which you should understand, which majority of the times people fear of doing it, and then they have a large pedicles and it becomes messy to clip those pedicles, or you end up in having 5-6 Hemolocks this side or a 5-6 Hemolocks on this side. What all you require, if you really correctly do it, it will be only 2 or 3 Hemolocks on either side. You don't need more than that for that pedicles. You should understand the lower half of the prostate doesn't have any attachments, no vessels going into it. So only 2 clips at the base of the prostate. Rest all can be stripped and the whole prostate can be, it comes out as enucleated. And the last point is, as I said, the most respectable tissues are the periurethral tissues. There's no point having a nice stump of the urethra completely barren. I would say a good stump of urethra with all the tissues around the urethra is the most important point of continence. People will strip it off completely and the whole nerves and the muscle of the urethra is completely stripped away there. It is not good. So have a nice urethra with the good tissues around. Rather, don't compromise on the apical dissection at the same point. Suturing is at the end of the day, it is you to practice and understand how to suture it. It cannot be said or it cannot be done without a practice. I think these are the tips which I can give regarding radical prostate is concerned.
Can I any from the audience? Can we take some questions from the audience?
Sure, please, definitely.
Sir, there are no more questions. We'll move to the other topic of presentation by Yuvaraja on robotic radical prostatectomy by TV Yuvaraja.
Excuse me, Doctor. Just to introduce Dr. TV Yuvaraja. Dr. TV Yuvaraja. Sorry, Dr. TV Yuvaraja is a renowned uro-oncosurgeon from Kokilaben Hospital, Mumbai, India, and he'll be talking on robotic. Okay. robotic radical prostatectomy. Please start.
Good evening. At the beginning, so I would like to thank Nepal Urological Association and Dr. Bojraj and Dr. Pawan for inviting me for this video talk. So in this video, I'll be showing important and silent steps of robot-assisted radical prostatectomy. So we'll start the video. So now we know that robotic radical prostatectomy is the standard of care now for the surgical treatment of localized prostate cancer. So in brief, the port placement is depicted in this picture. So we have both XI and SI WNC systems. So this picture depicts the port placement for XI. So the difference is just a little triangulation in SI. Otherwise, the ports are the similar one. So 8mm central midline port for the camera, and I use 2 ports on the left side and 1 port on the right side. So these are the yellow depicted are the robotic procars, and then I generally use 12mm right side one assistant. If there is a need, then we use a 5mm assistant if the patient is obese or it is becoming difficult. So this is the port placement configuration. So this is the patient position, steep tendon position. So most important. So rather than tying, sometimes we tie like this, or sometimes we put the shoulder support so that the patient don't slip back. So that's very important because sometimes the patient can go down and then it will be difficult. And then for the better understanding, so I divided them in briefly into 10 steps. So I will discuss each step once we go and discuss in the video. So the most important is that, so now when we work around the bladder neck, especially for the continence, to preserve the continence mechanism as well as preservation of the neurovascular bundle. The first step I do, this is the transporitoneal surgery. So I do the standard one, so I don't do any radius sparing or perineal approach. The first is to identify the posterior plane posterior to the seminal cycle and the vas deferens, and then identify the anterior surface of the rectum and the generalus fascia. If we can see that, once we do that, then I dissect the seminal cycle. You can see this is the left seminal cycle and the vas deferens which I'm dissecting. And we dissect it till its entry to the prostate gland so that it becomes easier. And this is on the right side. You can see that we are dissecting the vas deferens. And when we do vas deferens, we go directly so that the seminal vesicle becomes lateral. So you can see that. So that is the right seminal vesicle. And once this is done as a first step, then the second step is to create a perivesical dissection or a lateral pelvic dissection. So this is necessary for the lymph node dissection, but in the beginning only I dissect it and keep it. You can see that this is the right external iliac artery, right external iliac vein, and we enter this is the medial umbilical ligament, and we enter the lateral pelvic or paravesical space. So that is done on both the sides. And while doing so, we take again the vas deferens and cut it. So you can see that this is the left vas deferens. So we just buzz because it has got some blood vessels, so it is better always, otherwise it starts oozing. You can see that this is the left paravesical space which we create. Once we do these spaces, then the next step becomes very easy, trapping down the bladder. So we know that we don't go beyond certain limits. So that is to identify the boundaries, I always do the lateral dissection first, and then identify the bladder attachment to the anterabdominal wall and drop it down. So this is a very easy step where most of our residents do this step. You can see that. So once we enter the retropubic space, the next important is clear all the fat on the prostate gland and the anterior surface of the prostate gland. That is important because sometimes some people have a lot of fat on that, and then sometimes they also have lymph node in that. I think we have a couple of patients where lymph nodes are positive in locally advanced prostate cancer. The next step is to identify whether you can identify the fascia. So this is the fascia which we have to preserve for the neurovascular bundle. So this is little. I can't say it's a very high release. I can say it's the mid release. You can see the boundaries here now. Levator ani muscle, endopelvic fascia which is cut, capsule with the nerve sparing. So this is the prostate gland. So this is how we do nerve sparing. You can do later on, or while doing lateral dissection, you can do that. Next, I concentrate towards the bladder neck. So how to identify the bladder neck? Little challenging, especially in patients with a lot of, it's an enlarged gland or a median lobe or a previous TORP. Otherwise, it is a little bit, challenging. So if you can see that, so I am cutting the identified by putting a traction on the catheter and also pitching the bladder neck between two instruments. And once we do that, I usually try to preserve the bladder neck as far as possible. Almost we can do it 70 to 80% of the times. If you are unable to do that, we have to reconstruct it. So that I feel personally, bladder neck reconstruction or preservation is a very important part during to prevent continence. So that's how we do it. You can see the boundaries, bladder neck, and this is the posterior bladder neck which I'm cutting. So I just pull the catheter out and do it, and then I don't catch the catheter. So I just do it directly. So there is no need to do that unless it's a very large gland or, it's very difficult to do it. And then go to the posterior plane. Once you go to the posterior plane, very important, you don't look at the prostate. It's the principle. Don't look at the prostate. You just take the good thickness of the bladder wall. Then you'll be able to identify the plane. If you looking at the prostate, then it will be many times either we enter the bladder or enter the prostate. Then the lateral dissection, these are the few detrusor muscles, you can see that. So generally, if we are doing nose preservation, when we go to the lateral, this thing, so usually we try to avoid cautery. So here I am using very minimal cautery. So you can see that either I use Ethicon clips or sometimes we use Himola clip. So if it is the thin, if it is a thin pedicle, then I use regular clip. And if it's a thick one, you can see nicely the prostatic surface, and you can we identify. This is a very important step where we identify the lateral pedicles. You can see that. So this is we have already dissected earlier, so that subneurological plane or rectal plane becomes easier. And the laterally, you identify all the, which have already dissected and break it down. You can see that and identify, and then try to avoid lot of cautery in this area. Sometimes you may have to use the if there is any bleeding or the point of bleeding, you can bust them off. Otherwise, there is no need to do that. So once we do the posterior dissection and the pedicle, then we do the DVC, ligation and cutting. You can see that first we cut the prostate ligament close to the prostate, and then you can keep on cutting it. So usually, because here we increase the pressure to 18 millimeter of mercury, so there is no bleed unless there is arterial twig in the DVC. So once we do that,
Thank you very much, Dr. T.B. Uraza. It was really a nice display on the important steps of robotic radical prostatectomy. We don't have much time to discuss on things now, so we'll take a little detour and call upon Professor Dr. Amlesh Seth from All India Institute of Medical Sciences, New Delhi, to speak on open radical nephrectomy with IBC thrombectomy, techniques, challenges, and troubleshooting. The floor is all yours, Amlesh, sir. Amlesh Seth, sir.
Thank you so much. I must thank the Nepal Association of Urological Surgeons, Professor C.S. Agarwal, the president, and Dr. Pawan Raj Chalise, Dr. Bhojraj. They've all been very, very close friends for decades, I would say. I have very close association with the Nepal Association of Urological Surgeons and Nepal by itself. I will quickly begin my presentation. Can you see my screen? Can you see my screen?
Yes, sir. This is visible.
Visible. So, okay, so I'll begin. Okay, so the topic that has been given to me is open radical nephrectomy with IVC thrombectomy, techniques, challenges, and troubleshooting. Greetings from the All India Institute of Medical Sciences, New Delhi. We know that 2 to 3% of adult malignancies are renal cell carcinomas, and amongst all the urological malignancies, it is the most lethal. And IVC thrombus is seen in about 4 to 10% of these patients. The IVC thrombus can go all the way up to the right atrium and even beyond. I have seen one going up into the pulmonary artery without lymph node or systemic metastasis. If patients present with lymph node metastasis or systemic metastasis, then the prognosis becomes very poor. But in the absence of lymph node or systemic metastasis, even in the presence of the thrombus going as high up as the right atrium, if a good surgery is done, which is technically challenging, the long-term prognosis can be reasonably good. The preoperative workup, the standard workup includes chest X-ray, LFT, RFT, ECG, hemogram, and CT abdomen. But in these patients, because the surgery is much more challenging, CT chest should be added if there is any doubt of metastasis. And for patients who have a level 4 thrombus going up to the atrium, a coronary angiography, either a CT angiography or the direct standard coronary angiography should be done, because if they need a CABG in addition, then CABG can be added relatively easily in the presence of this extensive surgery. It is a practice to get a Doppler ultrasonogram done the evening before to know the exact upper level, because the surgery depends upon the exact upper level of the tumor. Usually, if it is within the abdomen, the standard incision is bilateral subcostal or chevron. But if the patient is really tall and thin, a long midline incision may be preferable. And the right thoracoabdominal for right-sided, mainly upper polar tumors, if a control above and below would be better provided by right thoracoabdominal, although right thoracoabdominal becomes more painful compared even to the bilateral subcostal. And those who have the thrombus going up to the atrium, not only a long midline laparotomy, but a midline sternotomy is also required in addition. Early arterial control is of utmost importance, because 10% of the cardiac output flows through each kidney, making a total of 20% of the cardiac output through both the kidneys. And this cardiac output increases significantly if there is a large renal tumor. And within the tumor, we know in renal cell carcinomas, there is a lot of AV shunting, which further leads to an increase in the arterial flow. And the venous obstruction leads to significant dilatation of all the venous tributaries. And if the venous tributaries are ligated before taking the artery under control, then these tend to rupture, increasing the blood loss. We must also keep in mind that in about 20 to 25% of the patients, there are so-called accessory renal arteries, which are also the definite renal arteries supplying the kidney. These may be small ones, either above or below the main renal artery. And these ones also need to be taken care of as a part of the early arterial control. This is a video showing how to achieve early arterial control. The left renal vein is the key. So after dividing the posterior peritoneum just medial to the inferior mesenteric vein, the left renal vein has to be identified. Then the left renal vein has to be lifted and the aorta has to be identified. Or we have to go on the right side of the aorta for right renal artery and to the left of the aorta for the left renal artery. The control of the venous system depends upon the level of the upper level of the thrombus. So the approach will depend upon whether the thrombus is finishing within the renal vein or it remains intrahepatic or intrahepatic. In intrahepatic, we have to decide whether we'll be able to dissect the upper level within the liver from below, or we need suprahepatic control. If we need suprahepatic control, and then in that situation, aorta also has to be cross-clamped. And in that situation, we take the help of the liver transplant surgical team. If it is suprahepatic or going intra-arterial, then we post these patients in the cardiac surgery OT along with the cardiac surgery team. If the thrombus is still the renal vein level, then the most important thing is to have a good clearance of the IVC above and below, and a very large Setinsky should be put in, because if you need a large Setinsky, because you need a good cuff of the IVC to suture. Otherwise, if the IVC wall slips into the Setinsky, then you are in a lot of trouble. And I'll not be talking about troubleshooting, but if you actually land up in trouble, then you are in a lot of trouble. It's very difficult to get out of trouble. So most important thing is to prevent landing up in trouble. So for that situation, you must have a very large Setinsky to prevent slippage of the IVC wall into the Setinsky's clamps. And the next video will show how it is done. Here you can see a good part of the IVC above and below has been dissected and a large Setinsky clamp has been applied. When you are cutting the renal vein, forget that you are a uro-oncologist. Think like a vascular surgeon. Try to preserve the vein because you need the vein to suture it up. Otherwise, like a uro-oncologist, if you do a very wide excision, then you will be in trouble. Next, if it is infrahepatic, then complete mobilization, after complete mobilization of the tumor, when the tumor is left hanging on the IVC, then we need control of the IVC above and below the thrombus, and we also need to control the opposite renal vein. The lumbar veins, as many as can be seen and as many as can be ligated, they should also be ligated, because despite the control above, below, and of the opposite renal vein, the lumbar veins lead to so much of bleeding that till the time you sew back the IVC, they keep on bleeding, and it becomes like, you know, movements full of tension. The cavotomy should be kept as small as possible, because till the time you control you sew up the IVC, bleeding will continue. For left-sided renal vein, left-sided tumors, they bleed a lot because controlling the right renal vein is sometimes not adequate, because despite controlling the right renal vein, there would be a lot of collateral bleeding going on from the adrenal vein and the lumbar veins. There, in that situation, sometimes the right renal artery, in addition to the left renal artery, may also have to be clamped, and the right renal artery should also be kept exposed, so that if there is a bleeding which is significantly more, then the right renal artery should also be clamped. Sometimes it is also wise to keep the supraceliac aorta under control, and in a desperate situation, if you just clamp the supraceliac aorta, your field will certainly become significantly better. And that is sometimes what we do in patients who have level 3 thrombus going up into the intrahepatic part, and when we have to control the suprahepatic IVC, we also usually clear the supraceliac aorta and keep a cross clamp ready in that area, just in case we land up in a lot of trouble. Sorry, the last video here. I don't know why this video is not coming. Anyway, so let's go ahead. There's some trouble. Why my video is not coming?
I think so. You have to off the screen share and again start with that. Again share the screen.
Okay, let me do that. Stop screen and then I begin again. Okay. Yeah, something is coming. No. Okay. If there is a 2 centimeter gap available between the point where the hepatic veins are joining the IVC and then intrahepatic dissection of the IVC can be done. And usually the plane is well defined between the IVC and the hepatic parenchyma. There would be small tributaries from the liver into the anterior and lateral surface of the IVC. Usually the posterior surface will not have any tributaries, and you need to dissect the IVC all around within the parenchyma. And this kind of a dissection is possible almost till the hepatic veins. And then you can have a good part of the IVC to cross clamp. And then the subsequent steps become like the intrahepatic IVC. I don't know why these videos are not coming. Okay, I think I will skip these two videos. I'll
So you can continue with your other slides in the meantime.
Yes, I'll do that. Okay, if the gap is less than 2 centimeters and you think that with intrahepatic dissection of the IVC, you will not be able to reach above the thrombus, which then you have to control the IVC above. And you have to put a cross clamp just inferior to the diaphragm. And there we take the help of the hepatic transplant team. They dissect the suprahepatic IVC for us, and the porta also needs to be cross clamped. Then for that, what they need to do is they need to completely mobilize the liver by ligating the ligamentum teres hepatis, the falciform ligament, and the triangular ligaments. Now the Pringer's cross clamp actually cannot go on for more than 20 minutes. Otherwise, there will be a significant degree of hepatic necrosis. So once we have put these clamps, then there are two ways to proceed ahead. One is then that we quickly dissect intrahepatically and put the cross clamp as we had done in the previous situation, or we open the IVC and take out the entire thrombus and sew back the IVC. As I told you previously, in this situation, sometimes there is a massive bleeding that continues despite all these cross clamps, which means despite the porta cross clamp, suprahepatic cross clamp, inferior IVC cross clamp, and opposite renal vein cross clamp. In this situation, what we generally do is we keep the supraceliac aorta also ready, and then in that situation we cross clamp the supraceliac aorta, and once we have taken the thrombus out, and we quickly sew up the IVC, and all this should get completed within a period of 20 minutes, and generally we are able to complete all this within a period of 11 or 12 minutes. Usually even 20 minutes are not required. Speed is very important, and here comes the importance of the team. Every member of the team must work in synchronization with each and other person, and there must be a perfect understanding, and all these steps must be rehearsed, and everybody should know what one is going to do in that situation. I don't know why my slides are not moving. Every time do I have to stop share and go back?
So your slides are equally good. So maybe we can continue with the slides.
Okay, but even my slides have stopped moving. I don't know why.
Can we do a slideshow?
Okay.
Yeah, we can do a slideshow. Hello, Amrit sir. I think you'll have to restart again. Stop slide share and then restart.
Okay, I'll do that again. Yes, now this video has come. I don't know how it has come. It was this video which, so here you can see there is a control above and a control below and the opposite renal vein. The tumor has been taken out and now you can see that this thrombus is being taken out from within the IVC and the edges of the IVC are being freshened. And here, this is what I was telling you, that if the lumbar veins are under control, then you don't have much bleeding. But if the lumbar veins are not under control, then till the time you sew up this IVC, the bleeding will continue. If there is a distal gland thrombus, and the IVC is completely occluded, then the IVC below should be ligated completely. There's no point taking out the bland thrombus because it is not malignant. And if you take it out, it will reform very early in the post-operative period. And once the upper part of the IVC is deblocked, the risk of pulmonary thromboembolism would be very high. And in situation where the IVC is not completely occluded, still it is wiser to ligate the IVC completely because pulmonary thromboembolism is life-threatening. And the only disadvantage that this patient will have is that this patient will develop bilateral pedal edema, which would last for a period of about 2 to 3 months. And slowly with time, the collaterals will open up and the pedal edema will go away. So this was actually a video showing a suprahepatic control. You can see the liver and the liver transplant team dissecting the IVC above between the diaphragm and the liver, and then the control. But this video is very heavy, so I'm not showing this video. I'll go on to the next slide. Okay, so this is a patient who has a thrombus going up till the point where the hepatic veins are opening into the IVC, and suprahepatic control was reasonably dangerous, and therefore we went ahead with a long midline sternotomy as well as midline laparotomy, and the IVC was controlled within the pericardium. And once the IVC was controlled within the pericardium, we could take out the entire specimen in one go. Here you can see there's a big thrombus which was taken out from the suprahepatic part of the IVC. Now for an intraatrial thrombus, the commonly described technique in the textbook is what is described as cold hypothermic circulatory arrest with exsanguination, which basically means that the patient is put on cardiopulmonary bypass and then cooled to a temperature of 18 to 20 degrees centigrade. This is cold. This is deep hypothermia. And then after deep hypothermia, the patient is exsanguinated. In exsanguination, the arterial inflow into the patient is stopped. The venous outflow from the patient into the heart-lung machine continues. And after exsanguination, the heart-lung machine is also stopped, which means that the patient is under complete circulatory arrest. And then under a situation of complete circulatory arrest, the atrium is opened, the IVC is opened, and the entire thrombus is taken out. Now, this is something which we don't do. What we do is, our modification is that we put these patients on cardiopulmonary bypass, but we cool these patients to a temperature of only 31 to 32 degrees centigrade, which is mild hypothermia. And after that, we carry out a partial circulatory arrest, which is in the form of cross clamping of the supraceliac aorta. And the heart-lung machine continues. With this, the blood supply to the central nervous system, the coronary circulation, the bronchial circulation, and the upper limb musculature continues. The most important is the circulation to the CNS, followed by the circulation to the coronaries. And in this video, you will see that this is a patient who had a left-sided tumor. Left-sided radical nephrectomy has been done. The IVC below is soft. A mid-sternotomy has been done. And this is the dissection of the supraceliac aorta. Just below the diaphragm, the aorta has to be dissected from the crura of the diaphragm, and the aorta can be cross-clamped there, and there can be complete circulatory arrest of the lower half of the abdomen. So now the patient is being put on cardiopulmonary bypass. This is below the lower part of the IVC, that was the upper part of that was the SVC. Once the patient is put on cardiopulmonary bypass, then the patient is cooled to a temperature of 31 to 32 degrees centigrade. And then at that time, the IVC below and the right atrium is opened after the partial circulatory arrest, after the cross clamping of the aorta. With this, the degree of bleeding is significantly low, but it is not zero. And therefore, there has to be a sucker in the IVC below, which will keep on sucking blood into the heart-lung machine. But you can see that the degree of bleeding is not very massive. And this is the suction, which is sucking the blood, and the field is relatively bloodless. So this is the right atrium that is opened up. Some part of the thrombus which was remaining in the atrium that has been taken out, and the sucker from the lower part has come up into the atrium. And now this is the gauze piece being put from above down below, and whatever small tags are there, they also have been taken out. And now the entire all the vena cavotomy and atriotomy, they are being closed, and cardiopulmonary bypass is being reversed, and the patient is being taken off the cardiopulmonary bypass. In the last about 25 years or so, we have done these many cases. You can see we have done 24 intraatrial with the help of a cardiac team, and about 11 with the help of our hepatic transplant team. And the median survival in patients who have a lower level thrombus is about 70 months, and the median survival in patients who have upper level thrombus is about 64. We lost one patient in the lower level thrombus. We lost 3 patients in the upper level thrombus in the perioperative period. The other complications have not been very major. The blood loss, one patient had a blood loss of almost 4,500 ml.
Sir,
And,
can I interrupt for something?
Yeah, thank you.
Okay, thank you. I was just trying to ask how many slides you have left.
No. Thank you very much.
Thank you very much, Mr. Kamlesh, sir. Actually, we're extremely short of time, sir. We're lagging behind by almost 20 minutes, so we'll have to go to the next topic. Thank you once again, Amlesh, sir. Thank you very much from NAUS.
Okay, thank you.
Okay, the next speaker is going to be Dr. Subhas Pandit from Nepal, and he'll be speaking on radiotherapy for carcinoma prostate, cure to palliation. Dr. Subhas.
Welcome, everyone. I would like to thank NAUS for organizing this hybrid conference in this difficult time. My name is Dr. Subhas Pandit, and today I am going to talk about role of radiation in management of prostate cancer, from cure to palliation. Talking about local treatment options in prostate cancer, there are standard of care treatment options like surgery, radiation in form of external beam radiation or brachy. Welcome. It comes in mainly 2 flavors, external beam radiation and brachytherapy. In external beam radiation form, as well as reversible in medical way. In medical type, it can be androgen deprivation in form of GnRH agonist and antagonist, or anti-androgen, which inhibit the synthesis of testosterone or block the receptor. There are old generation drugs like ketoconazole and bicultamide, and newer generation drug like abiraterone and enzalutamide. Now coming to the management depends on risk group. Patient can be of localized disease, locoregional disease, or metastatic. Localized disease can again be divided into 3 subgroups based on T staging, Gleason score, and PS. So how to tailor treatment according to risk stratification? Some treatment like active surveillance
we're experiencing some technical glitches. So we'll have to go to the next session. And to conduct the next session, I would like to call upon Professor Dr. Uttam Kumar Sharma, Professor Dr. Parasmani Shrestha, and Dr. Manish Shrestha to conduct the session on carcinoma urinary bladder.
Ladies and gentlemen, without delay, I would like to call upon the next speaker, which this is the session 4 in the carcinoma bladder session. So I would like to invite Hemant Tandodkar from India. He's talking on open radical cystectomy with Studer new bladder step by step. Hemant Tandodkar. Is not available? Oh, okay.
In this conference, and it's a real privilege and pleasure for me to be here to speak on ileal orthotopic neobladder, a topic which is very close to my heart because it was our team that developed neobladder first time in India way back in 1987. Well, we know that not all patients after a radical cystectomy are suitable for a neobladder, and there are certain patient factors and tumor factors which are necessary before one says that this patient can have a neobladder. The patient must have adequate hepatic, renal, and bowel function, adequate function of the rhabdosphincter. He must have adequate manual dexterity for clean intermittent self-catheterization if it's required, and he must also have not a one-time procedure. It requires careful monitoring about the oncological and functional outcomes for a long time. As far as the tumor factors are concerned, the only thing that one needs to ensure is that there is no disease in the urethra, which you can do either preoperatively by taking a biopsy from the prostatic urethra, or what I prefer is doing an intraoperative frozen section to ensure that the urethral cut margins are free of tumor. The reservoir should have an adequate volume, low pressure in all phases of filling, but must have adequate pressure at capacity to empty the bladder completely. Now, any segment is fine so long as it fulfills these requirements, and many people have used different kinds of segments and with equally good functional results. The technical specifications were not matching this platform. So I have borrowed this video from Dr. Ganesh Bakshi, professor and head of Uro-Oncology at Tata Hospital, and his associates, who have been nice enough to allow me the use of their video. It's the same as what we normally do. Isolate a segment of distal ileum about 15 to 20 centimeters away from the ileocecal wall, and the segment should be consist of about 55 centimeters of unstretched bowel, and the 40 centimeters of this is reserved for making the neobladder, and 15 centimeters remains unopened to form a chimney. Now, the length, you can take a slightly longer length if you think that the mesentery is short, so that the extra length will compensate for the shortness of mesentery, and you will have no problem in reaching the urethra. Now, as far as mobilization of this segment is concerned, the distal mesoileal window should be deep. It should be long, so that there is good mobility that you can get. While the proximal window, as you can see, is much shorter, this ensures that the blood supply to the reservoir containing ileal segment is adequate. Once we have ensured that the ileal loop is reaching the urethra properly, like this, placed along the anterior mesenteric border, posterior plate or the posterior wall of the neobladder. This is done by using either 2-0 or 3-0 Vicryl, continuous suture, and then I usually take some buttressing or reinforcing sutures. So, ileal anastomosis is done in a standard fashion as you would do for an ileal conduit after spatulating the ureter. Continuous suture or interrupted sutures, my own preference is interrupted 4-0 Vicryl sutures. And then the anastomosis later. You can even take a stitch here to fix the stent to the ureter using plain catgut, and then the ureteric anastomosis is then completed. I usually take a second layer of periureteric tissue just to take the tension away from the ureter, from the anastomosis. And this ensures that you won't ever get a leak from this anastomosis. The second ureter is also anastomosis exactly a similar fashion. The next step is then the folding of the neobladder wall upon itself. By doing this, we are also partly, imagining reconstruction of the anterior wall, and we find out the segment of the unopened of the open segment, the part which reaches the urethra with the least possible tension. Some people here they excise a disc of about 1 centimeter away from the suture line and suture that disc, that opening, to the urethra. Now the problem here is the urethral anastomosis, the urethro-ileal anastomosis becomes narrow, about 1 centimeter, and which we follow now, is we anastomose the posterior wall of the pouch directly to the urethra. So this gives much better flexibility that you can really choose at the last moment which part you want to anastomose to the urethra. Secondly, you can take nice wide bites on the posterior plate so that the caliber of the urethro-ileal anastomosis is nice and wide. And you can see here the posterior wall has been taken, and we usually use continuous 2-0 monofilament sutures with 5/8 circumference needle going from 9 o'clock to 3 o'clock, and then along the anterior wall from 3 o'clock to 9 o'clock. This is where you start reconstructing the anterior wall of the pouch. At 3 and 9 o'clock position, you can see that you get a very nice wide urethro-ileal anastomosis, which is absolutely secure under vision. And then the same suture is then continued proximally either do with 30 or 20 Vicodin, and then buttressing sutures with PDS are then taken. Here the pouch is being completed. Ensure then that it's a watertight closure, and then the ureteric stents are brought out into the right iliac fossa at an appropriate point. We also confirm that the lie of the neobladder is good, the hemostasis is proper, and then we close the
So first, I would like to thank the organizing committee of the Nepal Urological Association for inviting me to be with you in this meeting. And it's my pleasure to present the lab radical cystectomy. And I'm Professor Ali Abdul Karim from Alexandria University, Egypt. As you know, that the incidence of bladder cancer in Egypt is quite high. And we do those cases by laparoscopic approach quite frequent. So our routine is to use from the 3 to 5 ports. We put them like the radical prostatectomy in semicircle pattern, starting from the umbilicus. However, the camera port we inserted above the umbilicus to be able to get the urachus. In this video, I'm going to show you the steps of the lab radical cystectomy step by step. And here we are inside the abdomen of the patient. This patient has bilateral inguinal hernia. And what we do is to do an incision of the lateral peritoneum, just lateral to the medial umbilical ligament. It's here to get the vas difference on the right side. And we can control the vas difference either by the ligature or by using the hemoclips. Then we make an incision downwards, just lateral to the medial umbilical ligament. This is the medial umbilical ligaments until we reach the distal end of our dissection, which is the pubic bone. During our dissection, we combine both sharp and blunt dissection using the ligature. And by this, you will see we can have a bloodless field. Then we extend our dissection upwards along the iliac vessels until we reach the common iliac vessels. Then we just medial to the iliac vessels, we go deeply until we see the obturator fossa with its content. This is the most posterior part of the limit of our dissection. As long as you go on the right plane, you will have a loose order tissue. This is the obturator nerve. And we make an incision along the posterior aspect of the bladder at the rectovesical pouch until we reach the midline. Then we repeat the same procedure on the left side. We identify the vas difference, we get it, and we dissect it. Then we control it with the ligature. And again, we extend our incision along the iliac vessels. Here we do a mobilization of the rectosigmoid medially. This is the left external iliac vessels. Then we go just medial to the external iliac vessels again to reach the obturator fossa on the left side. Here you can appreciate the obturator nerve on the left side. This is the limit of our posterior dissection. Then again, like on the left side, right side, we do the same on the left side. We make a transverse incision along the posterior aspect of the bladder until it meets the other side in the midline. Now the two incisions meet in the midline. Then the posterior peritoneum covering the bladder is mobilized medially and posteriorly. Then we start looking for the ureter. This patient has a trigonal tumor and it was on the left side. That's why the left ureter was hugely dilated. As you see, it was obstructed by the tumor. We dissected the ureter downwards until the site of its insertion into the bladder. And we do the same on the left, on the right side. This is the right ureter, it was not dilated. And we go downwards until we reach its insertion into the bladder. Then we enter the posterior to the bladder and we could identify the adenonovillary fascia. And we incise it. We go between this fascia and the bladder. Now we have the two lateral pedicles on the both sides because we did the posterior dissection and the lateral dissection. Yeah, this is the adenonovillary fascia. Then we divide the ureter. We either use the ligature because by the end we do trimming of the ureter and we take its distal end for histopathology, or we can use clips. Then we start division of the lateral pedicle by using the vessel sealing instrument. As you see here, tissue sealing instrument, we have a bloodless field, and we do the same on the right side. This is the right ureter. This is the superior vesical artery. Then we do in-block dissection of the lateral pedicle using the ligature. In fact, compared with the open surgery, as you see, we have almost bleeding as long as we go on the right plane and we are using tissue sealing device like the ligature or harmonic or the whatever the way you use. So, and of course, laparoscopy allows you to go deeply and you see all details of the anatomy in the pelvis, which is hard to see with the open surgery. Then we reach it downwards until we reach this is the endopelvic fascia, and this is the obturator internus muscle. We keep going posteriorly until we reach the apex of the prostate. This is the prostate here. Now we reach the apex of the prostate posteriorly. Then we start doing the anterior dissection of the bladder, taking the all surrounding areolar tissue on both sides. And as you can appreciate here, now we go with the camera port into the port itself to make sure that we are taking the urachus in block with the bladder, with the specimen. to ensure the radicality of the procedure. Now we reach the periprostatic plexus of veins surrounding the veins and the fat. And again, we control this with the diathermy. Then we start exposure of the endopelvic fascia, and we sharply incise the endopelvic fascia on both sides. This is the prostate here after incision of the, and we do the same on the right side. This is the deep dorsal vein complex. And this is the obturator, the endopelvic fascia on the right side. Then we divide the puboprostatic ligament. It's in the midline. This is the symphysis pubis here, and this is the prostate, and upwards is the bladder. This is the prostate with the dorsal vein complex. Then this is the endopelvic fascia on the right side. We do more exposure of the dorsal vein complex. And our routine is to use sutures, or in this patient, we use the ligature for control of the dorsal vein complex. We can use also the argon beam for surface coagulation after division of the dorsal vein complex by the ligature. And we keep our dissection downwards. This is the urethra, and we start sharply incising and dividing the urethra by the scissors. This is the Foley's catheter. We divided the anterior aspect of the urethra. Then we divide the Foley's catheter to ensure complete dissection and division of the urethra. While doing this, we grasp the distal end of the Foley's catheter with a grasper to avoid any spillage of the tumor outside of the bladder. Then the posterior aspect of the urethra was sharply divided. And now we are dividing the final part of the specimen at the apex, and this is the final view of the pelvis after doing the radical prostatectomy. And subsequently, we do the pelvic lymphadenectomy, and our routine is to do pelvic lymphadenectomy after finishing the cystectomy. Finally, I would like to thank you for the invitation and for your attention.
हलको आवाज बाहिर आइरहेको छैन सुनिन्छ
David Winkley from Australia. I think he's a past president of Australian Society of Urologists. He's talking on reconstructive option for the failed bladder post radiotherapy for pelvic malignancy. I would like to welcome Dr. David Winkley to this conference. Thank you very much for joining us.
Thank you very much for inviting me to this conference. It's a great honor, and I would have been delighted to have attended in person. I imagine that COVID is going to play havoc with our conferences for a year or two yet. I will just endeavor to share my screen. And I might need some help for getting my presentation. Can one of the people on that end just tell me what button I need to push to achieve? getting my
Let's here on the
PowerPoint.
slides here and share your screen.
So I push the share button.
And then again share on the right hand side down.
And it says open system preferences.
No, it's not visible, sir.
I'll just see.
So you just need to do the slides here.
Share screen button at the bottom of the Zoom platform.
It says
On the
share
Zoom screen. On the Zoom screen, can you click the share screen button? Share screen.
Yeah. Share screen. Yep.
And then share desktop. And then again, you have to click share.
And it says allow Zoom to share my screen. Open system preferences. Sorry about this. So I have to push Zoom.
You have to open your slides on this desktop first of all. And
Yeah,
then
they are.
come back
They're
to
open on the desktop. Yep.
Then come back to share screen and there should be something visible that you can double click.
Can you see that at all?
For inviting pelvic malignancies occur in all ages.
Are you seeing that? Or?
No, we are hearing, not seeing.
Sorry, I recorded it. I do beg your pardon for this.
Not a problem.
I'll go back to share screen.
Dr. David?
Yeah.
Professor David, yeah. In the Zoom platform, just on the bottom, there is share screen icon is there. You just click that. Share screen.
Yep, I've got share screen, but it just gives me a white thing that says share, but not.
So what you can do is you minimize the Zoom and go to desktop and open your PPT or whatever file is there. Minimize Zoom, yeah. So that you will be out of scene, yeah. Yeah, the same thing we are taking.
Hello, sir.
Yeah.
You need to minimize yourself now. Are you using Mac or?
Yeah, I'm using a Mac.
So please minimize the Zoom. First.
Yeah, it's minimized.
Somehow we are not being able to see your laptop, the laptop screen. So I think you need to minimize.
Pelvic malignancy.
I keep opening it, and so I have minimized both myself and the Zoom. I do beg your pardon from this.
Yeah.
Open.
So first you need to minimize, and then you open your PowerPoint, and then at the bottom of the Zoom platform you have a share screen button, which you have to press.
So I'm in my PowerPoint presentation, and I don't know where the share screen thing is there. I'm sorry.
Yeah. Unlock the minimize Zoom. Could you please unlock the minimize Zoom? Can you maximize the Zoom now?
Yep. So can you see me now?
Dr. David?
Yeah.
Sorry, due to those time crunches and technical hitches, what we request to you is that please do Zoom recording today in your feasible time.
Yes.
And tomorrow we can do on air with some feasible time. Do
Okay.
connected with us. Thank
I
you
do
very
beg
much.
That's a pleasure. I do beg your pardon.
Yeah, you take time. Thank you very much. So
Okay.
this comes to the conclusion of the uro-oncology session. I would like to thank all the chairpersons. They have given valuable time and comments, and all the delegates from different parts of the world. They have enlightened us in different aspects of the uro-oncology. Stay safe. Bye-bye for this time. Thank you very much.
Very warm welcome. A very good evening to all the enthusiastic delegates. And now we'll be starting the next session on behalf of Nepal Association of Urological Surgeons and the International Society of Reconstructive Urologists. I would like to call upon the chairpersons, Professor Dr. Bolaraj Joshi, Dr. Gunakumar Shrestha, and Dr. Sanjay Balwant Kulkarni to chair the session on reconstructive urology. So, B.R. Joshi, sir, the floor is all yours. You'll have to chair the session and start the session, I guess.
Dr. Joshi? Hello?
Hello. Hello. Professor Kulkarni is there, virtual?
Yes, I'm here. I'm
Okay.
here. I can hear you.
Yeah, you can hear. So welcome to the NOWS program, and it is a ISRO, that a reconstructive urology session, and you are the master of this reconstructive urology, particularly in the urethral aspect. So welcome to the conference. So it's my pleasure, and you take the floor, Professor Kulkarni, and just start the session. And I would like to invite first Pawan Raj Chalise. He's the General Secretary of the NOWS, and he's the main person behind this type of the conference, that the hybrid conference. So over to Professor Kulkarni first, and you will have some word to and message to our all fellow. Over to Professor Kulkarni.
Yeah, thank you, Dr. Joshi. I welcome all the members of Nepal Urology Association and SAUS for this combined meeting with ISORU. International Society of Reconstructive Urology was started a few years ago. The idea was to propagate live surgery workshops around the world, and the founder members are Professor Mandi, Professor Barbagli, Sanjay Kulkarni, Pankaj Joshi, and others. And we have been conducting live surgery workshops around the world. Unfortunately, because of COVID, we can't do that this year, but we would like to come and visit Nepal, our favorite place to conduct a live surgery workshop. So we start the session today with Dr. Pawan Raj Chalise. Is going to talk about workup of patients of urethral stricture. With me is the secretary, Dr. Pankaj Joshi, secretary of ISORU. So Dr. Chalise, please.
Thank you, Chairperson, and very good evening. On behalf of organizing committee and as a convener of this session, I welcome you all to this NOWS joint session of NOWS and International Society of Reconstructive Urology session during UROCON 2021. I'm very thankful to the world-renowned reconstructive surgeons, especially Dr. Sanjay Kulkarni and Jalil Hosseini, and all my friends to accept our invitation to participate in this session. Today, in these 10 minutes, I'm discussing on workup of patient with urethral stricture. When we talk about the stricture disease and its management, this slogan holds true. We need to think fast, but we need to move very slowly. What we must know before embarking any surgical procedure is at least we should know exactly the location and number of strictures, the length of stricture, the density of scar, presence of any associated urethral pathology or bony pathology in pelvic fracture disease. The successful outcome of the treatment depends upon careful evaluation and diagnosis, accurate estimation of stricture length, the patient selection, and of course, surgical expertise and the high volume center. Workup of urethral stricture is done by the thorough history, meticulous physical examination, a battery of radiological imaging techniques, and the endoscopic procedure. In a history, we should ask about the onset of symptom, history of recurrent UTI, urethral discharge, any trauma to the perineum, penis, or instrumentation need to be documented. The history of CISC need to be documented as well. The erectile function, ejaculatory function is very important for outcome, and the patient counseling. The comorbidities like diabetes, hypertension, neurological disease, and personal history is also very important. In our part, especially the history of smoking and tobacco chewing is very essential for graft harvestment. In a meticulous physical examination, start from general physical examination. Abdomen should be palpated for any chronic urinary retention, and if the patient has a palpable bladder, it's always prudent to have the diversion done. The location of suprapubic catheter need to be noted. The patient need to be evaluated and examined regarding the genitalia, its redundant foreskin, meatus, and the whole of the urethra need to be palpated for any thickening or indiguration. Bogey tender swelling could be abscess, and it should be treated before any surgical procedure. Laboratory investigation include urine analysis, and the negative urine culture is mandatory. The selection of imaging methods depend upon the etiology, sites, patient general conditions, and obviously the cost. It needs to be considered in our part. The two defining events in workup of this patient are an elegant description of dynamic urethrogram described by McCallum and Colapinto in mid-1970s, and the development of flexible cystoscope. We have the list of radiological imaging, but out of that, the gold standard is the conventional imaging, which constitutes of retrograde uretrogram and the voidic cystourethropy. The dynamic urethrography represents a synergy of these two imaging techniques, retrograde uretrogram, which delineates the anterior urethral anatomy, and the voiding urethrography is done to assess for the posterior urethra in male. Who should perform and interpret the result? Obviously, the answer is it should be performed and interpreted by treating urologists, because in the study done by Batchby et al., concordance between independently reported length to intraoperative measured length has been shown to be very high with the urologist. This is the classical position to perform a retrograde urethrography. The dynamic image is seen as anterior urethra distance when 20 to 30 ml of contrast material is injected with gentle pressure. The Cooper's gland, periurethral glands of litters can be seen during this procedure. Voiding cystourethropy is done for evaluation of male posterior urethra and for the evaluation of female urethra. In the VCUG, bladder neck, bladder pathology is assessed, as well as the posterior urethra is assessed for stricture disease. If the bladder neck does not open during the procedures, we have the option of medication. We can use the flexible cystoscope and can visualize the posterior urethra directly, or we can inject the contrast through the flexible ureteroscopy, and dynamic imaging can be acquired. The limitation of RGU and VCUG are that periurethral pathology cannot be assessed by this technique, and it does not provide the degree of spongiofibrosis. Obviously, retrograde urethrography may underestimate the stricture length. Another beautiful workup of the patients can be done with the cystoscopy or urethroscopy. We need to have a small caliber ureteroscope or pediatric cystoscope for the evaluation of this disease, before embarking any surgical procedures. We can use the integrated flexible cystoscopy for the assessment of the posterior urethra, or we can use that flexible cystoscopy to assess the bladder neck competence or any fibrosis or scarring in the bladder neck. These are the prime concern for incontinence following surgery. Apart from these gold standard imaging techniques, we have other batteries of workup procedures like a symptom score, quality of life assessment, uroflowmetry, and other cross-sectional imaging techniques. Low Qmax and constructive pattern of obstructive flow pattern are compatible with the urethral stricture disease. The patient can have a continuous box pattern of uroflowmetry. The curve characteristics providing more useful than the maximum flow rate. You have to, this uroflowmetry can also be used in a follow-up of this patient. Sonourethropy give you the adjunctive technique in the evaluation of urethral stricture disease, is especially used for assessment of spongiofibrosis, which was first described by McNeice in 1998. Actual scar or the stricture length can be assessed. Along with that, it will give you any false passage or the periurethral abscess or any pathology can be assessed. Why we need a cross-sectional imaging like MRI or CT during the evaluation of the stricture disease is that sometimes the conventional radiography incorrectly estimates the length of a distraction defect, and it does not give the axis of prostatic displacement. Complicating features such as fistula, cavitation, diverticula, and the false passage may be overlooked. So MRI or the CT are the best ancillary imaging modality for assessing post-traumatic pelvic anatomy and prostatomembranous defect. It assesses the position of the prostate in a vertical and a horizontal axis and the amount of pelvic fibrosis. These can also be used as a predictor of permanent impotence in pelvic fracture urethral injury. Thank you. Thank you, my friend.
Thank you, Dr. Pawan Raj Chalise. Any comments from Dr. Gunasheshta and Dr. Joshi?
Nicely, he has said everything. So I would like to hear from Professor Kulkarni any more suggestions regarding the assessment of the patient, regarding the neurogenic bladder associated other thing.
For
So
neurogenic,
I would like to hear.
yes, so we have some patients of pelvic fracture urethral trauma who come with foot drop, and that may, this patient may have what we call hypotonic bladder, and then even after successful urethroplasty, there is a chance that he may not be able to pass urine. Our center popularized the use of a small caliber endoscope like a 6 French ureteroscope to assess the urethral stricture length and the quality of the stricture and to see the proximal urethra. So this has been now accepted worldwide, and I'm really happy about it. Any other comment, Dr. Joshi?
No further comment, yeah.
Yeah. So we go
to the next one.
So 2 years
Yes,
ago,
Pankaj, yeah.
2 years ago, we would have introduced Mohammad Nafi as a shy endourologist who was just silent in the OR. But what has transformed is his journey in Pune at the Kulkarni Institute. Now he's roaring as a tiger, performing superb recon procedures in Egypt, and invite our friend, our colleague Nafi to talk about his journey from a fellow to a consultant and now so famous on the YouTube with his videos.
I just want to tell my friends there that in last 10 months, in spite of corona epidemic, COVID epidemic, he has performed 250 urethroplasties in Egypt. That's congratulations, one of the highest number in the world. So Mohammed,
thank you, sir. Yeah, sure. I am Mohammad Nafi, a reconstructive urologist from Egypt, the GRS Fellow at Kulkarni Center 2019-2020. My talk, first of all, I would like to thank the Nepal Urologic Association for this opportunity to participate in UROCON 2021. My fellowship, the life-changing journey for me. An overview, I will speak about myself before the fellowship and what I gained from my fellowship and what I did after I went back home finishing my fellowship. The most in Pune, India for 3 months, and the most important one was in 2020 and 2019, when I was GRS clinical fellow for 1 year, also in Kulkarni Center, Pune, India. Was so slowly, and soon also I stuck doing urethroplasty, struggle a lot. I have many failure, and I was asking myself why my patients has to suffer. Soon I realized I had to learn. I have to learn more. It is not a matter of try and error. I have to improve my results. I have to join a high volume center. Opportunities don't happen, you have to create them. In 2016, the boss visited Egypt for a conference, and I met him there, and I asked him to join KC for 3 months as observer with some recommendation from my boss, and he said yes, absolutely yes. So I went in 2017 for observation for 3 months, but after I went back home, I have some troubles again, and I found myself need to learn more. So I applied for my GRS fellowship, and fortunately I got my acceptance. What did I get from my fellowship? During 1 year fellowship at Kulkarni Hospital in 2019, I did a lot of urethroplasty. I did more than 200 urethroplasty. More than 20 hypospadias, mostly were crippled. More than 20 female genital reconstruction, 11 cases of urethrorectal fistula, and 4 radical prostatectomy. More than 300 cases of general urology. These were our daily list in Kulkarni Hospital. You can find that the urethroplasty waiting the operative list equal to other monthly list in 1 day. Also, I got my mentors, Dr. Sanjay Kulkarni and Dr. Pankaj Joshi. But I usually told Dr. Sanjay Kulkarni, I learned from you not only urethroplasty, but I learned a lot. I learned how to think and how to improve yourself. Dear sir, I remember all your words, and I remember also the way how you think. He also taught me how to present yourself. I got also my guru, Dr. Sanjay Kulkarni, with some words. Still, I follow these words, like saying that your patient is your father or your son. Usually, he told me that Egyptians are a good surgeons. And usually, Dr. Bankash told me, don't worry, when you go back home, you can do the most complex cases easily. And usually, boss also has some words for me. When you go back home, go to the desert, start a small center, and say, I am a reconstructive urologist. That's it. Also, I got so many friends from different cultures, and it was a great chance for me to change my knowledge and to change my experience. I lost some pounds also, and I got a family. Thousands of miles away from my family in Egypt, I never felt alone with them. Finally, I get my certificate, and I went back home during this COVID-19. As soon as go back home, I found my progress was so fast, and start doing urethroplasty from day one, and this was amazing for me. I found the most difficult case easy for me. I can manage these cases so easily. I have no troubles and I have no fears to stuck. And this was 10 months baby with BFUI. I did him so good. I had also so many urethrorectal fistula post RTA like this child. I did so many urethroplasty with buccal or lingual graft, and I had so good grafts, like Dr. Bankaj usually taught me. I did so many ban anterior urethroplasty Kulkarni. It was so easy for me to invaginate the penis within 1 or 2 minutes after I was struggling for maybe 30 minutes or more. This was my last week case. Ventral only urethroplasty took from me about 60 minutes to finish the case from skin to skin, and this was so good for me. Dorsal only Kulkarni was my daily case, or I did it 2 or 3 cases per week. I did also pediatric urology. I am a pediatric urologist mainly, and urethroplasty, a reconstructive urologist. I did distal hypospadias, and this was my last week case. This was so proximal hypospadias penoscrotal with severe chordae. I have to dissect the urethral blade and transect it to correct this chordae and take a artificial graft for the first stage, as you can see here. This was about 8 months ago. After that, last week, I did the second stage after tubularization of the graft and taking tunical flap as a second layer and closure of the glands. It was so good results and cosmesis. Also, I did a lot of genital reconstruction like Peyronie disease, like in this man, like more than 180 degree of curvature after tunical grafting. I started doing BMG urethroplasty in 10 cases with a so good results. I just got my acceptance in my abstract in the EAU just 2 days ago on this technique. And also last week I did this case. It's a complex duplex kidney with high grade reflux of the upper moiety and urethrocoel of the lower moiety. As soon I found myself a referral from other urologists in my country, in my surrounding countries, neighboring countries, and I found a lot of cases of reconstructive urology and pediatric urology referred to me. So after 1 year from back home, I did more than 200 cases of urethroplasty in 10 months. I did about 90 cases of hypospadias and 20 cases of UBGO, uretropelvic junction obstruction, 9 cases of urethroplasty, and 4 cases of female urethroplasty. So I think when I say that the fellowship, that the journey that changed my life, I am true. I start doing my paperwork, and I was so late to do that, but I start late, better not to start. I just got my acceptance, my abstract got accepted in the EAU 2 days ago about buccal urethroplasty or double face augmentation urethroplasty with buccal mucosal graft, a novel surgical technique for reconstruction of complex urethral restriction and injuries. Like father, like son, I start my reconstructive team. As usually boss said that it is a matter of team, not one man show, because when you use team in reconstructive urology, you will find your progress so fast. I start transfer my experience to others. I start my own fellowship program, and I have some delegates. I start my monthly workshop, actually exactly like my boss did. My guru, Dr. Sanjay Kulkarni, I will owe for you a favor for the rest of my life, for everything you taught me. And usually I tell you that I am so thankful for you. Thank you so much, sir, for everything, For me, these giant three mans in rhesusoplasty like our giant three pyramids in Egypt, Dr. Sanjay Kulkarni, Anthony Mandi, and Guido Barbagli. And one of my dreams that I can invite all of you in Egypt one time, and I can assist each one of you. Finally, thank you from the King Tut and Khamun, and you are most welcome in Egypt. You will find a friend and a place there waiting for you. Thank you. Good morning, everyone.
Nafi, thank you. That was a very excellent talk. And more important than not, if this can be your journey, it can be journey of all the fellows who are visiting this center or all those who want to pursue fellowship. So it just transforms everyone. Thanks a lot for a wonderful talk.
Thank you, Professor Kulkarni, for this training such a nice fellowship program, and it has been done. The person doctors visited your center.
So we invite, since we are running slightly short of time, may I invite our colleague Akio from Japan. We met him for the first time in Boston AUA, where he presented beautiful technique on MRI and pelvic fracture. And he's one of the topmost reconstructive urologists in Japan today. Akio, we would like to present, we would like you to present your talk on bulbar urethroplasty. May I ask the studio to play his video, please?
I already sent my video to the office, so please start my video.
Is everything back to normal?
Yeah.
Well,
Till they start your video, speak about what work you do.
sorry, I couldn't get here. Divas? Juma live huncha. Yeah. So just I would like to congratulate the Kulkarni Institute of the Reconstructions. Yeah, and Guru ka Guru, what we say now that there are so many, and the Chini is becoming more refined and refined. So that should make that institute very proud. And so many reconstructive urologists is coming to this world, to this region, to Asia as well. So very, very nicely done, Mohammed Nafi. Keep it up. And Professor Kulkarni is very, very proud of you. That is my, and younger urologists from Nepal, you must see how you can go to the Kulkarni Institute and acquire the knowledge. Thank you.
Akio, do you have your presentation with you right now?
No, actually, I already sent my video to the office, so I have no video now. So sorry.
It's not on your desktop. So in case if there's a problem in playing the video, do you want to play Pukar's video right now? Pavan, are you there? Who's there in the studio?
Sanjay sir, we are not having the problem in playing video. We are just resuming our due to electricity cut. Just bear us with 30 seconds.
Not a
Okay,
problem.
okay. So I'm happy to see my friend Dr. Jalil Hosseini from Tehran, Iran, Dr. Seichi from Mexico. And just before we started our session, we had Dr. David Winkle from Australia, a friend of mine.
I'm Dr. Akio Horiguchi, a Japanese reconstructive urologist. Thank you so much for inviting me at this great conference. It is a great honor to have this opportunity to present here. I have no financial interest to disclose. At first, let me introduce myself before my talk. I'm working at the National Defense Medical College belonging to the Japanese Defense Ministry. My institute is one and only high-volume center of reconstructive urology in Japan. Actually, I was invited to UROCON Nepal 3 years ago, and it was an unforgettable and enjoyable memory for me. This picture was taken with my good friends Pankaju and Anil. I'm really looking forward to the day when the pandemic is over and I can visit Nepal again. So now let me start my talk. Male urethral stricture is a common and challenging urological issue. It is characterized as a constriction of urethral lumen by spongiofibrosis due to various etiologies, and it causes various symptoms. Vulvar urethra is the commonest site of male urethral stricture in all age groups. Vulvar urethral strictures are very likely to be encountered in our daily practice, and we need to treat them appropriately. This is a flowchart for the management of vulvar urethral stricture. Surgical management of vulvar urethral stricture has changed dramatically in the last several decades, and urethroplasty has become the gold standard treatment. The appropriate type of urethroplasty depends on the location and length of stricture. Vulvar urethroplasty can be subdivided into two types. One is excision and primary anastomosis, EPA, shown in the left panel, and the other is substitution urethroplasty, shown in the right panel. In principle, EPA is the procedure of choice whenever possible because of its long-term high success rate. This slide shows the reported success rate from large series of EPA for vulvar urethral strictures. EPA has an excellent long-term success rate, generally over 90%. However, EPA is suitable only for short and proximal vulvar stricture because EPA for other strictures can cause anastomotic tension and have a risk of CORD. This slide shows the images of EPA. The concept of EPA consists of complete excision of the stricture and creation of a wide and tension-free anastomosis. I'm going to show my surgical technique. A midline perineal incision is made. The bulbospongiosus muscle is then divided and retracted laterally to expose the vulvar urethra. The vulvar urethra is then circumferentially mobilized from the pinoscrotal junction distally to the departure of anterior urethra proximally. The vulvar urethra is transected at the stricture site, and the stricture segment is excised. The both urethral ends are spatulated to make a wide anastomosis. Eight interrupted sutures using 4O PDS are placed. The spongial tunica on the ventral half is closed in the second layer. Urethral anastomosis is completed. EPA is a highly effective surgery, but complications such as cold feeling in the glands, decreased glandular tumescence, and erectile dysfunctions were reported. These complications might be attributed to complete transection of the corpus spongiosum, thereby disrupting the antegrade blood flow. The need to transect the urethra has been questioned because the area of fibrosis to be excised is actually very small in most cases. This slide shows the histological findings of non-traumatic bulbar stricture. You can see the area of spongiofibrosis is actually very limited, and most of spongiosum tissue is normal. In order to achieve both stricture removal and sparing spongiosum tissue, Dr. Jordan first developed a vessel-sparing EPA, and Dr. Andrich and Dr. Mandy thereafter described a modified non-transecting EPA technique. This slide shows the result of multi-institutional study comparing outcomes of EPA and non-transecting EPA for bulbar urethral stricture. Non-transecting EPA reduces the risk of associated sexual dysfunction without compromising success rate. This is a recent trend in the management of short bulbar stricture. EPA remains the main strategy for bulbar stricture with dense fibrosis due to perineal trauma. In contrast, it is possible to avoid transecting the urethra in patients with non-traumatic strictures not associated with circumferential fibrosis. In contrast to short and proximal bulbar stricture, substitute tissue is always needed in other situations such as long and/or distal bulbar focused on substitution urethroplasty for bulbar stricture. I hope you will find it useful for your daily practice. Traditionally, penile skin has been widely used for urethral reconstruction. However, it has gradually been replaced by oral mucosa graft. Dr. Barbagli reported that urethroplasty using oral mucosa graft shows greater success rate than that using penile skin. Urethroplasties are the most popular types. Ventral onlay was first described by Dr. Mori and Dr. Makanich in 1996. The stricture is incised ventrally without mobilization of urethra, and graft is sewn directly to the edge of the urethrotomy. The graft is finally covered with spongiosum tissues compared to the dorsal onlay. The stricture area is exposed. The harvested oral mucosa graft is sutured to the right side of the urethra. You can see the urethral lumen is augmented with oral mucosa graft. Finally, the spongiosum tissue is closed over the oral mucosa graft. The surface of the stricture is incised after mobilizing bulbar urethra and then sutured to the graft fixed on the corpora cavernosa. The advantages of dorsal onlay are less bleeding, spread fixed graft to the corpora cavernosa, and circumferentially mobilized and rotated. The dorsal urethral surface is incised along the midline to expose the entire stricture up to normal urethral mucosa. The oral mucosa graft is spread and fixed over the corpora cavernosa, and then the bulbar urethra is rotated back, and the edge of the graft is sutured to the lateral margin of urethral mucosa. dorsal only is completed. The choice of ventral or dorsal remains a matter of debate, but to date, there's no difference in success rates among the grafting positions. It's suitable for short bulbar stricture, and substitution urethroplasty using Orm-Coase graft is suitable for lengthy and mid to distal bulbar urethral strictures. The key to success is to select procedure appropriate for the stricture status and location. Thunderbird, thank you for your attention. Hello?
Thank you so much.
Excellent presentation, Akio.
Thank you.
Dr. Gunashesh, do you want to, do you have some comments?
As just one second, just as the organizers say, the time is very short because the inauguration by the Prime Minister, we got to vacate the hall almost 1 hour before. So can we move on to the next, Professor Kulkarni, do you agree to that?
Yes, I agree. Yeah.
Okay.
A very good morning, everyone. I'll be presenting on augmented anastomotic urethroplasty for the management of bulbar urethral strictures. And I bring you warm greetings from Partner Academy of Health Sciences and Alka Hospital. Over the previous 2 decades, there has been a debate on how to best manage bulbar urethral strictures. So debate is mainly centered on whether to transect the urethra or not to transect the urethra. The transecting techniques in general being associated with a very high success rate, and the non-transecting techniques resulting in very little or no sexual complications. Let me begin by discussing an index case. This was a young chap who had a history of trauma followed by voiding difficulties in childhood. He underwent repeated endoscopic urethral interventions and was in SPC for past 6 months. His retrograde urethrogram shows a near obliterative proximal bulbar urethral stricture and a non-obliterative stricture involving the mid-bulb and the distal bulb almost reaching up to the penoscrotal junction. Similar pictures seen in this, similar findings seen in this picture. So what are the choices we had for managing this young lad? Could you do a urethral stricture excision and anastomosis? I think the answer would be no, because a long segment of the urethra is involved. Could we do a patch urethroplasty using buccal mucosal graft? Again, the stricture is too obliterative for this purpose. And similarly, we can do a double face urethroplasty because the proximal stricture is too obliterative. So we decided to do an excision of the obliterated segment of the stricture and to graft the remaining non-obliterated segment, that is to perform an augmented anastomotic urethroplasty. Sorry for the poor quality of this picture, but what I'm trying to show is we had to pass the graft long before creating a urethral strip because of the more proximal location of the stricture. Pericatheter urethrogram done at 3 weeks revealed no leaks, and upon removal of the Foley catheter peripherally, he had a very good urine flow, good erection, no ventral curvature, and no glans insensitivity. Moreover, he was extremely satisfied with the result of the surgery. This technique of augmented anastomotic urethroplasty was pioneered by Turner Warwick in the year 1991, though the term was coined by George Webster in the year 2001. This surgery tries to combine the advantages of stricture excision, mainly the very good long-term results associated with anastomotic urethroplasty, and it tries to combine this with the benefits of augmentation urethroplasty, that is little or no damage to the blood supply and to the nerves of the urethra. Historically, anastomotic urethroplasty was deemed ideal for strictures up to 1 centimeter in length because 1 centimeter spatulation required on the contralateral sides would result in a 2 centimeter defect, which could easily be bridged without risk for penile shortening or chordae. However, for strictures more than 2 centimeter, excisional and anastomosis and end-to-end anastomosis would risk penile chordae or shortening because the resultant defect would be more than 2 centimeters. However, Alan Morey in the year 2010 published a series where he saw that up to 5 centimeters of proximal bulbar strictures can be excised without causing any erectile dysfunction or chordae. So what are the factors that determine what length of the stricture can be safely excised? These factors include genital length, the degree of urethral elasticity, and the extent of urethral mobilization that you can perform. And of course, the patient's acceptance of some degree of penile shortening or chording would definitely make your life easy. So what I would like to say is the final decision on the type of repair should depend not on the preoperative retrograde urethrogram findings, but it should depend on your intraoperative assessment of the stricture length, the state of the urethral mucosa, and the state of the spons. So does excision and end-to-end anastomosis really cause sexual dysfunction? In the series by Webster and another series by Alan Morey, none of the patients or very little patients had new onset erectile dysfunction. Whereas in a large series of patients who underwent urethral transection, Barbagley showed that none of these patients had erectile dysfunction accordingly, but less than 10% of the patient did have ejaculatory dysfunction or decreased gland sensitivity. In an often quoted series by Richard Santucci, which was actually published as an abstract, more than 15% of the patients had de novo erectile dysfunction, though this was a very small series. So taking into account the pros and cons of urethral excision and anastomosis and urethral augmentation, we can state that augmented anastomotic urethroplasty is a tool which should be in the armamentarium of all the reconstructive urologists. This surgery has 4 principal steps. These include excision of the most narrow or the fibrotic segment, ipsilateral spatulation of the urethra of the remaining urethra, anastomosis of the urethra as either a roof strip or a floor strip, and doing a graft onlay. So for a 2 centimeter stricture, this surgery would result in a gain of 1 centimeter of urethral length when compared with anastomotic urethroplasty. For strictures more than 2 centimeter long, the 2 centimeter most dense segment, intervening segment, would be excised. A stricturotomy would be performed, which would be extended for 1 centimeter as a ipsilateral spatulation into the normal urethra, and a graft would be patched. So the advantages of this technique would include use of shorter grafts, widening of the urethral wall, meaning less circumference of the reconstructed urethra would consist of graft material, and it would result in better healing because we're dealing with a much more healthier corpus spongiosum. So as I mentioned before, the urethral strip can be reconfigured as a floor strip, wherein the graft would be placed dorsally, or it could, or we could reconfigure the urethral plate as a dorsal strip, wherein the graft would be placed ventrally. There are certain situations where we have to decide on doing an augmented anastomotic urethroplasty based on, excuse me, based on intraoperative findings. The first situation is when an anastomotic urethroplasty has been planned based on preoperative urethrograms, but after transecting the stricture, we find that the stricture is much, much longer. This usually happens because the less severe proximal stricture is dilated by the hydrostatic forces during voiding. The second situation is when you have done a urethrotomy through the entire stricture, and then you find that there is an obliterative segment measuring 1 to 2 centimeters. If you place a graft, if you pass this segment, if you try to treat this segment with a graft, it's surely going to recur. Aborsali and Angermeyer has described a technique when the stricture is located at or near the bulbomembrane junction. In this technique, they suture the graft to the distal segment as a ventral onlay, and then they anastomose the composite urethra to the proximal urethra. And proponents of double face urethroplasty would state that double face urethroplasty is a much better alternative to augmented anastomotic urethroplasty. And though an initial series by Palmenteri showed that none of his patients had de novo erectile dysfunction, a recent series from Hyderabad from Asian Institute showed that 16% of the patients had de novo erectile dysfunction or ejaculatory dysfunction. On the contrary, series by Webster, Aborsali, and Al-Kasabi, large series, have shown a very good, a very handsome stricture-free rate with augmented anastomotic urethroplasty, and little or no penile cordoning or sexual dysfunction. So I would like to conclude by stating that augmented anastomotic urethroplasty is a very good tool that has to be in the armamentarium of a reconstructive urologist. It is associated with very less sexual dysfunction, very less risk of penile shortening chordae, and good results. And it is extremely good for long segment bulbar stricture with very dense intervening 1 to 2 centimeter segments. In those patients with traumatic stricture who have been previously treated with repeated DVIUs, and in those patients who have previously been treated with anastomotic urethroplasty but has failed, this can be the only salvage. So with this, I would like to thank you and a very happy New Year 2007.
Thank you, Dr. Pukar, for an excellent talk on augmented anastomotic urethroplasty. May I request the studio to play the video for our friend Sechi Fujiwara. He's got a Japanese origin, but now is a reconstructive urologist in one of the largest countries in the world. I heard his scissors are making beautiful noise in Mexico. Sechi, over to you for your presentation on panurethral stricture.
Dr. Seiichi Fujiwara Ruiz. I'm from Mexico. I would like to thank Dr. Pawan Raj for inviting us to this excellent congress, and also Dr. Kulkarni, for my guru, for all their teachings. So I'm going to talk about panurethral stricture. These are less than 10% of all strictures. The etiology, the most common, is BXO or lichen sclerosis. Idiopathic is the second most common, and instrumentation is almost 20%. This is about because of catheter, TURP, TURB, or cystoscopy or RRS. Recurrency. What we have to do is we have to see the evaluation and history. We have to see the penis, if they have lichen sclerosis like this here, or with any changes in color of the glands. If they have previous surgery like this urethral periosteomy, if they have these scars, fistulas, which is our first study we do, is the Uroflow. So we can see the flat curve. Then we will do RGU and MCU. So we can see that we have to be careful in these cases where we have extravasation of the contrast, because this can be a near obliterative or obliterative stricture. You're going to use a subcoronal incision and then the gloving. You're going to use a ventral incision, so you can go through the scrotum, or with a minimal invasive technique, that is invagination with Dr. Kulkarni's technique. And the repair, if you're going to use a buccal mucosal graft, refuse graft, or a flap. So the best graft that we know until now is the buccal mucosa. So we can take 1 or 2 cheeks, and we can also have a lingual graft. If you're going to use stage techniques, we have Johansson one, that you will cut ventrally the urethra, and then you suture in a continuous fashion with Vicryl for 0. And then you have the BRCA technique, that you will put the graft in the first stage, and then you will do a second stage in either of those after 3 to 6 months. If you did BRCA one, you can complete with Johansson 2, so you will tubularize the graft previously grafted. And if you did a Johansson one, you can do a SOPA. So you will do a cut in the 12 o'clock, and then you will put the graft and then tubularize. What happened with the BRCA one? Dr. Barbagli said that up to 40% of the patient, they will need a new graft. This is because of the conditions of weather. And the patient need to be, 50% of the cases will need more than 2 procedures. Like this, you can see that there's a fistula, there's no even a urethral plate. Kulkarni technicollis, you will see the bulbospongiosum muscle. Then you will dissect, and this is the bulbocavernous muscle that you are going to dissect and cut. This is the cavernous body. So you preserve this muscle, and then you will do invagination of the penile. This is the gauladed fascia that is going to be transected. First, at the beginning of the surgery, we usually put blue methylene in order to see the urethra and the stricture. And then you will go one side dissection, so you will preserve the other side, the neurovascular bundle. So at 12 o'clock, the urethrotomy, you will go distally and proximal. So you can see the For the meatus, you will do a dorsal cut at 12 o'clock and then several cuts between the 2 and 10 p.m. So you can patch the graft from the tip of the penis, and then you will quit the graft. So we usually use 4, and we do 3 rows. So we have to be careful with the anastomosis of the urethral to the in the next picture, and this is in a continuous fashion. See, this is 2 buccal mucosa, and in the middle was the side of the urethra, and this is called 3 stitches technique. So we put to the albuginia, then to the corpora, to the mucosa, and then to the sponge, not to the mucosal plate. So we avoid cord D, and then we close. And you have the midline perineal scar. This is the. What are the advantages in the Kulkarnis technique? So this is preserving the bulbospongiosan muscle that we see. The cut is in the bulbocavernosal. So this muscle helps for ejaculation and avoid dribbling. One side is preserved of the neurovascular bundle. This is a one-stage technique. The meatus is not hypospadias. There's a perineal incision with a minimal risk of fistula. This is Dr. Kulkarni's cases. They have 318 patients and counting between 1995 to 2015. The success rate is 84.9%, but if we are going for the primary and non-obliterative cases, the success is 92.3%, compared with a recurrence is 57, and obliterative cases like this picture is 57%. The most common cause is BXO, and 11% in this case, in this series, they have a previous surgery. In a multi-institutional evaluation, they found that the success rate is better in a single stage with buccal mucosa rather than a staged procedure or combination with graft. If you already have used one patch or you don't have a buccal mucosa to use, you can use flap. So we have to remember that the prepuce is going to be irrigated by external pudendal artery instead of the internal pudendal. So we can see here the vascular is going to be dorsolateral and ventrolateral. McKinnish is the most common use. We use the dartos fascia as a vascular flap. So we can see here, you can take almost 20 centimeters of prepuce, and we have to be careful in the dorsal part because there is a neurovascular. Other, you can use the Q flap, the Orandi flap, but the Orandi flap sometimes in the proximal part can have hair, so this is going to be a cause of UTIs, stones, and the success rate is about 62 to 76% in BXO, and they have additional complication like necrosis flap. Depends on the urethral plate. If it's more than 5 millimeters, you can use the Kulkarnis technique. If it's very narrow, you can do it in a stage procedure, or you can, and in the second stage, you can use oral mucosa graft. If in case of redo, you can do a full length ventral approach with dorsal inlay, like a SOPA. And you can, if you didn't do any invagination or you did a penile invagination, you can redo a penile invagination and putting a dorsal inlay or buccal mucosa graft. A stricture in between the grafts and in the proximal site. You can have fistulas. In case you did pedicle preputial or a flap, you can have a diverticula. You can have abscess, infection of the wound adhesions like this. You can have hematoma and erectile dysfunction. So take home messages. We have to know that pan-urethral strictures are complex cases. BXO is the most common etiology. We have to use BMG for the repair. If you can do, you always do a single stage Kulkarni's technique. The first repair always is the best. You have to be careful in near obliterative or obliterative segments, so you can use double phase in these cases. And you have to know the importance between different techniques, and you have to know all these techniques so you can do in each case that will be required. So thank you for inviting me, and we see you in questions. Hello.
Thank you, Sechi. Great talk. Dr. Joshi.
Thank you, Vijay. This is congratulations. Yeah. All of you are pupil. So I would like to salute Professor Kulkarni. Yeah. Everybody is finding the path very nicely. That is my comment.
Thank you. We go to the next talk by Dr. Pankaj Joshi, my associate for more than 10 years, and he treats all the failed hypospadias patients in our unit. So Pankaj.
All members of the Nepal Urology Association, and we welcome you to the joint meeting of NOS and the International Society of Reconstructive Urology. Lot of hard work from the organizing committee, Dr. Pavan Chalise, and sincere congratulations to you. I am happy to present on the topic of management of failed hypospadias repair whenever it comes to adults or it comes to children. Whenever it is a failed hypospadias, it can have varied presentations. One of the commonest one is the patient has still got a hypospadias. It can present as a penile stricture with recurrent attacks of UTI. There could be one or multiple ureterocutaneous fistula, a residual chordae, or can still have an uncorrected penoscrotal transposition. So it's a varied presentation and we need to take care of all of these factors. If we go by literature, there are more than 200 surgeries which are described for hypospadias. But the moment we hear the word failed hypospadias, the first surgery that comes to our mind is a stage urethroplasty using buccal graft or a BRCA surgery. In BRCA surgery, the entire scarred urethral plate is excised. An appropriate buccal graft length and width of the size of the urethra is harvested. It is then quilted onto the corpora. We keep on watering this graft, wait for a period of about 6 months, and then 6 months later, we call the patient and perform the two-stage surgery. It is done in a hope of removing the scarred tissue, correcting the chordae, as well as getting a new urethral plate. We have performed BRCA surgery in our unit, and so has in many all over the world, especially in the Asian subcontinent. Occasionally, the closure especially becomes difficult. At the edges, the blood supply can be precarious. In case the closure is tight, we may have to take a release incision onto the dorsal aspect of the penis. But whenever there is a tension or ischemia, the entire suture line can give up, causing it to have a failure. One of the very famous paper which has been published on high volume reconstructive urology suggests that there is a graft contraction of up to 39% whenever we do a stage urethroplasty using buccal graft. This is also a common experience when we talk to various urologists across the world. What it actually means is a two-stage surgery becomes a three-stage surgery and can even become a four-stage surgery. This patient needs another graft insertion, and this prolongs the agony of the patient. What we propose now is our new technique, which has been published. If at all the patient has a penile stricture or multiple ureterocutaneous fistula, we just lay open the urethra like a Johansson stage repair. We counsel the patient that we are going to make you hypospadiac for a period of 6 months, and 6 months later, we are going to correct you. After a period of 6 months, we can make a midline incision into the urethral plate. We harvest about 1.5 centimeter wide buccal graft. We quilt that graft onto the corpora, use the surrounding native urethral plate, and then tubularize the urethra. So what has happened in this particular technique is we have not inserted the graft in the first stage. We have inserted the graft in the second stage. And when we insert the graft, we tubularize the graft at the same time. So this is a very simple exercise. If we keep our mouth open for a minute or two, the buccal graft dries. The same thing happens when we insert a buccal graft in a staged way. We have proposed and published this paper. It has now found its way as a reference in the European guidelines and the Urological Society of India stricture guidelines. Whenever we insert a buccal graft as a BRCA technique, when we lift the edges, there is ischemia. Versus when we do a Johansson one, put the graft in the second stage, the surrounding skin has its own blood supply. So this is more vascular as compared to a two-stage surgery, which has been done conventionally. None of the patients require a redo surgery. Occasionally, there can be a dehiscence or a fistula, which can be treated. Another aspect of a failed hypospadias is presence of multiple urethrocuteneous fistula. Usually, the origin is ischemic, or it can be due to presence of a distal stricture. We always inject methylene blue. Occasionally, if we close one fistula, we might see another fistula. So even after a complete repair, we inject methylene blue and check. Endoscopy is important to diagnose the fistula. A urethral incision is made onto the skin around the level of the fistula. We dissect down to the level of fistula, excise any raw tissue and the skin that is there, close the fistula using small suture like a 6-0 polydiaxone. The most important layer is that of a dartos. We cover it with a dartos, make a triangular flap and cover the fistula area. If at all there is presence of a meatal stenosis or a distal stricture, just closing the fistula will not help. It can cause recurrence. In those cases, we open the urethra ventrally, insert a dorsal inlay graft, can use the surrounding penile skin, prepucial skin, or a buccal graft, close the urethra, use a nice cover of dartos, and reform the entire penile shape rather than just closing the fistula. When it comes to chordae correction, traditionally we all know there are two ways. One of the common ways is to transect the urethral plate in case it is more than 30 degrees, make multiple corporotomies on the ventral aspect, make the penis straight. If none of this help, we can do a mobilization of the neurovascular bundle, and then we can do a plication either using an SBIT technique or a 16-dot technique. One of the problems in mobilization of a neurovascular bundle is that in case there is an injury, it can cause an ischemia to the glands. In this particular case, we have mobilized a neurovascular bundle. We have done the plication. We now see that the penis is erect. This was a redo case. We did not transect the urethral plate. After having corrected the chordae, we suture the urethral plate back to the corpora, make a midline incision, insert a buccal graft, close the urethrotomy. We then use a dartos layer as a second cover and then perform a single stage surgery, including chordae correction. I propose my views, which I have also sent for publication and spoken in previous conferences. Penis has two corporas, which are convex cylinder. There is no point taking a suture in the midline for correcting the chordae. Chordae correction is done by plication at the most convex border, which is laterally. I believe there is no need to mobilize the entire neurovascular bundle for chordae correction unless we are doing a total penile disassembly or an extreme amount of chordae. So what I propose is called as the semi-mobilization of neurovascular bundle, where we just lift the bundle from the urethral plate till around 11 o'clock position. Here we see that none of the tissue has been lifted in the midline. We can do plication, correct the chordae, and this would decrease the complications that we see of glans ischemia, and chordae correction might just become easy for a common urologist. It is not only about chordae correction, urethrocuteneous fistula, and urethral correction. One of the most important aspects in a failed hypospadias is a penile aesthetics. Many a times patients do follow up with us with a failed correction of the penoscrotal transposition. We make incisions around the scrotal plate. It is very simple. If we see a penoscrotal transposition, the rugae are going vertically. All we need is to transpose it, and suture it in such a way that the rugae become horizontal. So penile aesthetics and the genital aesthetics is a very important part when it comes to failed hypospadias. We do have patients who have had a pedicle tube in the childhood. It has now become a huge diverticulum. This patient has diverticulum while passing urine and is unable to ejaculate after having a masturbation or sex. In such cases, we need to go down, reduce the size of the diverticulum. But what is most important is this was the preoperative picture, but we have to give him a vertically slit meatus, which is at the tip of the penis. If you look at proms, patients give a lot of importance to the appearance of glands. And I believe whenever possible, in most of the cases at least, we should be able to give them a meatus right at the tip of the glands. I present my retractor, which I've dedicated on the name of my guru. This is the Joshi Kulkarni retractor, which is a self-retaining retractor for the use in penile surgeries and especially hypospadias. The message that I have from my talk is avoid inserting buccal graft in the first stage, give a priority to genital aesthetics, correct any transposition, close the fistulas if required, the distal stricture, and perform a chordy correction to the best possible way. Because of this work and my teacher, Dr. Kulkarni, we were a part of the WHO team where we went to Zimbabwe and corrected urethrocuteneous fistulas that took place after a voluntary male circumcision. I thank Dr. Pavan Chalise, the organizing committee, the secretary, the president, and the entire Nepal Urology Association for giving me this opportunity to speak on management of failed hypospadias. Thank you. Great.
Thank you, Dr. Pankaj Joshi. In order to save time, as suggested by Dr. Joshi in Nepal, we go to the next topic. I request my friend Dr. Jalil Hosseini from Tehran, Iran, to talk about the technique and experience with pelvic fracture urethral injury. Dr. Jalil, please.
Nepal Association of Urology Surgeons that invite me to talk on the technique of urethroplasty in pelvic fracture urethral injury and introduce some experience in my department. This is my lovely hospital in north of Tehran that I do the reconstructive surgery during last 27 years. Pelvic fracture coming like this picture, or the left ramus inferior one, or both ramus. Of course, sometimes MRI also can help, but this picture show very well. In this case, there have a lot of surgery in orthopedic in the pelvis. For these surgeries, fine instrument and fine dissection is very important. I start in the perineum and then open up the bulbospongiosus muscle, and in the right side, fine mobilization of anterior urethra from corpus cavernosa, as you see here. Then going down for dissection in the pelvis to reach to the membranous urethra, and then mobilization of the bulbar urethra from rectal area. At this stage, I try to cut both ends within the fibrosis to prevent tissue damage or loss of normal tissue, like this. Please remember this case, this slides. I will come back again. Then open up both ends of the urethra, spatulation, good tissue here, and 6 sutures to make a urethroplasty end-to-end over the 18 French, usually, silastic catheter. Another point is that the transection is necessary or not. It is dependent to which case. There is a good paper from Andrich and Mundi, and finalized their opinion that If there is minimal spongiofibrosis, okay, non-transecting is good approach. Shall I introduce some complex urethroplasty in my department? I trained the fellowship and they aid me in such difficult cases, about 5-6 cases per week, mostly redo. You remember this one, but most of the urologists send the metal sonde in this stage to open up the prostatic urethra like this. But it's not appropriate because metal sonde make malaligned urethra during urethroplasty. As you can see in this picture, there is a normal posterior false passage to the bladder. Or when you send the metal sonde here, metal sonde cannot come to the end of the urethra, but stay here, and you miss some part of the normal urethra. In this case, I usually use the flexible cystoscope going into the bladder neck and the light in the perineum, a needle, and on the needle I open up. What we can do by this case, that the verumontanum is here, a long stricture here, also to this part of the urethra, long distance stricture. There are 4 steps to bring down both ends of the urethra: corporal body separation, inferior pubectomy, supracrural that I don't like it, and sometimes transpubic approach, and you can bring the penile urethra to the prostatic by these approaches. This is the separation of the corpus cavernosa. There is a fine septum here, but should be careful to do not make a bleeding. Of course, in redo cases, the tissue is not as fine as previous one, and there are a lot of fibrosis, and there is no obvious corpus cavernosa here, and a lot of fibrosis. In this stage, this is the pubic symphysis and the proximal urethra. Flexible guide us to open up the proximal urethra, and then 6 suture as previous one, and finally end-to-end. Another case that I introduce is earthquake and a debris on the patient, and coming with 1 posterior urethroplasty and still a long distance between 2 ends. Flexible shows that there is 2 centimeters after verumontanum urethra. And I did to remove the stone, corolla isolation and separation and inferior pubectomy, and make it urethroplasty finally. Another case has the manipulation, dilation, and bladder neck false passage coming to our department, as I showed you before. In this case, from the bladder, you can see the false passage here and normal prostatic urethra here. End-to-end anastomosis again. In some cases, I bring the tissue, omental flap from the abdomen to rotate on the urethra and to fill this defect. Another case is a false passage here, normal bladder neck, and a fistula. When we open up, there is from the bladder, metal sonde make many hole here in the posterior urethra, and then has a fistula, ureterorectal fistula, perineal fistula, bone fixation. Many attempts for urethroplasty failed, and coming to our department, rectal fistula closed by a colostomy only, hopefully. And you can see in the pictures that there are wire fixator and fistula to the perineum. The fistula, when I open it, the fistula is going to the metal wire here. As you can see, metal wire shows here, and the separation of anterior urethra. Then try to do the end-to-end urethroplasty. And at the final stages, after removing of the fistula, I try to bring a pad flap to cover the metal steel. For take-home message, the first operation should be the most successful one. Fine instrument and flexible cystoscope for complex cases, and do more than few cases per month is the condition for successful of the operations. Thank you for your attention. I appreciate.
Thank you, Dr. Jalil Hosseini. I just want to tell my friends who are watching this videos that after I listened to Dr. Hosseini in an EAU meeting some time ago, I bought my first flexible cystoscope. And then whenever we get patients of double transection, bladder transection plus posterior urethral trauma, I use the Jalil Hosseini technique to identify the posterior urethra at the apex of membranous urethra, and then the patients with double transection are continent. So thank you, Jalil, for introducing this very beautiful and anatomical technique to the field of reconstructive urology. In order to...
Thank you very much. It really helped very much. The flexible cystoscope during complex urethroplasty helped a lot. Thank you for your support of this technique.
Thank you. So in order to save time, I'll go to my presentation. Can we start the video?
I suppose Professor Chairman has a comment here.
Nepal Urology Association.
Yeah.
For inviting me to this annual meeting. I would have liked to be present personally, but because of COVID situation, we are forced to go virtual. So this is a nice program arranged by my friends, and I'm going to discuss about how to do perfect posterior urethral injury. This is a video of a redo anastomotic urethroplasty for pelvic fracture urethral trauma. This is a RGU, which shows that there is outpouching on one side with an MCU showing a dilated proximal urethra under spinal anesthesia. Midline perineal incision is made. The bulbo-spongy muscle is incised in the midline. The bulbar urethra dissected with sharp scissors from the corpora cavernosa. The dissection goes distally up to the punoscrotal junction. With the left index finger, I'm pushing both corpora on the patient's left side, and I'm dissecting between the corpora cavernosa and spongiosa. For proximal dissection, I have applied a master retractor and then another Babcock retractor on the ventral spongy tissue. And here I'm lifting the bulb of the urethra from the perineal body. Because this is a redo case, the bleeders may not be severe. As in a primary case, I have inserted a small dilator for French and a forceps inside the proximal urethra, and I'm going to excise the scar at the apex of posterior urethra. Here I'm making an incision at 12 o'clock, and it is too close to the pubic bone. So this is the next step, is crural separation. I made an incision in the midline between the two corpora cavernosa, and with a knife I can do a better dissection. Occasionally one may enter a corpora cavernosa and he has to suture it immediately. The attachment is mainly anterior, so posteriorly I can insert a scissor behind and then open it gradually. Now a second master retractor is applied in a upside down fashion, and you can see fascia after separation of the corpora. Once I incise the fascia, gradually and carefully, you can see the deep dorsal vein of the penis here on the patient's left side. The vein is coming into view. This is fascia over the vein. So if the vein is too big as is the midline, you can ligate it and you can transect it. One must make sure that lateral to the vein are the dorsal arteries of the penis, and one should not damage the dorsal artery. If you damage the dorsal artery, there is a higher risk of developing bulbourethral ischemic necrosis. Next step is to do periosteal incision. So this incision is in the midline, keeping the vein on one side in this patient on the left side, and many urologists make an incision onto the periosteum in an inverted U fashion. That may destroy the blood supply going to the glands, what we call the dorsal arteries of the penis. So here the incision is deepened. Then I'm bending the tip of the electrode at an angle, so I can do further dissection of the bone subperiosteally. I want to do the dissection subperiosteally and now not above the periosteum to preserve the vascular supply to the glands. Then I'm going to do inferior pubectomy with a hammer and gouge. We have 5, 10, and 15 millimeter size gouge. I'm using 10 millimeter gouge in this patient. Now we have to remove just a tiny piece of bone, adequate enough for my index finger to go in, so that I can excise the tissue or the fibrosis at the apex of posterior urethra. Initially, the direction of pubectomy is oblique. If the posterior urethra is high, then we change it to a more horizontal position parallel to the ground. Here I'm removing a piece of bone with a periosteal attachment posteriorly. This is a space just adequate for my index finger to go in. And now I'm excising the scar anterolateral to the incision, which I made at 12 o'clock into the posterior urethra. Occasionally, I may use a knife to go around. The excision of scar tissue has to be judicious. The scar is white, firm, and fixed. The urethra is pink, mobile, and soft. Here, this is the incision onto the 12 o'clock position of the urethra. You can see the posterior urethra now, the wall nicely. I'm excising the anterolateral portion of the scar tissue here. I don't do a lot of dissection posteriorly here because there is rectum. In case of redo cases or in difficult patients where I cannot feel the bougie in the perineum, I insert the left index finger into the rectum. This is an incision onto the periosteum here, little bit of white scar tissue, and then we excise it with scissors. The space has to be adequate enough for my needle holder to rotate and for the urethra to be seen beautifully. The last bit of tissue at the apex of posterior urethra here. Most of the patients have the posterior urethra turned in a J-shaped manner. As in this case, you can see the mucosa turning upwards because of the absorption of hematoma and fibrosis formation. I'm going to excise this little upturned part of the mucosa I can see the posterior urethra nicely. I must make sure that I have entered the right spot by doing an endoscopy at this point to make sure that I can see the veru and the bladder neck. I'm excising a little bit of scar which is on the posterior wall, but we have to be careful not to injure the rectum. You can see the urethra here is pink, soft and mobile, and the scar tissue was white, firm and non-mobile. Change the direction in case of more pubectomy is required. I just suggested that initial pubectomy is oblique, and then if required from oblique position, I go more horizontal, more parallel to the ground in order to avoid abdominal approach if possible. Occasionally, abdominal peritoneal approach is required. This is a lateral view, and I am going more horizontally for a high-lying posterior urethra. The next step is anastomosis. Here I'm using 50 PDS sutures, now starting at 1 o'clock, outside in, inside out and outside in. And here the knot lies inside the lumen, knot in the tissue versus knot in the lumen. There is less fibrosis with the knot in the lumen, and the knot can fall off. So we take sutures at 1 o'clock, 11 o'clock, 9 o'clock and 3 o'clock. And at the end for 5 and 7 o'clock, I'm holding the needle end on. I'm inserting the needle posteriorly away from the mucosa, and I rotate the needle holder, I depress it, and I can see the needle coming out at the right spot inside the urethra. And then I push the needle into the bladder and then rotate and take it out. So usually I insert 6 sutures of 50 PDS or 40 vicryl, and a 14 French silicone catheter is inserted, and the Foley balloon is inflated, and the catheter is pulled out so that the Foley bulb is at the bladder neck, and then we tie the sutures. Then a suprapubic catheter is inserted, and the patient is discharged after 48 hours. We remove the urethral Foley catheter at the end of 4 weeks, clamp the suprapubic tube, and then allow the patient to void normally. This gives us a success rate of more than 90%. Thank you for inviting me for this August gathering. Bye-bye. I thank the...
So we finished the all the nice lectures and videos. Any final comments from Dr. Bolaraj Joshi and Dr. Gunasheshta, please?
Thank you very much. Yeah. So nice of you, Professor Kulkarni. Just you have just done a very nice job. And now the security persons are just outside and waiting this hall to be vacated because the Prime Minister will be coming and they won't like to see. So thank you very much, everybody who has participated here. So give a big use of clap to the Professor Kulkarni. Thank you very much.
Thank you very much.
Dr. Shrestha has a comment. Dr. Shrestha, yeah, open the microphone. Your microphone is closed. Okay. Thank you very much. Thank you for your invitation. I also have the complicated cases here and try to show you, and also thanks to Sanjay. Nice to see all of you. Bye-bye.
Thank you all the delegates. And now we will have a hold for some time in the Zoom. And then I ask all the delegates from the national and international to join us at the 6:45 Nepal Standard Time. And for the president of the International Society also to join us at 6:45 Nepal Standard Time so that we can upgrade you to the panelist so that we can run the inauguration session. Thank you. Join you at 6:45 Nepal Standard Time. you.
A place where the intensive care unit. It's a place where patients believe they get well. But it is also a place where dangerous infections lurk. There are multiple causes of hospital-acquired infections, one of which is the use of infusion systems. Infusion systems are an important part of overall surgical and ICU care. These systems are either open or closed. Examples of open infusion systems include glass and plastic bottles, while that of closed systems include intravenous bags. Research has revealed that open infusion systems are more prone to increasing the risk of hospital-acquired infections. Closed infusion systems are superior to open systems in preventing hospital-acquired infections. Hence, it is now time to break this chain of hospital-acquired infections. Fresenius Kabi has pioneered 100 years of excellence in clinical nutrition and volume therapy products. It is recognized by European regulatory authorities for promoting good manufacturing practices. Introducing the new innovation from the leaders in volume therapy worldwide, FreeFlex, the DEHP-free, non-PVC, environment-friendly solution to infusion therapy. Innovative injection port. Rigid injection port ensures the safe connection, prevention of needle stick injuries and damaging of the bag during drug reconstitution. Self-sealing septum in the injection port to prevent leakage after removal of the syringe. Sterilized at
Medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make urology surgery familiar with the generation of latest innovative technology in the field of urology, bringing loving care to healthcare. Any sufficient advanced technology is indistinguishable from magic. Being medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make urology surgery familiar with the generation of latest innovative technology in the field of urology, bringing loving care to healthcare. Any sufficient advanced technology is indistinguishable from magic. Being medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make urology surgery familiar with the generation of latest innovative technology in the field of urology, bringing loving care to healthcare. Any sufficient advanced technology is indistinguishable from magic. Being medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make urology surgery familiar with the generation of latest innovative technology in the field of urology, bringing loving care to healthcare. Any sufficient advanced technology is indistinguishable from magic. Being medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make urology surgery familiar with the generation of latest innovative technology in the field of urology, bringing loving care to healthcare. Any sufficient advanced technology is indistinguishable from magic. Being medical equipment distributor, we, Nova Bioinformatics Private Limited, would like to make
Hello, can you hear me?
Chapel, sir, this is Dr. Divas from on behalf of NAUS. We'll start around around 20 minutes to half an hour. So please be with us. Thank you, sir.
Okay, thank you. Michelle Burgoyne. Marie, thank you very much for your note. I'll make alternative arrangements for best wishes. Sheila McNeil. Yes, sir. Sheila, thanks. I'll investigate getting hold of Samesh and try and do this in the next week.
I'll come back to you on this at best wishes. Incidentally, I've had a very good response so far to the questionnaire, but although I don't know what the results look like, as they're all hosted in South Korea. This is all based on people emailing me back with best wishes. Sheila, next one. Next thing from Sheila, thanks for the feedback. Best wishes. Next one, the same. Chloe Barandier, I've already responded to her. Thanks. TMDP, I need to do. Neville, Adi. Yeah, Neville, thanks for the feedback. With best wishes. Jenny, if you could keep a tally on this. So we've got 5 for the meal, 2 with wine, 7 with me and Mary, and 4 and 2 rooms so far, 2 double rooms. So thanks, Neville. Thing from Neville and from Naz and Chris Harding, no, it's necessary. Wrong tang. And if you could send in a short and updated CV. Yeah, wrong tang. I'll prepare the slides I'll prepare the slides myself. Thanks, Jen. Do we start shortly? Can you please advise?
हेलो। हाँ बताओ।
हाँ, घर कब आ रहे हो?
रास्ते में है, बताओ।
अगर मैं और सारण तो बाहर से मंगवाई खाएंगे, आपको कुछ खाना है? चिकन नगेट?
Hello, can you hear me? Can you hear me all right?
Yes, you are well heard. No problem.
Thank you very much indeed.
Hello, good evening.
Good evening.
Hello, good evening. Can you?
Perfectly.
Yes, you are well heard.
Okay, thank you.
Hello, a very good evening to all our international delegates who are joining us by Zoom. I'd like to remind all of you, we will be beginning the inaugural session shortly. We are waiting for the arrival of our chief guest, Right Honorable Prime Minister K.P. Sarma Oli. We will be beginning the inaugural session shortly. Thank you. Once again, I'd like to kindly remind all of you, our chief guest, Right Honorable Prime Minister KP Sharma Oli is right on the way. He will be here shortly. We are waiting for his arrival. We'll be beginning the inaugural session in a while. Thank you. I request all of you to keep your mobile phone, cell phone on silence mode. Thank you. Right Honorable Prime Minister of Nepal, KP Sharma Oli, had just arrived. I request all of you to welcome him with a big round of applause. We are immensely honored to have him here as a chief guest this evening for the inaugural session of UROCON 2021. I request our technical crew to play national anthem, and I request all of you to rise. Thank you. I request all of you to remain seated. May I kindly remind you, this is the 6th annual conference organized by Nepal Association of Urological Surgeons, which is themed as Expanding the Horizon. A very good evening, ladies and gentlemen, distinguished guests, members from NOWS, international delegates, and everyone who are here to mark the inaugural ceremony of 6th annual hybrid conference, UROCON 2021. I'm immensely honored and privileged to welcome you here this evening on behalf of NOWS, Nepal Association of Urological Surgeons. No matter where we are in the world, we are the strongest when we share ideas, learn from each other, and exchange energies. So this two-day conference seeks all of your active participation. To begin with, I'd like to welcome our dignitaries in the dais. May I have the pleasure of welcoming Chairman of this inaugural session, President of Nepal Association of Urological Surgeons, Professor C.S. Agrawal. Likewise, with equal pleasure, may I now kindly request Right Honorable Prime Minister KP Sharma Oli to grace the inaugural session as a chief guest. We are very elated to have him here as a chief guest despite of his busy schedule. Likewise, I humbly request Organizing Secretary of UROCON 2021 and General Secretary of Nepal Association of Urological Surgeons, Dr. Pawan Raj Chalise, to kindly take a seat in the dais. Moving ahead, I hereby would like to welcome Vice President and Chairman of Scientific Committee, Dr. Mahesh Bahadur Adhikari, to take a seat in the dais. Thank you, gentlemen. With this, I once again welcome everyone on and off the dais, and a big welcome to all our delegates and participation who are joining us virtually via Zoom and other media as well. Though most of us present here are aware about Nepal Association of Urological Surgeons, for a non-technical person like me and all our international delegates, I'd like to give a brief insight of the organization. Nepal Association of Urological Surgeons was established with a very humble beginning in 2006. Since then, it has nurtured numbers of academic and clinical practitioners throughout the nation. It has evolved itself as a common platform of dynamic urologists who share common dreams and aspirations. It also aims to bring urologists from all over the nation and abroad under one umbrella to excel ongoing practice and also to share technical know-how among the professionals. To begin with, may I now request President of the NOWS to present UROCON 2021 momentum to our chief guest. And I'd also like to request Dr. Amit Mani Upadhyay to assist. President of NOWS, offering UROCON 2021 memento to our chief guest, Right Honorable Prime Minister KP Sharma Oli, and assisting him, Dr. Amit Mani Upadhyay, Chairman of Hospitality Committee. Now, I'd also like to request Dr. Pawan Raj Chalise, Organizing Secretary and the General Secretary of NOWS, to distribute badges to dignitaries in the dais. And I would like to request Dr. Deepak K. Thakur to assist Dr. Chalise. And I'd also like to request Dr. Mahesh Bahadur Adhikari to present souvenir to our chief guest, Right Honorable Prime Minister KP Sharma Oli. And I'd also like to request Dr. Vosraj Loitel to assist Dr. Mahesh Bahadur Adhikari. Thank you, gentlemen. Now I'd like to request Chairman of this inaugural session and President of NOWS, Professor C.S. Agrawal, to deliver welcome remarks. Thank you.
Good evening, Namaste. The chief guest of today's inaugural ceremony, Right Honorable Prime Minister of Nepal, Sri KP Sharma Oli, Sir. Vice President of NOWS and Chairman Scientific Committee, Dr. Mahesh Bahadur Adhikari. Organizing Secretary, Pawan Raj Chalise. President and Secretaries of other Urological Societies of Asia. Member of the Executive Committee of NOWS, past President of NOWS, invited national and international guests, faculties, delegates, media personnel, ladies and gentlemen. It gives me immense pleasure in welcoming you all to the inaugural function of 6th Annual Hybrid Conference of Nepal Association of Urological Surgeons, UROCON 2021. I feel honored to welcome our visionary and beloved Right Honorable Prime Minister of Nepal, Sri KP Oli Sharma Sir. We are humbled by your gracious presence, sir. Your presence has inspired and blessed all of us. Thank you, sir, for sparing your valuable time despite your many national commitments and busy schedule. Thank you, sir. The COVID-19 pandemic has caused a stir in our daily lives. Several planned activities like UROCON 2020 has to cancel at short notice. Healthcare professionals have suffered a disproportionate death rate from COVID-19, resulting from their direct role in patient contact and care. Societies and patients owe a great debt of gratitude to those colleagues whose lives have been lost in the service of others. This is an occasion to remember the stalwarts who built the organization and gave it a definitive direction, and a moment to remember all those who nurtured society to this glorious day. An occasion like this allows us an opportunity to take stock of what we have achieved so far and what are the future challenges for society and for our profession. Our annual conference has gained a reputation of being one of the best academic meets in the region. It will offer participants a platform to learn, share, and discuss their needs amongst the stalwarts at both national and international levels, while exploring the recent developments and controversies from the masters themselves in the field of urology. The theme of the conference is Uro-Oncology, Expanding the Horizon. The scientific committee has very thoughtfully put up a well-versed scientific program. The two-day program includes session on uro-oncology, stone disease, renal transplant, nursing session, IJU session, SARC session, to name a few. We have experts from across the field who shall be sharing their thoughts, knowledge, and opinions with the rest of us. The conference strives to impart new frontiers of knowledge in current evidence-based information and technical skills in the field of urology. Due to the challenging time caused by the COVID-19, we encourage our participants to stay safe and maintain social distancing, as a result of which this conference is conducted in a hybrid manner through the use of technology. I hope this socio-economic feast will provide you new insights into the emerging fields of urology, and you will have an exciting time in unforgettable location and carry pleasant memories with you back home. I look forward to your active participation and making this meet a memorable event. Welcome again to UROCON 2021, and I wish you a safe and comfortable stay in Kathmandu. Jai Naos, Jai Nepal. Thank you.
Thank you, Professor C.S. Agrawal, for your welcome remarks. Now, I'd like to request our chief guest, Right Honorable Prime Minister K.P. Sharma Oli, to inaugurate the UROCON 2021 by lighting the lamp. I would like to request dignitaries in the dais to accompany our chief guest, Right Honorable Prime Minister K.P. Sharma Oli. I wish this conference will turn out as a signing platform for professional and scientific exchange in the field of urology and its various avenues. Moving ahead, may I now request our chief guest, once again, Right Honorable Prime Minister K.P. Sharma Oli, to release the conference souvenir. And I'd also like to request Dr. Vosraj Luitel to assist Right Honorable Prime Minister in the launching of the conference souvenir. Thank you, Right Honorable Prime Minister K.P. Sharma Oli and Dr. Vosraj Luitel. Moving ahead, we're heading towards felicitation session. I believe if we do not honor our past, we can never excel, either as an individual or as a society. A generation which ignores its senior and does not cherish their accomplishment cannot witness a bright future. Keeping this in mind, we are felicitating some extraordinary efforts with Lifetime Achievement Award. Ladies and gentlemen, now presenting you the Lifetime Achievement Award. And this award goes to Professor Arjun Dev Bhatta for his noteworthy contribution in the field of urology. His tremendous work in the field of urology have been agents of social change and inspiration to many. His untiring efforts have always ignited a fire in every heart that dreams to serve the nation. On behalf of all of us gathered here, I'd like to take a moment to once again congratulate Professor Arjun Dev Bhatta for the Lifetime Achievement Award. May I kindly request Right Honorable Prime Minister KP Sharma Oli to present Lifetime Achievement Award to Professor Arjun Dev Bhatta. Before that, I'd like to welcome Dr. Krishna Kazi Bhumi to give a brief introduction of Professor Bhatta. Thank you.
I am extremely privileged to introduce Professor Arjun Dev Bhatta, one of the pioneer urologists of Nepal and life member of NAUS. Professor A.D. Bhatta was born on 25th of January 1946 in Palpa. He is basically from far western part of Nepal, Baitari, where he did his schooling. After finishing ISC from teaching Trichandra College, he had an opportunity to study in medicine in USSR. He did his medical graduation in 1970 from Kharkov Medical Institute, USSR, along with mastery in surgery, PhD in 1974. Then he came back to Nepal and joined government service at Janakpur Jaleshwar General Hospital. Dr. Bhatta was one and only surgeon in that region at that time and performed several kinds of surgeries which he could do himself. In 1978, he again moved to USSR and did Doctor of Science DSc in Urology. After completing DSc in Urology, he came back to Nepal and worked as surgical registrar in Bir Hospital. He became head of urology in 1985 in Bir Hospital and popularized several advanced urological operations. He also completed fellowship in renal transplantation from Bangkok in 2004. Dr. Bhatta retired as professor of urology from NAMS in 2006. Although he retired from government service 15 years back, he is still actively involved in providing urological services from Medical National Hospital, Kathmandu. Dr. A.D. Bhatta has been decorated with Mahendra Vidyabhushan Kaur in 1975 by the government of Nepal. Besides service to patients, Dr. Bhatta has passion of writing. He has authored a total of 6 books and over 150 articles in Nepalese, English, and Russian languages. He is married to Mrs. Oksana Bhatta in 1970 and is blessed with a son and a daughter. With this short introduction, I present Professor Arjun Dev Bhatta for felicitation.
I'd also like to request President of NAS, Dr. C.S. Agrawal, to offer Sol to Professor Arjun Dev Bhatta. Though his action speaks louder than words, this introduction is just a mere formality for all of us. Congratulations, Professor Arjun Dev Bhatta for Lifetime Achievement Award. The next felicitation goes to, this is the honorary NOS membership award, and this award goes to Dr. Ravindra B. Sabines. And to make a short introduction of Dr. Ravindra B. Sabines, I would like to request Dr. Vosraj Luitel in the stage. Thank you.
Good evening. It's a matter of pride and privilege to give an introduction to Professor Ravindra B. Sabines. He is a world authority in urology, not only in South Asia. So he was born in 1958, and currently he is a chairman in Department of Urology at Nadia Multibhai Patel Urology Hospital, and he is chairman in Department of Urology. not only that, he is currently the president-elect of Urological Society of India as well. He had vast teaching experience of more than 32 years, and he has produced more than 35 urologists worldwide. And he has served in different positions in the past, and he is a prolific writer also, with different books and book chapters, at least one book and 8 book chapters he has written. And he has multiple publications in national and international journals, more than 200 publications. And he is invited faculty and examiner to Europe and South Asia. And he is reviewer of the journal in different journals, and international visiting professors to Dharan BP Koirala Institute of Health Sciences, Dharan. And he was chief of the Board of Education of Urological Society of India as well. Youngsters of urology in Nepal, all of them know Professor Sabnis as guru. His relentless effort to teach youngsters for skill transfer and academic knowledge is immense. All of us think him as a role model that we want to become in the future. So with this short introduction, NAU's executive committee has decided to offer an honorary membership for his immense contribution in the field of urology, not only in India, but in Nepal and worldwide. We offer this honorary membership. Thank you very much, sir.
So we are offering honorary NOS membership award to Dr. Ravindra B. Sabins for his continuous support to strengthen NOS. His visionary ideas and zeal has always worked as an igniting factor for the growth of this organization. We also seek continuous support in the days to come. I request Right Honorable Prime Minister K.P. Sharma Oli to present this award to Dr. Bozraj Luitel on behalf of Dr. Ravindra B. Sabins. So, ladies and gentlemen, now presenting the honorary award to Dr. Ravindra B. Sabins. Dr. Bozraj Luitel receiving the award on behalf of Dr. Ravindra B. Sabins. Now, moving ahead, may I have the pleasure of inviting our Lifetime Achievement Awardee, Professor Arjun Deb Bhatta, to deliver a few words here this evening. Thank you.